ये वो करते हैं।
नहीं समझे हम।
मतलब एक सेंट्रल लाइन लगाने के लिए आएगा, पेशेंट आएगा। तो
अच्छा।
इसलिए हम सीनियर ने बोले, मतलब राहुल बॉस ने बोले कि वहाँ पे वेट करो,
वहाँ कोई लड़का
लग रहा है, बैकग्राउंड तो अच्छा लग रहा है। तुम वो दोनों में
नमामि धन्वन्तरिमादिदेवं सुरासुरैः वन्दितपादपद्मं लोके जरारुभयमृत्युनाशं दातारमीशं विविधौषधीनां शङ्खं चक्रं जलौकां दधतं मृतघटं चारुतोर्भिश्चतुर्भिः सूक्ष्मस्वच्छादिरुद्यं शुकपरिविलसन् मौलिमं भोजनेत्रं कालाम्बोदोज्ज्वलाङ्गं कटितटविलसत् चारुपीताम्बराढ्यं वन्दे धन्वन्तरिन्तं निखिलगदमिव प्रौढदावाग्निनीलम्।
नमस्कार, आप सभी को आयुष दर्पण के मंच पर आप सभी का बहुत बहुत स्वागत है। अंतर्राष्ट्रीय महिला दिवस के अवसर पर ये आज दूसरे दिन का कार्यक्रम यहाँ पर वैद्य शीतल असूदकर जी के निर्देशन में और प्रोफेसर सुभाष चंद्र वार्ष्णेय सर की चेयरमैनशिप में चल रहा है। कल का बहुत ही अच्छा प्रोग्राम रहा है, उसको फेसबुक पर भी अपलोड किया गया है। कुछ तकनीकी कारणों से वो अपलोड नहीं हो पाया, आज वो अपलोड होगा। और अभी आप इस कार्यक्रम को यूट्यूब चैनल पर आप लाइव देख रहे हैं और आप सभी आयुष दर्पण के यूट्यूब चैनल पर आप सर्च करें और ये प्रोग्राम वहाँ लाइव है। तो मैं वैद्य प्रोफेसर शीतल असूदकर जी को आप सभी को सहित सभी वैद्यों को, जो स्त्री वैद्य हैं, उन सभी को अंतर्राष्ट्रीय महिला दिवस पर बहुत बहुत शुभकामनाएं देता हूँ। और मैं आपको मैडम होस्ट बनाता हूँ। आगे का कार्यक्रम अब आप संचालित कीजिए।
थैंक यू, धन्यवाद डॉक्टर नवीन जोशी सर। आज सभी गुरुवरों को मेरा प्रणाम, मेरा नमस्कार। डॉक्टर वार्ष्णेय सर, डॉक्टर सालवी मैम, डॉक्टर DN पांडे सर, अ वेरी वार्म गुड मॉर्निंग टू ऑल ऑफ यू। और मैं आप सबके समक्ष आज इंटरनेशनल वुमेन्स डे की सबको शुभकामनाएं देती हूँ। अ वेरी हैप्पी वुमेन्स डे टू ऑल। और इस आयुष दर्पण फोरम के माध्यम से और महात्मा गांधी आयुर्वेद कॉलेज हॉस्पिटल रिसर्च सेंटर, कॉन्स्टिट्यूएंट कॉलेज ऑफ दत्ता मेघे इंस्टीट्यूट ऑफ मेडिकल साइंसेज वर्धा, इनके संयुक्त सौजन्य से हम इस पर्टिकुलर इंटरनेशनल वुमेन्स डे के सुअवसर पर एक लेडी सर्जन्स कॉन्फ्रेंस का, लेडी आयुर्वेदा सर्जन्स कॉन्फ्रेंस का आयोजन किए हैं, जो कि 7 और 8 मार्च को आयुष दर्पण फोरम के माध्यम से लाइव प्रसारित हो रहा है। ये YouTube चैनल पर आयुष दर्पण के लाइव प्रसारित हो रहा है और मैं बहुत ही हर्ष के साथ, बहुत ही आनंद के साथ यहाँ पर कहना चाहूंगी कि हमारे साथ यहाँ पर आयुर्वेद जगत से, शल्यशाला के प्रसूति, स्त्री रोग और संज्ञाहरण विभाग से करीब करीब 24 से 25 विदुषिया हमारे साथ जुड़ी हुई है। और कल हमारे साथ 7 तारीख को करीब करीब 11 से 12 लेडी सर्जन्स ने अपने अपने प्रेजेंटेशंस जो है वो इस माध्यम पर प्रस्तुत किए, जो कि हाईली अप्रिशिएटेड प्रेजेंटेशंस रहे हैं। और कल डॉक्टर वार्ष्णेय सर के चेयरपर्सनशिप में हमारे जो महिला सर्जन्स ने अपना जो काम यहाँ पर प्रदर्शित किया, प्रकट किया, उसको बहुत बहुत मान्यताएं मिली है। हमारे सभी जो रिस्पेक्टेड डिग्निटरीज हमारे साथ मौजूद है, टू द कैडर ऑफ डॉक्टर वार्ष्णेय सर, डॉक्टर डी.एन. पांडे सर और हमारी जो डॉक्टर श्रीकांत काशीकर सर यहाँ पर हमारे साथ थे, डॉक्टर कामिनी धीमान, डॉक्टर सुनीता सुमन, डॉक्टर सुमन शर्मा मैम फ्रॉम NI जयपुर, डॉक्टर पश्मीना जोशी फ्रॉम IDRA जामनगर एंड मेनी मोर अदर पर्सन्स, अदर डिग्निटरीज जो कि यहाँ पर मौजूद है। उन सबके समक्ष हमने अपना कार्य प्रस्तुत किया। तो इस साल जो इंटरनेशनल वुमेन्स डे का जो थीम है, उस थीम के साथ उजागर होते हुए, उसके साथ जागर रहते हुए, जागरूक रहते हुए हमने अपना कार्य यहाँ पर प्रस्तुत किया है, जो कि स्त्रियों का एम्पावरमेंट होना चाहिए जो हम लोग सोचते हैं। तो जेंडर इक्विटी टुवर्ड्स सस्टेनेबल टुमारो इज द थीम ऑफ इंटरनेशनल वुमेन्स डे दिस ईयर। सो मेरे ख्याल से यहाँ पर जेंडर इक्विटी का एक बहुत ही सशक्त उदाहरण हम इस मंच के माध्यम से प्रस्तुत कर रहे हैं कि स्त्रियों का जो वर्क है हमारे आयुर्वेदा सर्जन्स का, उसको हमारे यहाँ पर प्रस्तुत करने का हमें मौका मिला, उसकी यूनिकनेस को हाईलाइट करने का हमें मौका मिला है और उसको हमने पूर्णतः इस्तेमाल करते हुए, इस मौके का फायदा उठाते हुए हमने अपना कार्य यहाँ पर प्रस्तुत किया। इसके लिए मैं आप सबकी बहुत बहुत आभारी हूँ और आप सबको मैं बहुत बहुत शुभकामनाएं देती हूँ कि हमें आपने यह मौका दिया। और मुझे कल के प्रोग्राम से एक बहुत ही सुंदर कोट को यहाँ पर प्रस्तुत करते हुए बहुत ही खुशी महसूस हो रही है कि डॉक्टर काशीकर सर हैड राइटली सेड कि this is one of the diamond presentations in the fraternity of Ayurveda, as the diamond glitters when the light falls on each of the facets of the diamond, and it will get almost completed when all the other presentations which are scheduled tomorrow will be completed. Each facet of the diamond will be enlightened so as to complete the diamond presentation, diamond seminar of the Ayurveda fraternity. So ये मुझे बहुत ही भाया सर ने जो कल हमारे लिए यहाँ पर उद्धृत किए उनके मनोगत, और डॉक्टर वार्ष्णेय सर ने तो हम लोगों को इतना यहाँ पर एक रिस्पेक्टेबल फोरम पे जो कुछ प्रेजेंटेशंस प्रस्तुत हुए, सर ने जो मान्यता दी है कि बहुत एक जो प्रेजेंटेशन था यहाँ पर वो अपने आप में परिपूर्ण था। तो इसके लिए हम आपके सर बहुत बहुत शुक्रगुजार है कि आप हमारे साथ थ्रू आउट द डे yesterday you were present, and I am sure that you will be present over here today also, and you will be analyzing, you will be critically giving the appraisal to our presentations, and you will be summing up the program at the end in the valedictory session, sir. Thank you so much, sir, for being here with us. And Dr. D.N. Pandey, sir, you were present here since morning till the end of the program yesterday. And sir, we are very much happy to say that we are with you, sir. We are deeply in support of you. Your mission Sangyaharan PG restoration program, and all the lady surgeons want the Sangyaharan PG restored to the Ayurveda fraternity. So sir, we are with you and we are very much thankful that you are with us today. You are also one of the renowned guest speakers and one of the guest of honors today in our program. Thank you so much, sir. And now that all the dignitaries have arrived in the meeting, I would like to announce you. I would like to officially declare that the program, which was already inaugurated yesterday in the morning, which is going to be scheduled, which is planned to be scheduled on 7th and 8th of March 2022, which was virtually inaugurated yesterday. Today is the day 2 of the International Women's Day celebrations program on Ayush Darpan, and on behalf of Ayush Darpan and Mahatma Gandhi Ayurveda College, we are here. I am here to carry forward the program today. So in the first session of the program yesterday, we had paid condolences to late Dr. Premvati Tiwari ji ma'am, and everybody had offered tributes to her. She is the Iron Lady of Ayurveda Shalya Tantra, and she deserves the warm condolences which we have been offering her since last day, since yesterday, and today also we are remembering her in every session. So I would like now to officially announce that our today's program is going to start today, is going to open today with keynote address by one of our renowned Ayurveda surgeons in the field of Ayurveda Shalakya Tantra, that is ENT department, Dr. Sangeeta Salvi ma'am. So I welcome you ma'am on the very august forum of Ayush Darpan Foundation and Mahatma Gandhi Ayurveda College, and I invite you ma'am for your keynote address today. The role of the importance of Char Karma in Karna Nasa and Mukhrogas, that is Shalakya Tantra. So ma'am needs no introduction. The madam आपका नाम ही काफी है आयुर्वेद जगत के लिए. So I am very glad to have you with us ma'am, and I am so happy for your presence throughout yesterday and throughout today also. You will be with us in the valedictory. So I welcome you ma'am. Thank you so much.
Thank you. Thank you so much. Could you please allow me?
मैम को ask कर. No, हाँ Salvi, yes, more co-host बना दो, more करके co-host बना. हाँ. Yes ma'am, now you can share ma'am.
Yeah. Ma'am, is it visible?
Yes ma'am, it is visible. अब मैं जब next मेरा जो presentation रहेगा.
Just give me a moment, ma'am.
Yes ma'am.
Yeah. Is that fine?
Yes, this is okay ma'am. Just take it on presentation mode ma'am.
Yes, I have taken it. Is it visible on presentation?
It's visible ma'am.
Yeah. Good morning and a very warm welcome to all the presenters today who are attending this workshop or a seminar, and congratulations to Sheetal ma'am for organizing such a wonderful event. As I said yesterday, as what we couldn't do is she's doing it. So welcome to all of you, and let me present a few things which I feel I know I'm going to go a bit fast because of the time constraint, but I'll try to make it within 20 minutes. So ma'am, please allow me to start the presentation.
Yes ma'am, please go ahead.
Pranam
to your own time ma'am.
Yes ma'am. With my pranam to my guru, Dr. Puranik sir, I start this presentation. And before the presentation, let me wish all of you a very happy Women's Day. I have tried to maintain the colors, which are the color codes for the International Women's Day for this year. That is green, purple and white. So in my slides, I have changed all my colors and I've tried to make this presentation a colorful one. So wish all of you a very, very happy International Women's Day. Now, Char Karma is a procedure or is a science which has been explained in Sushruta, and it is second to the Shastra Karma. So people who are contraindicated for surgeries or people who cannot undergo a certain surgery, Char Karma is the procedure which is always advised. Maybe it is still to be highlighted, and I will try to highlight a few things, and I will try to initiate the juniors or the budding Shalakis to start using these procedures in their daily practice. And believe me, after seeing this procedure, everyone will be, confident that you don't need a post-graduation in Shalakya Tantra to do all these procedures. You just need to be a BMS and you need to know how to do these procedures. So I know because all of them are not from Shalakya who are listening to this presentation. So I have tried to, initiate this presentation for all the faculties of Ayurveda. Now, as we know, after the Shastra Karma, they have been explained Ashtavidha Shastra Karmas. In Ashtavidha Shastra Karmas, Anushastras, and Anushastras have been explained in details by Sushruta. Sushruta has dedicated a total separate chapter on Ksharakalpana. So Sushrut Sutrasthan 11 is a totally dedicated chapter for Ksharakharma. I'll go a bit fast because the main slides are coming behind. While explaining the Anushastras, Sushruta has explained 15 types of Anushastras. And I've tried to bring pictures of all these 15 types, out of which Anguli Shastra, which has been explained in the last. These are the types of Anushastras which we can make minor surgical procedures, or they are called as parasurgical procedures. Now, why Anushastras and why Ksharakharma? While explaining Anushastras, they have been explained in three parts. One is Rakta Moksha, one is Dahan Karma, and the third is Kshar. And Kshar has been explained as the most important of the Anushastra Karmas. So, while explaining the Anushastras, what are the things which are going to get highlighted while we are doing a Kshar Karma? Now, Kshar Karma, or the Kshar which we use, has a certain properties which can be used as a surgical procedure also. The main physiology of the Kshar Karma is that it separates the vitiated doshas. This is a very important action of a Kshar. The second important action of a Kshar is it cuts the unhealthy and the excessive tissue. So where Shastra Karma cannot be done, you can go for a Kshar Karma procedure. Sushruta explains that again, Kshar removes the vitiated doshas and purifies the wound. So along with a Lekhan Karma, it also can be used as a wound healing procedure, and we have got some examples where we have used Kshar for a better wound healing. So these are the properties of Kshar. Now, the first important property is it is a Tridoshagna because it is made from various plants, various chemicals. And hence it can be used where there is a Tridosha vitiation in our body. It is white in color, and it should be white in color. It is a very important property, that is, it is an Agneya property. So because of that Agneya property, it can be used as a cauterizing agent. The Vilayan property of the Kshar again is a very useful property because it reduces the inflammation and it helps for the Vrana to have a better wound healing. So it dries up the secretions which are there in an infected wound.
Ma'am.
Yes, ma'am.
Just a minute. Your slides are not moving, ma'am.
They are moving in front of me.
No, here only thank you for the patient listening slide is there, ma'am.
Okay, I'll just see. I'll just stop sharing and start sharing again.
Okay, madam.
Ma'am, now is it visible?
Yes, ma'am. Yes.
From the first one?
Yes.
Now is it visible, ma'am?
Ma'am. Yes, it is.
Yeah. Sorry for the interruption. When we study of the Kshar, which I experienced in last some few years, and to be very true, I have not been practicing Kshar or Karma Chikitsa since my beginning, but since last say a decade, so I'm practicing Kshara Karma, and to my experience, I have used a Pratisaranya Kshar more as compared to a Paniya Kshar. Now, Pratisaranya Kshar, as we all know, it is of three types depending upon its activity. It is Mrudu, Madhya, and Tikshna. Now, there are a few conditions where Kshar Karma should be avoided. Now, which are the conditions? We should be very careful because we should be able to know where Kshar Karma should not be used. Small children, because they are not, they are very inquisitive. We cannot make them sit in a stable position. And if you try to apply Kshar and the child moves, the Kshar can be applied to the normal tissue also. So which can cause a chemical burn to the other parts of the body. Older people, the skin becomes dry. There is a lot of fibrosis in the skin. And if you try to put Kshar over there, it might destroy the underlying parts of the skin. Anxious patients is a very important contraindication which we see in our daily practice. If you know patient is anxious and he will not cooperate, please don't go for it because you might land up in a problem. Pregnancy, it's because of the hormonal changes. If at all there is a wound or a chemical cautery done because of the Char, because of the hormonal changes, a wound healing is delayed. So usually pregnancy, you should avoid Char Karma. Rakta Pitta, again, because the Char is Tikshna, here Char Kalpana should be avoided as far as possible. Prameha, if we take it as an increased blood sugar level, if the sugar level is increased, you should avoid applying Char because the wound healing is delayed. The oxygen carrying capacity of a diabetic wound is delayed and hence a wound healing will get delayed. So these are the particular systemic conditions where Char should be avoided. Char should be avoided in certain places like Marma, Sira, Snayu because we should not land up in a complication. Another important thing which Sushruta has mentioned that after a Shodhana Chikitsa, Char Karma should always be done after a Sarvadehik Shodhan. If after a Shodhan Chikitsa, the patient is complaining of Ajirna, that means Agni Mandya is there, you should not go for a Char application because the expected results will not be there. Now, where can we apply Char in Chalakya Tantra? Being an ENT facility or my specialization is ENT.
Madam, your slides are not moving right now again.
I
Change
don't know why.
Change कीजिए madam.
Abhi?
No ma'am.
She have put in slide share. Slideshow.
Slideshow. हाँ, yes ma'am. You can go for slideshow.
It is in slideshow, ma'am.
Now there is some problem.
नाही होते म्हणा. हा आता येते.
मम्मी असंच ठेवताय?
नाही, काम करा ना तुम्ही, फुल स्क्रीन घ्या आणि जे ऍज यू स्पीक देन चेंज द स्लाइड्स.
आय एम डूइंग दॅट.
खाली एक कप आहे बघा राईट कॉर्नरला. देयर इज वन कप. त्या शेजारी
तिथे स्टॉप शेअर आलाय.
नाही ते नाही. इकडे त्याच्या 41% जिथे लिहिलंय ना त्याच्या शेजारी बघा.
शेजारी. राईट सर.
कुठे सर मला नाही कळत आहे.
हे जे खाली
मॅडम तिथे खाली 41% लिहिलंय पहा तुमच्या तिथे राईट कॉर्नरला खाली स्क्रीनच्या खाली राईट साइडला
एक मायनसचं साइन आहे बघा. त्याच्या बाजूला 41% लिहिलंय खाली, अगदी खाली मॅडम.
इथे मला नाही दिसत आहे. स्लाइड मूव नाही होते मॅडम.
नाही मूव नाही होत मॅडम.
एकदा तुम्ही स्टॉप शेअर करा मॅडम आणि पुन्हा एकदा शेअर करा.
स्टॉप केलाय. सॉरी आय एम रिअली सॉरी.
नो मॅम, प्लीज डोंट बी सॉरी. हे टेक्निकल इश्यूज येतात. नो वरीज.
ओके, आता खाली जा. 41% दिसतंय तुम्हाला?
हो.
हा, त्याच्या शेजारी कप आहे बघा एक. अदर साइड. हा, तो शेअर द्या.
येत आहे सर?
नाही ना.
माझ्या ह्याच्यात येत आहे सर.
बरं ठीक आहे. ऍज यू स्पीक एक हे करत जा. स्लाइड कर्सरनी पुढे नेत जा. नाही तुम्ही पर्सेंटेज वाढवलं. पर्सेंटेज नका वाढव.
आता येत आहे सर?
हा, आता ठीक आहे.
ओके, मी ट्राय करते.
इट्स ओके नाउ.
Okay. Sorry for the inconvenience. The most important aspects of Char is there are the two important words which Charaka has explained. Now, Charaka was supposed to be a physician, and though being a physician, he has explained the properties of Char. He says Ksharanat. Now, when we say Ksharanat, it means that it removes the vitiated doshas. This is a very important thing which is there when we are expecting a good wound healing. Second word is Shatana. Shatana means it only removes the unhealthy tissue. So wherever there is an unhealthy tissue, Char Karma is going to be important.
मेरे पास 500 नगद है.
Sir, are the slides moving?
300 रुपए छोटे हैं.
Yes ma'am, now it's moving.
Okay. So we have gone through these properties, I will just go fast.
पहले सोच रहे थे लेकिन फिर भूल गए.
These were the contraindications, and these are the indications which we follow while practicing Char Karma in Shalakya Tantra. I have got pictures of many patients, and I'll give you a presentation where we have done Char application in various conditions. Now, this is a very important condition called as a earwort. As you all know, it is a viral infection, and there is a warty growth. This is a warty growth at the external auditory canal. This is a growth on the auricle. This picture I have taken it from the internet. This is not a picture which I have taken of a patient. This is the actual patient which we have worked. We have removed this wart from the external auditory canal with the help of a granulation forceps, and we have removed it with the help of a stab knife. Now, after using a stab knife and after removing this wart, we can apply a Char at the base so that there is no recurrence, because warts are known to recur. So this is an integrative approach. Remove it by a surgical procedure, apply a Char so that there is a non-recurrence. Then these are the two very common conditions which we get to see in the OPD patients. This is what you see is a black, this is an impacted wax, and because of the impaction of wax, there has been an inflammatory granuloma. This is another condition where you get granulomas. This is a mucor fungal infection of the external auditory canal. These two conditions, if you remove the causative factor and if you try to put a Char over here, we get better results and the inflammatory changes reduce. Now, this is a very common condition which we see in our day-to-day practice. A lady has tried to pick her nose, pick her ear in so many places, and she has got an allergic reaction, and there is a granuloma over here. Now, if the patient comes in an early phase where the granulation has a small pedicle, a Char Karma is going to be the right line of treatment. Instead of going for an incision and removing it, there are chances that this might turn up into a keloid. And as we all know, keloids are known to recur. So a patient you catch up in an early phase, you can apply Char. The Char which we are applying in our OPD procedure is Apamarga Char. Now, this is a picture which I have taken from the surgery department. The Shalya Tantra people have applied a Char Sutra. See at the keloid. The keloid has a bigger base. Now, when there is a bigger base, and if you go for a Char Sutra application, you get a better result. So here is a big keloid. The Char Sutra is tied at the base of the keloid, and as the Char Sutra goes on cutting these edges, the keloid is thrown off. So this is the Char Sutra which has been used by the Shalya Tantra department. This was a very challenging case for me, and I had consulted this case with Kashikar sir also. This patient was referred by an ENT surgeon, and she had already been operated twice for a keloid. Once it was surgically removed, and the second Char Sutra was applied. Now, because of the Char Sutra, the base of the keloid was very big. And when we operate such keloids, we have to remove some part of the normal part of the auricle. So being a young patient, being a young female, I had a challenge that I should keep this ear shape in a proper shape. So the keloid was removed. The skin grafting was done. This is the first skin grafting which I've done in my life. I have seen Kashikar sir doing skin grafting, so I learned a few things from him. And after a few days, so this is initially the keloid, this was looking quite ugly, and I was quite nervous whether I would be able to save the patient's ear. After the 13th day, there was a little bit of necrosis, but the other part of the wound was healthy. There was a granulation tissue here. There was a granulation tissue here. So I applied Apamarga Char here. And to my surprise, I applied another drug which gave me wonders, is honey application. I used honey, I dipped it in a Johnson bud, and I applied it on the wound where the stitches were still intact. Now, after honey application, I could see the change in the color of the wound. So this was the initial keloid. This was the dirty picture which I got before the honey application. This was the honey application, and this is, I removed the stitches almost after 1 month. And see, it is a good wound healing. So honey has given me a very good result, and I have taken it as a Char. I have a small video, but I will not play. It is only a video of how honey should be applied on the wound. This is another common condition where we can apply Apamarga Char. I use more of Apamarga Char in my OPD procedures. If it is a polyp from the external auditory canal, it is nothing but an irritation of the skin which lands up in a polyp formation. Here you can go for an Apamargakshar Pratisaran along with internal medicines. I will not claim that only Apamargakshar works. We have to give anti-inflammatory medicines where the inflammation should reduce. Once the inflammation reduces, the Kshar results will be more promising. This again is a common condition which we see in our OPD practices. This is a preauricular sinus. It should not be touched unless it is infected. So here is a case of an infected preauricular sinus. This was a young patient who came last year in our OPD and he had an infected preauricular sinus. We had to drain it, drainage and incision was done. There were 2 openings of this preauricular sinus. Here we have applied Apamargakshar. And after a few days, the wound is almost looking normal. This took a little more days to heal up. After Apamargakshar also, in the later stages, we have applied simple honey because honey is used in Sadhyavarnas and this is a Sadhyavarna because we have given an incision. This patient, a 6-year-old patient who came with a mastoid abscess. Now, mastoid abscess is a very rare condition nowadays. And I operated a mastoid abscess after many years. So after we incised this mastoid abscess, this was the granulation tissue which formed in the post-auricular scar region. Now after the mastoid abscess is drained, we have to go for a mastoidectomy. But we have to wait for this wound to heal. So before we could go for a mastoidectomy, we applied Apamargakshar here. So this is after the application of Apamargakshar. Being a small child, we needed a good wound healing. And after the mastoidectomy, the wound has healed up in a very nice way. So if you have an integrated approach, you use both the sciences together at the right time with the right choice, you get best results. This is a very, very common condition which day-to-day practice we are seeing. This is an inferior turbinate hypertrophy and this is a deviated nasal septum. It is always that where the deviation is there, opposite side there is a turbinate hypertrophy. Now both these conditions, if they are before the surgical domain, we can apply Apamargakshar here. And this was being my PhD thesis. We have tried Apamargakshar application in more than 300 patients. So we have got excellent results. If the patient is not ready for the surgery or if the patient is still not in the domain of a surgical procedure, you can very well apply a Kshar over here and you can apply a Kshar on the mild deviation also. The patient gets excellent results. As I said, we have tried for more than 300 cases and we have got excellent results where we have applied Apamargakshar. Apamargakshar can be tried in 3 types of nasal conditions. One is a C-shaped deviation. One is a thickening of the septum where the septum is in the center but the mucoperichondrial flaps are thickened. Here if you apply Kshar, there will be fibrosis and this mucoperichondrial flap will come in the center. Nasal polyps, I have a very nice CT scan report in the next slides. We had one patient who was studied with nasal polyps and he being a VIP patient, he refused to go for a surgical procedure. Now, it was again a challenging case for me because if I see such a patient, surgery is only the option. But taking up this challenge, we applied Apamargakshar in this patient for minimum period of 1 or 2 years. Patient used to come very sincerely. We used to apply Kshar on the polyps for 40 to 50 seconds and the patient came once a week for minimum 2 years. Now, I'll just go to the next slide because I have a report of a scan which shows how the Apamargakshar application has helped. Now, this is an Apamargakshar procedure which is done in the inferior turbinate, which is hypertrophied. Here is the nasal septum of the same patient. So when we are applying Kshar, we are applying it 3 places. One is the lateral wall. Second is the medial wall, which is called as the nasal septum. And third is the floor of the nasal cavity. So these are the 3 places where Apamargakshar is applied. We apply once a week for 40 to 50 seconds. And to my experience, I have not used any nasal douche after the application because Apamargakshar being a Soumya Kshar, the irritation levels are not very high, but the results are very good. Now, this is a small SOP of how you should apply the Apamarga Char. Either you can use a probe or you can use a earbud. If you want a good char to come on the earbud, you can dip it in a drop of distilled water. Once the cotton is a bit wet, the char will come on the cotton and you can apply it. Now you have to keep it on that position for 50 seconds. 50 matra is explained in the granthas. So 50 matra comes to 45 seconds. I have used on the nasal cavity, I have used it for 45 seconds. Now, how does it work? One action is a chemical cauterizing agent. Because of its chemical cauterizing agent, there is a shrinkage of the hypertrophic tissue. The second, it penetrates the boginess. As we said, it penetrates the vitiated doshas. Vitiated doshas is nothing but a collection of fluid under the skin or the mucosal layer, and that is what causes a boginess. So this cauterizing agent will penetrate into the boginess. It will dry the secretions and it will cause something which is called as necrosis. So necrosis of the hypertrophic tissue is the main mode of action which reduces the inflammatory changes and reduces the chances of a recurrence. As I said, it absorbs the collected fluid, it causes shrinkage, and the action is more on a Mounce dhatu. So wherever there is a Mounce dhatu, the inferior turbinate is nothing but a Mounce dhatu. So if you apply it on this, there is going to be a shrinkage. Now these were the nasal polyps, which, as I mentioned earlier, there was a patient who was studied with nasal polyps, and we tried to apply Apamarga Char on this patient again 50 to 60 seconds once a week, and we had to repeat it after a week. We tried in a patient for more than a year. This is the reference which I took where Kanchan Karma Chikitsa is explained, where 4 types of treatment is explained. One is Aushadhi Chikitsa, Kshara Chikitsa, Agni Chikitsa, and Shastrakarma. So if the Bheshaja Chikitsa or the conservative line is not useful, Kshar Chikitsa is going to be useful. So this is a patient who had multiple polyps. There was a mucosal thickening in all the sinuses. And the most important fact which I would like to highlight is the osteometal complex on either side appear blocked. Now this is a very important pathology where the osteometal complex has to be open in a normal person. After 1 year of application of Apamarga Char, this is the result what we got after we repeated the scan. Unfortunately, patient went to another scan center, which ideally should be done in the same scan center. But to my surprise, this was a very important finding which we got is bilateral osteometal units and infundibuli appear normal. Now, once this osteometal complex is open, the recurrence of the nasal polyps is reduced. So this was a very good result which I got in nasal polyps. What else can be used for treating nasal polyps? Very important is this is the Snuhi Kshir, and Snuhi Kshir can be mixed with Haridra. Both of them are Lekhana, and this Lekhana property will reduce the size of the polyps. Though I have not tried in much patients, I have tried in only one patient with Snuhi Kshar and Haridra. I preferred to use Apamarga Kshar because being a mild Kshar, the corrosiveness of the Kshar is less. Now this was a patient who had an inverted papilloma. Inverted papilloma again is a case which goes on recurring. So once this papilloma was removed, again let me mention that this papilloma was removed surgically by using a stab knife. We removed it from the base and then we applied Apamarga Char. If you feel that this is looking something dirty, which is not having a healthy look, always go for a biopsy. We did the biopsy and the biopsy report was it was an inverted papilloma of the nasal septum. So it has come from the septum and it has come down into the nasal cavity. Now, after applying Apamarga Char for around about 6 sittings, we found that this patient has not developed any recurrence. So recurrence is a very important thing in a few conditions of Shalakya, where you need to have a good line of treatment where the patient will not get operated or parasurgically done various times, because then patient will not come to you if there is a recurrence. This is a very common finding. This is a nasal wart. Now these pictures are from the internet. The next pictures are from our OPD patients. This is what we have used. Again, Apamargakshar. This is a patient who has been treated some 15 days ago. She came with multiple nasal warts on the nasal surface. One was there on the septum. This we started, initially we gave them some modern line of treatment where the congestion was reduced, and after that we have applied Apamargakshar. So now the size of the warts has definitely reduced. This was the wart which was there on this side of the nose, and now the size, see the circumference of this wart, now it has come down to this size. This is the endoscopic view of this nasal wart, and this is the nasal application of Apamargakshar. After Apamargakshar, the wart size has reduced. So patient may not, otherwise patient has to go for a surgical line of treatment, or they give some laser treatment, or they cut it, and after incising it, there is a recurrence. So to avoid recurrence, we can use this Char Karma Chikitsa very effectively. A very common thing which is not seen in females, but in males also, because nowadays males are also picking their noses over here. And initially it used to be called as a keloid. Now it is called as an irritation bump. So if you prick your nose and the cartilage is pricked through and through, you're going to get a bump. Now after this bump, you have to first give some anti-inflammatory and then apply Apamargakshar here. Definitely the size of this bump reduces. Now the patient wants to look beautiful, but because of this bump, the nose has become an ugly looking nose. So Apamargakshar can be applied here to get better results. This was again a challenging case for me. 18-year young child who wanted to have a nice nose. He fell on his nose a few years ago and he had a very bad shape looking nose. Now this is before surgery. This is after surgery where this broadness has reduced. Definitely it has reduced, but being a very aggressive surgery which we had to do a septorhinoplasty where the deviation septum was also removed and these nasal bones were fractured and kept in place. Now after doing this aggressive line of treatment, the patient develops a very common complication called as Synechia. That is because these two flaps come very close to each other, they start joining and there is something which is called as an adhesion. Here we applied Apamargakshar to this patient and within 3 to 4 applications, the total Synechia had disappeared. So this is again a very important place where you can go for an Apamargakshar Pratisaran. A very common condition which is nowadays seen is Vasomotor Rhinitis. A very common thing where patients develop an inflammatory mucosa in the nasal cavity, both in the septum as well as the turbinate. Now here is a challenging case because the size of the turbinate increases and it touches the nasal septum. So patient cannot breathe through the nasal cavity. Patient starts breathing through the oral cavity. Now if here we are applying Apamargakshar, we have to be patient. We have to make the patient also take the treatment very patiently because it takes time. But once the inflammation reduces, once the hypertrophy reduces, the patient gets excellent results. So you can apply Apamargakshar. Along with Apamargakshar, what we use is we either use Apamargakshar Tel Nasya or Yashti Madhugruta Nasya. Both of them have Lekhan properties and they will help to reduce the inflammatory changes in the nasal cavity. Very common thing which people use nowadays, they have a nasal blockage, they go over the counter, they take some nasal decongestant drops and they start using them. So after a long period of getting used to these drops, there is a complication called as rhinitis medicamentosa. That is overusage of decongestant nasal drops. Now, because of this overusage, the action of the decongestion totally goes away. And even if you patients tell me that sometimes they need one whole bottle in a day. So that is a big amount of nasal decongestants they are using. Now here complication is that the changes which are here are totally irreversible changes. Again, this is a challenging case where we can apply Apamargakshar. The only reason is it takes time because of the pathological changes. Being irreversible changes, we have to wait for a longer time we have to do the Char application for more attempts because the size of the inflamed mucosa takes time. And once it starts shrinking, then you have a better result. Because in the initial days, in these cases, there used to be a surgery and it used to land up in a complication called as an empty nose syndrome. And it used to land up in atrophic rhinitis. So to avoid all these surgical complications, I think Char application should be the first line of action before you go for a surgical intervention. Another very common condition, a retention cyst. Usually it is seen on the lower lip because this is the lip where you bite, and once it is bitten, your teeth all the time go and sit there and it causes a granulation tissue. The best results which I have seen for this without excising it is simple Sendhava and Madhu. So Sendhava and Madhu, instead of keeping it there, what treatment is expected is Pratisaran. Now Pratisaran here means Gharshana. So you mix Madhu and Sendhava in equal quantities and just rub it on the retention cyst. Like magical results, we see the reduction in the size. But be careful, if this cyst has become hard, there are chances where you have to remove it and then you can apply Sendhava and Madhu to again avoid a recurrence because these retention cysts are known to recur. Another common condition where we are applying Char or where we are doing some chikitsa which is called as a Pidana chikitsa or Pidana Karma. This condition is called as Gala Shundika in our granthas, which we call it as an elongated uvula. Now, elongated uvula once causes a lot of irritation in the throat. There is a surgical procedure which has been explained by Sushruta, that is Gala Shundika Shastra Karma. Now, before going for a Shastra Karma, if you can avoid the Shastra Karma, because this part of the oral cavity is very difficult, patient has to sit with an open mouth. GA is not needed, but local anesthesia is difficult. And with an open mouth, the patient sees the instruments going inside. He feels the instruments going inside. So it is an uncomfortable feel for the patient. A very common drug which can be used, which we have been using for years together, and I've learned this from Dr. Yago Joshi sir, who taught me to apply Bhallatak Tel Pratisaran on this Galashurika. People who are sensitive to Bhallataka can go for a Haridra Pratisaran, or we take it on a finger or on a spatula and we press it on the elongated uvula. So once that Haridra or Bhallatak Tel comes in contact with this mucosal edema, there is a regression of the mucosal edema and the uvula goes back to its normal size. So as I told you, you don't need a post-graduation in Shalakya Tantra to do all these simple procedures. Another challenging condition which we get is adult tonsillitis. Now, adult patients, when they have hypertrophic tonsils, usually an ENT surgeon does not go for a surgical procedure. Why? There is a lot of necrosis, there is a lot of fibrosis, and removing an adult tonsil is like calling bad luck for you because there is an excessive bleeding. So we have tried, I think in last 2 years, 10 patients where we have applied Apamargak Char. And along with Apamargak Char, we ask the patient to do gargles with Madhu and equal amount of Madhu and water. So Madhu Jala Gandush and Apamargak Char, both of them are Char. So both of them can be used as a chemical cauterizing agent so that they will reduce the size and we can avoid a surgical procedure in an hypertrophic tonsils, preferably in adults. We have tried one patient with a lingual tonsillitis, the most difficult thing to treat. When an ENT surgeon sees a patient of lingual tonsillitis, he really feels very unlucky because patient is not getting result of anything. This is a point where no surgeon would like to touch because this is a very difficult place to operate. So if you apply Apamargak Char, the only thing is we have to apply it for more than 1 minute. What we have tried in 2 patients is we have kept Apamargak Char here for a period of 1.5 minutes. So that is 90 seconds we have tried, and we have called the patient after every 3 days. Now after every 3 days, the size reduces and the patient gets a relief in the complaints. This was my MD thesis where a tonsillectomy has been done, and what we apply here is Madhu application. So we take Madhu in the operation theater, we take it in our finger and we apply it in the post-operative fossa of the tonsillectomy wound. Results are excellent. The Ropana Chikitsa, the Ropan qualities of the Madhu are very, very important here. And the faster the recovery, the faster the patient comes back to a normal diet. So this also can be tried in your OPD, where a patient comes after tonsillectomy. Just ask him to do gargles with honey. That is the best Char which you can advise. Now, what could be the advantages? After seeing all these, simple cases, I have not taken any complicated cases because I know all of them are not from the Shalakya department. So these are the things where you can go for a Char application. The cost effective is really very less. A big bottle of 50 grams of Char, you can use it for a period of 1 or 2 years. So you need not keep on spending on that Char because it's very easily available and it is very cheap. The most important thing is you don't need anesthesia. Only in a few cases where you have to incise and then apply Char, only in such cases you need a local anesthesia. The best thing of Char application is the recurrence rate is very, very low. Whatever patients we have seen that the recurrence chances have reduced. The post-operative pain is less. There is no need of an admission. That is the first thing patient will ask. Do we need to get hospitalized? No. That is the most important thing what the patient feels. Instrumentation is minimum. You hardly need one probe. You hardly need one tongue depressor, and you need a Johnson butt. So these are the minimum things which are required for a Char application. There are a few precautions which you should always follow. Always know your limitations. First, see that the Char is freshly prepared. If the Char is not showing you the expected results, please throw that Char away because it must be an old Char. Go for a freshly prepared Char. Excessive use of Char is also contraindicated. Once you start realizing that now the hypertrophy has reduced and you might invade the normal tissue, please stop going for the Char application. If the Char does not give you results which you expect, please discontinue and go for a surgical thing. Please know your limitations. Everywhere you cannot use a Char. Where surgery is needed, there you have to go for a surgical procedure. Depending upon the site and pathology, you have to decide which type of Char you can use. So Apamarga Char, Snuhi Char, Haridra, honey, these are the various types of simple Chars which you can use even in your daily OPD basis. If you feel that the growth is malignant, please don't go for a Char application. Go for a histopathological evaluation. If the patient is malignant, please stop thinking of a Char. Only after a surgical procedure, if you feel that the wound needs a cauterization, there you can go for a Char application. Marma Pradesh also should be avoided because that would give you unwanted complications which are more difficult to treat. Now, where are the scope? Regarding the scope, as I said, there are various conditions where you can go for a Pratisaranya scar. You have to document each and every case. I really thank Kashikar sir for guiding me because he was the only one who used to keep on telling me, madam, documentation. Initially, we have not documented our cases. If I would have started documentation when I started practice, I would have got loads of papers which I could present. But that's my bad luck. At least now we have learned, so we are documenting all the cases so that you can present these conditions, you can present these cases in front of modern people and you can convince them that what you are doing is not wrong. Char Kalpana definitely has a very good scope. Where limitations are there, you can go for a Char Karma. Patients who have systemic ailments and who are contraindicated for a general anesthesia or a local anesthesia, you can go for a Char application and reduce the possibility of a surgical intervention. Now, what message we can take from this Char application? I know it's a small topic. I have tried to explode it. I have cut most of my slides. I have tried to make the presentation as short as possible. But one thing I would say, after a practice of 26 years, the granthas which are explained, what we see is like this. But the meaning of the granthas is deep down. So when we are reading the granthas, when we are learning the granthas, we have to think 100 or more than 100 times what could be the meaning behind it, because the sutras are only 2 sentences. The meaning behind them is really very, very big. So we have to think deep. We have to explore the basic concepts. We have to go ahead. Just exploring is not enough. We have to take them and go ahead. We have to prove ourselves to the present era, because our acharyas are watching us. When we take admission for BMS, we know that our acharyas are going to see what we are doing, because they are expecting a lot from us, and this is what we should try to explore and try to bring out from the granthas which we are reading. One request I would do for the budding chalakis or the budding surgeons, please try to come up with as many as patents as we can get. Now Haridra, somebody else has taken the patent and gone ahead. We are having our basic drugs with excellent results, but we are not claiming the patents. So if we have documentation of such cases, the patent, we can get them easily. This slide I purposely took an image where all females are there, being an International Women's Day. I thought this would be a better picture for today, but I would always try to advise the budding people. One very important thing, do not limit your challenges, because if you start limiting your challenges, we do not have permission, we are not taught, we cannot do. These are the limitations which we are putting on ourselves. We have to accept those challenges. We have to go beyond the challenges, cross our limitations, and definitely success is going to be at your doorstep. So all the budding surgeons, please come up with a very strong determination that you are going to be a successful surgeon. Do a lot of execution. Not only determination is not going to help, you have to do a lot of hard work. You have to be very ambitious, and you have to have a very good vision. So if you are having a good vision, all these steps are going to be very simple for you. So I request to all the budding surgeons, please go ahead, and we have to make a different world of Ayurveda. I like this picture, that's why I take it in every of my presentation. It is for BMS people, saying that lotus is the only flower which teaches us where we reach is important, not where we come from. We are coming from a background where we missed our MBBS admissions, but we have tried to express ourselves, we have tried to prove ourselves, and we are no less than the others. So let us be like this lotus. Let us prove that we have reached heights, not from where we come from. So I hope I have managed the time, because I cut a lot of my slides because I didn't want to make it a boring presentation. So I hope, Sheetal madam, I have done my job. Lastly, I would like to say that anesthesia department has to come again, because that is the only thing which is going to save us. A surgeon without an anesthetist is of no use, and we are not going to rely upon the modern surgeons. We want our people to come up as anesthesiologists and take our surgical branches ahead. So thank you very much for a patient listening, and I thank all the people who have been listening to this presentation. I hope it has been an inspiration to all of you. So thank you very much, Sheetal madam.
Thank you so much, ma'am, for such a wonderful presentation by covering all the clinical aspects, the application part of Char Karma in Shalakya Tantra, Karna, Nasa, and Mukhroga. You have a vast experience in the field of Shalakya Tantra, ma'am, and you are fortunate enough that you have got so many patients, so much variety of patients, and you are able to have the implications of Shara Sutra. You are able to project the scope of Shara Karma in Shalakya Tantra, in the general practice, in the IPD patients, in the routine patients of OPD, how we can apply these things. So I guess the students are able to grasp the things what you have tried your best, ma'am, that to give to the budding surgeons or budding students. But I am a great fan of yours, ma'am, and I can't stop saying always, now and always, that you are an inspiration to many of our surgeons like me. And the way you talk, the controlled presentation, the efforts, the most of the efforts you take, but the least you say in your words, but it is projected in your slides, ma'am. Every aspect of your presentation, I am a deep fan of yours. So thank you so much for being associated with us. And I guess the students would imitate, if they try to imitate you even, they will be having so much growth in their careers and lives and many things. So thank you so much, ma'am, for such a wonderful presentation. Thank you so much.
Thank you so much.
So this is a great start to today's International Women's Day presentations, celebrations rather, on Ayush Darpan Forum, and a great opening session today morning by Dr. Sangeeta Salvi ma'am on application of Kanchan Karma in Shalakya Tantra, Karna, Nasa and Mukharogas. So ma'am, chat box is flooding with wishes for you and thanks notes for you. Please answer them. Everybody is praising your presentation and they have liked it so much. A ma'am, some Dr. Shrestha, some Smita Shrestha or some ma'am is there. She has joined from straightway from Nepal to our conference. Sarita Shrestha ma'am, welcome ma'am, and I welcome her in this Lady Surgeons conference here on the forum of Ayush Darpan Foundation, ma'am. Ma'am, can you just briefly introduce yourself, ma'am, to our speakers and our audience?
Namaste. I am Dr. Sarita Shrestha. I MD in Sri Tatha Prasthiti Rog from BHU. And I have been working for government of Nepal in hospital for more than 30 years. And then now I am working as a faculty in USA in the college Mount Madonna Institute of Yoga and Ayurveda. So I teach over there and I am doing my clinical practice also.
Okay. Thank you. Thank you so much, ma'am, for being with us today. Please be with us in the meeting, if possible, till the valedictory session. And according to the availabilities, ma'am, please give your remarks about our session in the presentations in the valedictory session, ma'am.
Sure. It's been wonderful. Thank you.
Okay, ma'am. Thank you so much.
Thank you. Thank you, Shalvi, ma'am.
So with a very good start to today's event, I would like to call upon Dr. Neema. Dr. Neema, are you there?
Yes, ma'am.
Yes. I hand over the mic to you, Neema.
Thank you, ma'am. A very good morning to one and all. And first of all, I would like to wish a very happy International Women's Day today to all the women, to all the Nari Shakti. Now, it's time to start our guest speakers. So it's time to call a very renowned and very dynamic personality of Ayurvedic surgery, Dr. Sheetala Sudkar ma'am. There are many things to say, and as we all know her, but on just as per protocol, I'll just go through a brief introduction of Dr. Sheetala Sudkar ma'am. Sheetala Sudkar ma'am, she is a professor and head of the Department of Shalya Tantra at the Mahatma Gandhi Ayurvedic College, Wardha. She is a PhD, PhD mentor also, PG guide also. She's having a 22-year experience of teaching, more than 50 publications in the national and international journals, 4 books, 5 chapters. She has been an international speaker. She has been delivered many guest lectures, chaired many sessions, a very enthusiastic organization of various lecture series in webinar and seminar also. She has received the Best Teacher Award consecutively in 2020 and 2021. She has received Young Dynamic Speaker Award in the year 2021, Dhanvantari Award in 2020. She has been a member at various associations and forums, etc. So, ma'am, सबको पता है सबको पता है मैम आपके बारे में, and I'm just little bit कुछ छूट गया हो तो sorry for that. And just request you to start your session, ma'am.
Thank you, Neema. Thank you so much for the introduction. Actually, the protocols we have to follow. Otherwise, as you said, there is no need of all these things. So actually, because I wanted to give some glimpses of my presentation on Raktamokshana, Vistravan Karma. So that's why a very brief presentation I have prepared for this particular second day. So my presentation, is it visible? I think it is visible. Am I audible?
It is, yes, yes. You are perfectly audible and clear.
Yes, yes. Okay. So I'll make it full screen. So again, once again, I wish all the lady surgeons and our audience and all the Ayurveda fraternity, Vaidyas, Three Vaidyas, a very, very happy Women's Day. We are here, as Madam has rightly quoted, Dr. Sangeeta ma'am, that Women's Day, Yatra Naryastu Pujyate Ramante Tatra Devata is the quote, ideal quote, which always we remember, but not only on the Women's Day, but always we remember. The quote has been displayed many times, and we get to read it, get to listen to it throughout our life, in the every walk of our life, we can say. So gender equality today for a sustainable tomorrow is the theme of International Women's Day this year, and these are the colors, purple, green and white. As Madam has a very beautiful presentation which included all the colors in her presentation. Purple for justice and dignity, green symbolizes hope, and white represents purity. So ma'am, I have actually copied your slide and pasted over here because it is so beautiful. So under the Azadi Ka Amrut Mahotsav celebrations, my presentation is on the curative approach to diseases in various disciplines of Ayurveda with Rakta Vistravan Karma by Leech therapy. So as everybody knows, Raktamokshana is the technical term which is used to denote the Rakta Vistravan Karma or bloodletting through various forms of treatment modalities available in Ayurveda. So according to Ayurveda literature, it can be done in two ways: with the help of Shastra, that is surgical tools, and with the help of Anushastra, that is parasurgical tools. So Shastra Vistravana includes Prachan Siravyad, and Anushastra Vistravana includes Jalaukacharan, Shangavacharan, Alabu and Ghatyantra. This is the basic info. Then this particular table it displays the indications of Shringa Jalauka Alabu Avacharan according to various acharyas. So I'll rush through these slides. Jalauka, it's a tiny or soft, slimy parasite. And the clinician who knows all about the leeches, habitat, their methods of collection, variety, storage, and methods of application is successful in treatment, as it is quoted by Acharya Sushruta. And Jalam Asam Ayu Riti Jalokaha is the compound word which is having animals who are having water as their life. So all this particular presentation of mine, I dedicate it to Dr. Subhash Chandra Varshney sir, my guru, my guide, and sir के कारण ही मैं इस particular मूवमेंट पे, इस पर्टिकुलर कगार पे मेरे जो करियर के हूँ वो मैं सर को ओ करती हूँ, सर को बिलोंग करती हूँ. सो थैंक यू सो मच सर, ये सब आपके लिए है. So it is the Nirvish type of Jalaukas which we use in the practices, our clinical practices, and they are having Shita Snigdha Lakshana Madhur Gun, and the dosha, action on dosha is Pittahar. So the vidhi, the procedure we have to follow is Trivid Karma according to the Trivid Karma. So the Purva Karma contains following major criteria, that is collection maintenance, assessment of patient, Shodhan to the Jalauka and Atur Siddhi. I'll rush through these slides because what I want to project here is my particular clinical exposure to the patients' indications for Jalauka Avacharan, indications of patients. So leeches, leech lab, then patient selection, written informed consent, and patient explanation of the patient, explanation of the benefits of leech therapy to the patients. This is the procedures which we include in the Purva Karma. So leech lab at our hospitals, you can see the various of containers, jars, dressing trays and all. In cleaning of leech in Haridrajal, you are able to see here the leeches dwelling in the Haridrajal, pinch of Haridra included in the bowl, which is containing tap water. So this video I would skip. This is the handling of leeches. The training is given to the students in this way so that they should not have sometimes they feel pukish, but the students should be friendly to the leeches while before applying it to the patients. Then Pradhan Karma, that is application of leech and observation. This is the intern who is explaining the patient the benefits of leech therapy, and as the student is friendly, the student is able to apply it in a very easy manner to the patient. So this is the application of leech. The wet pads are applied over the leeches. Again, I will skip the video. So knuckle is formed, as you are able to see. It means the leech is very calmly and quietly had started its function of sucking the blood. So I would skip it. Again, detached leech you are able to see as some pinch of Haridra is put over it, or as soon as the capacity of the leech is complete, it will be detaching itself from the patient. Then the leech, detached leech. So then another thing, Paschat Karma, that is management of the patient and management of the Jalauka. So this is the Paschat Karma. As you are able to see, the intern is attributed to the patient because you need to be watchful while applying the leeches. You are able to see the dressing tray, then the dressing, the way it is performed, and the leech collected in a kidney tray, then the Vaman Karma given to the patient, to the leech, and then collection of the used leech in the another bowl. So this is the modus operandi which has to be followed in the SOPs of Jalokavacharan to any given patient. And then again after the Vamana, we give Shodhan, a mild Shodhan procedure to the leeches, same way. And symptomatology of Samyak Yoga, they say that when the impure blood is sucked out and the patient feels the relief in itching, burning and pricking pain, the leech should be detached. This is the Samyak Yoga, that is loss of pain and redness. Sadhyo Ragha Rujashama is the shloka given by Acharya Sushruta. So it depends on the, according to Dallana, the Samyak Yoga depends, Samyak Mithya or Ati Yoga depends on the Purusha Bal Pramana, Dosha Bal Pramana and Vatadi Janya Vyadhi Bal Pramana. And this is the symptoms if the Savish Jaloka bites. So sometimes the patient may feel like itching, murcha, jwar, daha, chardi, mad, angasad. And the treatment given for it is Mahagada, which is the explanation given in Sushrut Kalpasthana. You can go through it. Then leech description. This is the Hirudo medicinalis, which is used in the European world, and it is Hirudo granulosa, which is used in the Indian population or Asian population, which is the Indian cattle leech. So these are the species. Then this is the description. This is the Y-shaped wound of leech bite. Then leech therapy, which has been successfully practiced by Ayurveda physicians, and it includes 150 bioactive substances which have got various medicinal properties. And then these are the leeches which are nowadays in very much popularity, and please, and the popular contents of these leeches are like every clinician wants to know what exactly are the contributing factors of the leech therapy. So there are certain factors like platelet aggregation inhibitors, pyrase, collagenase, kaolin, vasodilators, proteinase inhibitors, anti-inflammatory enzymes, analgesic enzymes, and many more. So leech therapy in various clinical and surgical conditions. This is the aspect I want to highlight over here. So there are certain clinical conditions like arthritis. Patients of various types of arthritis come to our OPD for pain management, and there is a pain management OPD where we apply leeches to the patients of arthritis, and you are able to see the RA patients. The OPD almost is flooded with these patients. And then these are again the another patients of RA. This was actually the postgraduate thesis of one of the students, and the student was very much sincere to apply leeches. And you are able to see the patients come to you for pain management. They come to you, Dr. Sahib, कधी यायचंय leech लावायला, कधी यायचंय जळू लावायला, त्यांनी फार बरं वाटलं. So the postgraduate protocol was designed in such a way that bi-weekly the leeches were applied, and the pain criteria was assessed before and after the treatment. Then you are able to see another patient. So parametric statistical data, you are able to see the subjective parameters and mean percentage relief. So it was other criteria of the painful inflamed joints were also significantly reduced, but it was the pain which was on the top of the chart to have maximum relief in these patients. CRP and ESR were the inflammatory markers, which were the study of my particular it was the study of my research protocol where I performed my PhD on. So it is the significant decrease in the CRP and ESR of these patients. In osteoarthritis patients, you are able to see. Similarly, these patients were even given trial for leech therapy for pain management and reduction of inflammatory markers. You are able to see the reduction in pain and followed by other criteria like swelling, redness, tenderness, local temperature, restricted movement, walking effect. In gout patients, so it was a comparative study, which was a project of research, long-term research project. And when these three particular arthritis were compared, so I think I have, yes. So when these three particular arthritis were compared, it was the gouty arthritis which rendered the maximum results when the subjective parameters like pain, swelling, redness, tenderness, local temperature, restricted movement and walking effect were compared. Then you are able to see the cellulitis patient. This was again a postgraduate protocol, and you are able to see various patients of cellulitis. And in comparative group, another group, a Panchavalkalka was applied in these patients. Another patients, and there are significant results. The first case depicts the cellulitis. It was the venous thrombosis patient which later converted to cellulitis. Then leech therapy in CNHU. This is the wound bed preparation project of one of my patients, one of my students, which renders very significant, excellent results by leech therapy. Afterwards, then a project is planned. You are able to see similar patients, leech therapy in CNHU. Again, another project is planned where in these particular patients of wound bed preparation by time principle of wound management, we will be doing the Sandhana Karma. As you are able to see, leech therapy in CNHU in cellulitis patients. This was a necrotizing fasciitis patient. And in the last slide, you are able to see the skin grafting done. So it was the wound bed preparation project, and later on Ropan Karma or Sandhan Karma were the options given to the patients, and some patients opted for the Sandhan Karma. So Ropan Karma also can be done or Sandhan Karma can be done. It is the patient's choice, but then a research project is planned. So yesterday only I showed these slides, some of these slides which are the trademark patients. In this patient, amputation was saved. Leech therapy was done, broad spectrum antibiotic was given later on, VAC dressing was planned, and you are able to see the wound bed prepared in the third slide, and later on the graft was given. So this was an uncontrolled diabetic patient, and we were able to save the amputation in this patient. So it is said that if the surgeon is able to save an amputation in his life, then he is a successful surgeon. So our attempt is to render maximum services to the patient so that the patient can have a good quality of life after our therapy, whatever therapy options we give to the patients. So this is another case of diabetic foot. You are able to see again leeches applied, later on VAC dressing given, wound bed prepared under broad spectrum antibiotic coverage, and later on graft was given. But we couldn't save amputation of one digit in this patient. So you can see the statistics over here, pain statistics in CNHU patient with leech therapy. Then this is another parametric evaluation of this patient, particularly for the wound bed preparation criteria. Then there are various other diseases in which you can do leech therapy in your general practices or in your daycare procedures, as a daycare procedures. These are routine acne patients where we perform leech therapy. Younger, that is hyperpigmentation in patients, routine patients of routine female patients, which come to our OPD, blepharitis, alopecia. These are the areas of research, proposed research. Impending gangrene, the child came, it was a referred patient from a practitioner, leech therapy was done. Then leeches in keloid, this is again a research project which is proposed. Then leeches in an amputation wound, you are able to see the leeches applied post amputation, and you can see the healing which was promoted. This was a non-healing ulcer. Then in diabetic foot, this research is going on. There are a variety of patients who come to our OPD for leech therapy. Then these are routine patients, bilateral pedal eczema, Palmar allergic dermatitis. These are the routine. This patient comes to me with in every season when she gets this allergic type of dermatitis. So this patient is treated. She has to wean off from her routine work, whatever she does, and then she is under my treatment for 2 to 3 months. And then the patient gets result again. वो गायब हो जाती है जब उसको ठीक हो जाती है, रिलीफ हो जाता है, and again she comes after a year or two. This is a process going on for since last 2 to 3 years. Then lower limb foot ulcers, there are variety of such patients. Very recently there was one patient who came to me with foot ulcer, and then the patient who had a 15 to 20 years history. So locally debridement was done and histopath was done, and it came to be malignant this year. So otherwise that patient was a routine patient of ours. Then these are another patient. Second image, you can see the necrotizing fasciitis patient who was willing for Kanchan Karma, that is grafting, who was given the leech therapy prior to grafts. This is venous ulcer failure graft case from Government Medical College, Nagpur. And then another cases also, these are the exclusive cases who came for leech therapy. So your hospital gets popularity when some therapies of yours from Ayurveda fraternity, as we are the students of Sushruta, it gives you name, fame and all. So patients come to you for such therapies, and your even colleagues, even your patient sends to you their patients for this particularly for their these particular therapies with actual results. So peripheral vascular disease patient, there was a non-healing ulcer. In the second pic, you can see he was a chain smoker and leech therapy was advised and done, and then there was healing in the ulcer. The first pic also reveals the same. In a nail bed abscess also it was applied. Again another foot abscess. You can see thrombophlebitis, major bruises after RT and DVT. We are doing it in a broader scale, leech therapy on a broader scale, then a CNHU on a lower limb ulcer. The patient was referred from a medical officer from a public health department, and the patient had good results after leech therapy. SSTS, skin and soft tissue infection, even these are certain things under research. Thrombose hemorrhoids, as it is an indication of leech therapy, or Jalauka application indicated by Acharya Sushruta. Pain scale was 8 to 9 before therapy, and the pain was relieved till 3 to 4 after therapy on the first sitting only. And I must tell you that this is an employee of our institute which was benefited by leech therapy. So वो भक्त बन गया leech therapy का उसके बाद, otherwise the patient was crying with pain. So another similar case, leech therapy in thrombosed hemorrhoids. This is an ANC patient. Again, she came with severe pain and was given leech therapy, and you are able to see that the patient was applied it immediately, and immediate pain relief was there to the patient. So this is the thing which we get the results with leech therapy. Second case, first is the prolapse hemorrhoids. Another case is the perianal abscess at 12 o'clock, where leech therapy was done, giving immediate results, or ashukari chikitsa as we call it as, and leech therapy in electric burns. So in this patient, severe burn injuries were there. So mutilated trauma was there. The patient was mutilated with burns. Anyhow, he had to sacrifice his one of the lower limbs, but another limb was in this condition, and we applied the leeches and we did the things, and the patient was saved from this particular injury after the care which was taken for so many days. Then another traumatic wound, leech therapy in eczema, leech therapy in diabetic foot. This is the leech clinic which we run. I used to run in my previous institute, and nowadays I have shifted here. And here also we are able to project this type of particular patients, the uses of leech therapy. So these are the very highly appreciated patients of mine. So this is the mode of action, the bloodletting action during active suction of blood, the passive oozing of the wound, and injection of the biologically active substances with the saliva into the host. So these are certain active ingredients, that is salivary gland secretions, pyridine, kallin, destabilize, pyrostatin, dialins, hyaluronidase, tryptase inhibitors, and many more like acetylcholine, anesthetic substance and all. So there are certain potent actions like of leech therapy, like fibrolytic activity, antithrombotic effect, antifungal activity, antibacterial activity, analgesic and anti-inflammatory activity, and many more, which contribute to the multifactorial actions of leech therapy, which gives you wonder results in the patients with so many biologically active medical effects of leech therapy. So that's why I conclude that it is the ageless health through drugless alternative treatments is the next natural step forward as a choice of healthy lifestyle in our society, and it is one of the leading alternative and complementary modalities in the world. So a medical marvel has risen from both the swamp and the pages of history, it is said. And in this presentation, I have tried to throw light on the estimated research work that is done in my surgical practice since these many years, although there are many other indications to work on and many others to be revised with wide research to be undertaken in the form of RCTs. So I would always recommend further planned research in the huge diaspora of Ayurveda field with so many leads given today. So thus the therapy in the form of detoxification and rejuvenation through the blood purification with leeches is a drugless healing art and can be stated as the future for wellness. These are certain articles which I have tried to publish on leech therapy, and now the number has increased. So thank you so much. Thank you so much, my Guru Dr. Vashne sir, who has shown me the light to present my work on leech therapy over here. Thank you so much.
Thank you very much, ma'am. Leech therapies are trump card. Excellent presentation with the beautiful picturization of many clinical cases. Thanks for this, ma'am. Thanks for your valuable words. You are such an inspiration for budding surgeons. Thank you very much, ma'am. Now it is time to take next presentation of Dr. Madhuri Banaras, ma'am. Madhuri, ma'am, are you here?
Please start screen sharing.
Yes. Madhavi ma'am, she is a BMS, MD in Shalatantra, presently working as a professor and head of the department at PDEAS, College of Ayurveda and Research Center, Akurdi, Pune. She is PhD guide. Above 20 students completed the PG and PhD work under her guidance. She has written more than 18 articles. She has been an organizing secretary and resource person in CME in Shalatantra granted by RAV. She is a PhD examiner at BHU. So, ma'am, I request you to start your presentation.
Yes, ma'am. Please allow me to share the screen.
Yes, Shivam.
Madam, share screen.
Yes,
allow
ma'am.
kara.
Yes. Shivam, allow them. Yes, Shivam, please. Yes. Madhvi ma'am, you are co-host now. You can share your screen now.
Am I slides visible?
Slides are not visible, but you are clearly audible, ma'am. Slides.
स्क्रीन शेअरिंग हे केलं नाहीये मॅडम, डिसेबल्ड केलेलं नाहीये. पोस्ट डिसेबल्ड पार्टिसिपंट स्क्रीन शेअरिंग असं म्हणताय. Hello, am I audible?
Yes, ma'am, you are audible, but your screen is not visible.
The host is unable to screen sharing. ऐसे बोला है. हाँ, अभी आ गया है मैडम.
Okay, okay. Yes, ma'am. Yes. You just start your presentation.
Okay, thank you. So now it is visible.
Yes, yes, ma'am. It is perfectly visible.
Good morning, respected Dr. Varshney sir, Dr. Kashikar sir, Dr. Pandey sir, Dr. Sheetal ma'am, and all other respected faculty. First, I would like to wish you all a very happy Women's Day. I would like to thank Ayush Darpan, Dr. Sheetal madam, Naveen sir for giving me this opportunity on this wonderful occasion of the World Women's Day, which made it memorable for me. I would like to express my sincere gratitude towards my guru, Dr. Varshney sir, who taught me so many things. I express my deep condolences towards Dr. Premvati Tiwari madam, who is indeed a great surgeon. I also express my deep condolences towards my former HOD, Dr. B.N. Deshpande sir, who was a keen surgeon who taught me a lot and gave me a free hand. Now towards my presentation. So today's my topic is skin grafting, Ayurvedic and modern view. First, I would like to express some theoretical, then I will like to express some practical aspects. Everyone knows that Acharya Sushruta is well known as a father of plastic surgery. Acharya Sushruta made important contributions to the field of plastic surgery. Since very ancient times in India, mutilation of the ear and nose are very common, either by injuries in the war, formed in the war, or as a sort of punishment. If mutilated nose are damaged completely or partially, the work of a surgeon to repair it. Sushruta was first surgeon who performed this fabricated surgery. Sushruta described 15 types of procedure regarding joining of the mutilated ear. That is, he described 15 Karna Sandhan procedures in Sushruta Sutrastan Adhyay 16, Shlok 10. One of the 15 methods, he described it as a cut off a flap of the living muscle from the cheek, retaining its connection intact, turn over to the side of the lobe or damaged part after scraping the area and make the lobe over there. Ganda Duspatya Mounsena Sanu Panjena Jivata Karna Palimuma Palestu Kuryan Nirlikta Shastram. So this is the principle behind the Sushruta's plastic surgery, and we applied it on these days also. Sushruta also described the method of joining the mutilated nose, that is Nasal Fungus or rhinoplasty. Sushruta's method of rhinoplasty was adopted world over and popular as Indian rhinoplasty. So this is the shlok of Indian rhinoplasty or Sushruta's rhinoplasty, which is described in Sushruta Sutrastan Adhyay 16. So Nasal Sandhan or rhinoplasty. A leaf of a plant should be taken, cut to the shape of the nose, placed on the cheek, and then the cheek muscle is cut to the same size, raising the flap of it and maintaining the connection with live muscles. The flap is placed on the mutilated nose after scraping it. Then the bandage is tied, inserting 2 tubes in the nose to keep the airway intact. Then union has healed. The flap of muscle should be cut half length, allowing the remainder intact. If the nose is short, attempt should be made to augment it and if there is excess growth, it should be cut even. So this is the shlok of Oshtasandhan, or Sushruta described mutilated leaf or oroplasty in this shlok. So skin grafting, according to modern science, skin grafting is the transplantation of the skin, which is often used to treat extensive wounding or trauma, burns, areas of extensive skin loss due to infection, or as necrotizing fasciitis or purpura fulminans. Specific surgeries may require skin graft for healing, mostly removal of the skin cancer. So many skin cancer widely excise the skin, and it requires skin grafting. Skin grafts are often employed after injuries when some of the body skin is damaged. Surgical removal or excision or debridement of the damaged skin is flagged by the skin grafting. The grafting serves two purposes: reduce the course of the treatment and improve the function and appearance of the recipient area. So skin grafting helps to healing of the wound. So there are graft classification. There are two types of graft. Partial thickness. A thin layer is removed from the healthy part of the body, that is the donor section, like a peeling a potato. बटाट्याची साल काढतो त्याप्रमाणे partial thickness skin graft घेतला जातो. It is more common type. Full thickness, which involves stitching and cutting of skin away from the donor section. A full thickness graft is more risky in terms of body acceptance of the skin. Yet it leaves only a scar line on the donor side, similar to a cesarean section. It gives a scar, just a linear scar is left on the donor side. For full thickness skin graft, the donor section will often heal much more quickly than the injury and is less painful than the partial thickness skin graft. Partial thickness skin graft is more painful because all the cutaneous nerves get opened or exposed. Then skin graft classification are also autologous or autograft. The donor skin is from a different side of the same individual. That's particular माणसाची skin त्याच याला वापरल्या जाते. So it is autograft. Then isogenic or isograft or skin graft. The donor and the individuals are the genetically identical. Example, monozygotic twins. जुळ्या लोकांची स्किन एकमेकांना वापरली जाते. That is isogenic or isograft. Then allogenic or allograft, the donor and the recipient of the same species. That is human to human, dog to dog. In one of our cases, we used the skin of mother for his child of 12 years. He has a roadside accident and he damaged so much skin of his both legs. So there is no skin left for the skin grafting. And in that case, we used the skin of his mother. But unfortunately, the graft was rejected. Xenogenic or xenograft or heterograft. The donor and recipient are of different species. Example, bovine cartilage. So this is xenograft. Prosthetic or prosthetic implant. Lost tissue is remained with synthetic materials such as metal, plastic, or ceramic. Graft classification also there according to thickness. So a split thickness skin graft, commonly known as STSG, is a skin graft includes epidermis and part of the dermis. Its thickness depends on the donor site and the need of the patient. It can be processed through a skin mesh which makes aperture to the graft, allowing it to expand up to 9 times of its original size. Split thickness grafts are frequently used as they can alloy skin areas and the rate of the auto rejection is low. Split thickness skin grafts are more acceptable. The same donor area can be harvested again after 6 weeks. The donor site heals by re-epithelialization from the site and surrounding skin and hardly requires dressing. A full thickness skin graft consists of the epidermis and the entire thickness of the dermis. The dermis site, the donor site is either sutured closely directly or converted a split thickness skin graft, or covered with a split thickness skin graft. So full thickness skin graft consists of epidermis and the entire thickness of the dermis. And the donor site is either closed directly or covered with a split thickness skin graft. I want to show you both the cases, which suture directly and cover with a split thickness skin graft. Composite graft. A composite graft is a small graft containing skin and underlying cartilage or some other tissue. Donor sites include, for example, ear, skin, and cartilage to reconstruct nasal alar wing defect. Donor selection. When grafts are taken from other animals, they are known as heterografts or xenografts. They act as a temporary biological dressing, which the body will reject within 2 days or 2 weeks. But why we taken? They help to reduce the bacterial concentration on an open wound and reduce fluid loss. So this is acceptable, okay, for the temporary dressing. For more extensive tissue loss, a full thickness skin graft, which include entire thickness of the skin, may be necessary. This is often performed defect of the face and hands, where contraction of the graft should be minimized. The general rule is that the thickness, the thicker the graft, the less the contraction and deformity. But the general rule is that more thick the graft, chances of rejection are more. In order to remove the skin and well skin slices and strips from the donor site, and surgical instrument, dermatomy is used. Commonly, we know we tell it as a Humby's knife. This usually produces a split thickness skin graft contains the epidermis with only a portion of dermis. The dermis left behind at the donor site contains follicle and sebaceous glands, both of which and epidermal cells, which gradually proliferate out to form a new layer of epidermis. The donor site may be extremely painful and vulnerable to infection. It is so painful, so no need of dressing on the 3rd or 4th day. I have made the mistake and made the dressing of the donor site on 3rd day, and patient shouted with pain because all the cutaneous nerves are exposed. So no need of dressing until 10 days. When the dressing is looser, then you can do the dressing of that donor site. So these are some unique cases. Ideally, management of diabetic ulcer with composite skin graft. This is diabetic ulcer. The patient is 85 years male, occupation is farmer, and his whole heel is damaged with the ulcer. So here we make the incision on the sural area, make margins on the sural area, and there is a composite skin graft. This graft is taken from the sural area. This is augmented on the first. There is a debridement of this wound, and there is a suture, this composite skin graft. So here, which is the adjustment of the composite skin graft. Then here the recipient area after the this is the recipient area. This is the donor area. So for this donor area, we have to take the partial thickness skin graft. Taking partial thickness skin graft. So this is the partial. This is Humby's knife or dermatome, from which, with the help of this, we have taken the partial thickness skin graft. So this is the raw area after partial thickness skin graft. Then covering the donor area by split thickness. This is the donor area, and here we use the split thickness, partial thickness skin graft. So this is the donor area. This is the recipient area for the after first dressing. The graft, both the grafts are well accepted. So this is the another case, management of malignant inguinal growth by wide local excision with skin graft. He is a 60 years male, occupation is farmer. He has a ugly growth in the inguinal region. It is when the biopsy has taken, it is squamous cell carcinoma. Its primary focus is not known. So this is the malignant inguinal growth. We have done the wide local excision, the wound after wide local excision. So you can see the femoral vessels, bare femoral vessels you can see, and it was my wise decision to take the help of oncosurgeon. So his job is done by the oncosurgeon because we are dealing with the femoral vessel. So this is the pedicle graft is taken from the adjacent area. The graft is rotated after wide local excision. The graft is rotated and augment on the bare wound. So this is the raw area of the donor site after pedicle graft. You can see the rotation of the skin flap here. So to cover the raw area, we have to take a split partial thickness skin graft. So here the partial thickness split skin graft is sutured. Its edges are sutured. Here the wound after partial thickness split skin graft. Then this is the same case. So it is the malignant inguinal growth. This is another case, management of multiple basal cell carcinoma with wide local excision and nasolabial rotational pedicle graft. A 55 years male, socio-economically status was poor, occupation is farmer. He has a basal cell, multiple basal cell carcinoma on the head, on the back, on the hand. So first we have done is excision of this basal cell carcinoma. Send it for histopathology. Wide local excision was done under local anesthesia. Send it for histopathology, and it is basal cell carcinoma. Then the job of the oncosurgeon. So he has excised. First we have excised it and just sutured it. Then he has, this is the post. He has taken the nasolabial flap and covered it. I have excised basal cell carcinoma of the head, and it is so much bleeding. So I told the oncosurgeon that, sir, we आम्हाला एवढ्या bleeding ची सवय नाही. So this and just this suture. So this nasolabial skin graft made by the oncosurgeon. This is the post-operative day. Post-operative wound, you can see post-operative day wound is there. So this is POD1 all over the head. Here also there are basal cell carcinoma. Here also, all over his face and all over his body there are basal cell carcinoma. And so after first day, when we open the dressing, the whole face is swollen. This is post-operative second day. The swelling is reduced. After suture removal, POD 10, the almost swelling is reduced and original state is achieved. This is the face of after 15 days. Almost it is normal. This is the rodent, excised rodent ulcer, and this is the nasolabial flap. So this is another case of pilonidal sinus. 30 years male. Last week we have performed this surgery. So this is 30 years male having pilonidal sinus as his nasal cleft, sacrococcygeal region having 2 or 3 branches. So so this is the marking for the Hydroplasty. In this case, we perform Hydroplasty. So these are the markings from Hydroplasty. So on these markings, we have given the cut. Then this is the wide local excision of the pilonidal sinus area. Then after excision, it is the suture, and it is in the form of gel. So it is known as Hydroplasty. Just the donor, the flap is rotated here. For this is the wide local excision. We have taken from flap from the here and it is rotated on the raw area and sutured, just sutured. So here, no need of partial thickness skin graft for the donor area. Just a simple suturing is sufficient. This is another case of partial thickness skin graft for non-healing ulcer. It is a 60 years male having diabetes, and he has non-healing ulcer of the left foot. So here, when he comes, the wound is very dirty. So we have under spinal anesthesia, we have done the debridement of the wound. After debridement, you can see the raw area, or the hypergranulation we have debride. Then we have taken a thin split skin graft and this is the adjustment of the skin graft. After dressing, you can see the grafts are very well accepted. So this is my today's presentation. Lastly, all these procedures are not possible without anesthesia. A good anesthesia makes the surgeon's job easy. As Ayurvedic surgeons are performing good quality of surgery, so restoration of the anesthesia faculty in the field of Ayurveda is the necessary in this era. So thank you very much. Thank you very much, Sheetal Madam, for giving me the opportunity. Thank you very much, Ayush Darpan, and thanks all the faculties who patiently listen. Thank you.
Thank you very much, ma'am. Reconstructive surgery is the greatest achievement of Ayurvedic surgery. Your session is very informative on skin grafting. Thank you. Thank you very much, ma'am.
Thank you.
Now the next presentation is of Dr. Kanchan Karma, ma'am. Ma'am, are you here? Kanchan, ma'am? Dr. Kanchan Karma, are you here, ma'am? Dr. Kanchan Karma, ma'am. I think she is not in this session. Kanchan, ma'am. We can reschedule your presentation afterward, ma'am. Kanchan, ma'am. Please unmute yourself, ma'am. Please unmute yourself, ma'am.
Hello?
Yes.
Hello?
Yes, Kanchan, ma'am.
Yes, ma'am. Are you audible me?
Now you're clearly audible, but something is just like echo, ma'am, there.
Yeah. हे बंद करा. आणि याच्यावर screen चालू करा.
Now our presenter is Dr. Kanchan ma'am.
Please make me host, ma'am.
Yes, your screen is sharing, screen shared, ma'am. You are already co-host.
Okay.
Okay. Just briefing your introduction, ma'am. You are MS and PhD scholar at GSC Nanded. Madam is associate professor in the Shalatantra department at SVNHT's Ayurved Mahavidyalaya, Rahuri, Maharashtra. She has published over 57 research articles in international and national journals. She is a co-author of 12 books related with Ayurveda, and she is a MUHS approved PG guide. Guided 6 PG student till date. She is MUHS approved PhD guide right now. So request you, ma'am, to start your session.
Yes, his screen is sharing.
And screen PPT is not visible. Your screen is visible only. But your voice is in echo form, ma'am. Just please, that disturbance is just created here.
Slides. Can you see my
Slides
slide?
Slides are visible, but your volume is just in a loud manner or something is there. Echo is there. Now, ma'am, now just you are clearly audible.
Okay. Can I start?
Yes, ma'am. Go ahead.
So, First of all, good morning, all of you. Especially good morning to Vashne sir, respected Vashne sir, respected Pandey sir, Dr. Kashikar sir, Dr. Sheetal ma'am, Naveen Joshi sir, and Nirmala ma'am. Also, good morning to all my dear friends and happy Women's Day to all of you. So can I start?
You can start, madam. Just switch off the another device which is nearby you.
Okay.
That's why echo is going on.
Yeah.
Kanchan ma'am.
Yes, ma'am.
Please share your screen.
Slide share. Okay. ईमेल ओपन करून दे मला याच्यात. ईमेल ओपन कर. मी ऑलरेडी ओपन केलं होतं ते. Yes. Yes, ma'am. Now our slides are sharing.
No, no, ma'am. Still your slides are not visible.
Not visible. Just a minute. हे काय येतंय वेगळंच? Madam, some technical problems are there, but
Okay.
yes, I'm sure now you can see the slide. Is
Madam,
everything
can
okay,
you
ma'am?
take your presentation after this
That's-
one? We'll have one presentation till then.
No, madam, I think I have a slide presenting there. Screen is visible.
Hello.
No, ma'am. No, ma'am. Your screen is not visible. Yeah, we can take your presentation later on, ma'am.
Okay, okay.
So
No
just only
problem.
one presentation.
Okay, ma'am. Okay.
Okay, you just find out or sort out your issue and then we will take it. Okay, ma'am.
Okay.
Okay. So
काय हे?
yes, Shilpa ma'am. Shilpa ma'am, are you here? Shilpa Kadhar
Yes,
ma'am.
ma'am. Yes, ma'am, I'm here.
Okay, okay, okay. So we are taking the next presentation of Dr. Shilpa Kadhar madam. She is BMS and MS, PhD in Sangyaharan from Tilak Ayurved Mahavidyalaya, Pune, Maharashtra. She is MBA in Hospital Administration and Institute of Chartered Financial Analysis. She is a freelance anesthesiologist. She is ex-associate professor and head of the Department of Sangyaharan from Tilak Ayurved Mahavidyalaya, Pune. She's having a 17 years of teaching experience at Tilak Ayurved College, and she's PG guide for MD in Sangyaharan. She has received 6 Best Paper Award. She has presented papers in various national and international conferences and many more. So over to you, ma'am. I just request you to start your presentation.
Thank you, ma'am. Respected dignitaries present here today. Respected Dr. Vashne sir, Dr. Naveen Joshi sir, Dr. Sheetal ma'am, Dr. Pandey sir, Dr. Kashikar sir, Salvi ma'am, and all the dignitaries present here. I would start my presentation by paying my tributes and sincere gratitude to my guru, Dr. Puranik sir, Dr. Subramaniam Bhatt sir, and Dr. Murlidhar Sharma sir. Am I audible and visible?
Ma'am, you're clearly audible and visible too.
First originated from the concept of pain. Okay, pain has been man's greatest scourge at all.
Sorry to disturb you, ma'am. Shilpa ma'am, sorry to disturb you. Your voice is not clearly audible now. Shilpa ma'am.
Am I audible?
Yes, ma'am, you
Yes,
are
ma'am.
audible,
Yes,
ma'am.
yes, ma'am. You are audible. Ma'am, your screen is not visible, but
Host is. I think you'll have to make me the host first.
wait,
Shilpa ma'am, you can send your slides here. We will share.
Yeah, just a minute.
If there is any technical issue.
I think you'll have to make me the host first.
Co-host.
So that
You
I
are
can...
co-host, madam.
Can you see the screen now?
It is
Yes, ma'am. Yes.
visible.
Visible.
Okay. Shall I start?
Go ahead, ma'am. Go ahead.
Yeah. Was I not audible right from the beginning? Right from the beginning?
Ma'am, just one single slide. You just we were able to hear you.
Okay, I'll continue. I'll start from the beginning. Okay. Sangyaharan as a science first originated from the concept of pain. Pain has been man's greatest couch at all times and is a natural component as well as sequel of every surgical procedure. Even in the Vedic literature, where the earliest accounts of surgical treatment are found, there are evidences suggesting the use of pain-relieving drugs by the surgeons of those days. Sushruta, the father of surgery, had accepted the concept of minimizing pain during surgery. Surgery has been dealt with in detail in Sushruta Samhita when it was in the peak of its glory. Surgery was very much advanced in ancient India in Sushruta's period and opened out many vistas in surgical science. Sushruta used to perform various surgeries like laparotomy, rhinoplasty, hemorrhoidectomy, removal of the calculi, removal of obstructed fetus, and there is also a detailed description of the management of wounds, fractures, and dislocations in Sushruta Samhita. Although there is no specific reference of the terminology of Sangyaharan, there are references stating the use of alcohol by Sushruta in an attempt to minimize pain during surgery. Also, there are historical evidences to prove that the techniques of pain relief existed in one form or the other during the ancient times. Otherwise, the complex surgeries which were being performed in the ancient times by Sushruta would have been absolutely impossible to perform. Thus, it is convincing that Sangyaharan existed in its primitive form even at the time of Sushruta, and ancient surgeons were in search of drugs which could produce reversible state of unconsciousness. Even in the history of modern anesthesiology, there was a turning point with Morton's demonstration of ether anesthesia in 1846. After this breakthrough of ether anesthesia, there were many technical improvements in the science of anesthesiology, accompanied by academic recognition. The patients started having the privilege of better management of intra and post-operative pain, and also the surgeons had better operating conditions to carry out the surgical procedures. The practice of anesthesiology dates back to ancient times, yet the evolution of this specialty began in the mid-19th century. This branch of medicine became firmly established only less than 6 decades ago. That is very recent. Just 6 decades ago, anesthesiology got advanced. The application of recent advances in biomedical technology in clinical anesthesia continues to make anesthesia an exciting and rapidly evolving specialty. The anesthetic techniques evolved first with inhalation anesthesia, followed by local and regional anesthesia, and finally intravenous anesthesia. The development of surgical anesthesia is considered as one of the most important discoveries in human history. As we all know, none of the surgical or parasurgical branches can be complete without the support of an anesthesiologist. All the esteemed surgeons present here would agree to me that no surgical procedure is possible without the help of an anesthesiologist. A variety of surgeries are being performed by our experts in Shalya, Shalakya, and Strirog Prasuti Tantra since many years now. But most of them are still dependent on anesthesiologists of modern system of medicine to carry out these surgical procedures. In the late 60s and 70s, there were integrated courses like AVP, GFM, FFM, and in those days, many stalwart anesthesiologists were trained in St. Tarachan Hospital, Pune. A few to name: Dr. MP Joshi, Dr. Bhave, Dr. Limaye, Dr. A.B. Shah, Dr. Gopte, Dr. Chaudhary, Dr. Marathe, Dr. Puranik. These are few of the stalwart anesthesiologists of those 60s, 70s, 80s period. In those days, surgery and anesthesia would run hand in hand. There was a course of post-graduation in anesthesia in Sammohan, but later it was discontinued. Banaras Hindu University is also a pioneer in training anesthesiologists of Indian system of medicine. Initially, Shalya Tantra PGs were given meticulous training in anesthesiology, and they would have to opt for a subject related to Sangyaharan for their post-graduation dissertation topic. Similar, I had an opportunity to get trained in anesthesiology during my postgraduate studies in Shalya Tantra in SDM College of Ayurveda, Udupi, under the guidance of Professor Dr. S. Subramaniam Bhatt and Professor Murlidhar Sharma. Both of them were alumni of BHU. Later on, after passing out from Udupi, I joined as a lecturer in Tilak Ayurved Mahavidyalaya in 2004 and as a consultant anesthesiologist in St. Tarajan Hospital, Pune. And simultaneously, I also started my freelance anesthesia practice in Manchar, which is a suburb of Pune. Since I was practicing in the rural area, I had to face many challenges during my practice. Initially, there were compromised hospital setups with absolutely bare minimum facilities. I had to attend night LSCS calls and taking care of household responsibilities and taking care of children was also very taxing. But thankfully, women are naturally blessed by the Almighty, by the supreme power of multitasking, and hence I could actually manage all the challenges very easily. I started getting calls from major hospitals from Indian system of medicine as well as modern system of medicine. In just a few months of starting my practice, I got established as a leading anesthesiologist in my area. Another feather in the cap of my career was I got an official appointment in government hospital in Mansar RH, which is now a sub-district hospital, and Godegaon RH under NRHM. This was the breakthrough in my career, and I got to perform many challenging cases in these government setups. And thanks to the contemporary surgeons of that time to show faith in me for performing the procedures. Now, I would share a few statistics, the cases that I have performed till now. From 2004 onwards, I have conducted more than 18,000 anesthesia cases independently, 6,000 cases in government hospital alone, and more than 12,500 cases in private hospital. And of course, I have a detailed record of every patient I have anesthetized along with the name and diagnosis of the patient. During the COVID crisis, I also conducted COVID LSCS and I also intubated many COVID patients. During this period, I had to upgrade myself. So I learned the use of modern anesthesia workstations, the use of supraglottic airway devices, the use of modern techniques in regional anesthesia. Of course, everybody has to remain updated if you have to remain in practice. Simultaneously, I also pursued my PhD in Sangyaharan at Tilak Ayurved Mahavidyalaya under the guidance of my revered guru and mentor, my guide, Dr. D.P. Puranik sir. I'm really very thankful to him. Whatever I am today is just because of Puranik sir. During my academic journey, I always had the blessings from stalwart teachers of Tarachan Hospital like Dr. Marathe, Dr. Gangal, Dr. Doifude, Dr. Parchure, Dr. Borse, Dr. Sangeeta Salvi ma'am, and many more. And of course, I would like to mention Dr. Kashikar sir. He shares a special bond. Actually, he is the guide of my husband. And he was there as an examiner for me during my post-graduation examination. And I had an opportunity later on. I was humbled to be a co-examiner with him during one of our MD Sangyaharan examinations. In the meantime, PG course in Sangyaharan was also in the budding stage. In 1989, Executive Council of BHU approved Sangyaharan as a separate subject for post-graduation. This was further recognized by CCIM via Gazette notification in 2005. Finally, MD Sangyaharan was established as a separate branch at BHU, and students started getting trained as anesthesiologists and started practicing independently as freelance anesthesiologists. Even in Maharashtra, at the same time, as a result of painstaking efforts by Dr. Puranik, Dr. Gangal, Dr. Doifude, and many more for several years, MD Sangyaharan course started in Tilak Ayurved Mahavidyalaya in 2011. Every year, students started getting admitted and getting meticulously trained in clinical anesthesiology at our Tarachan Hospital. And I'm in a very proud position to say today that all the students of MD Sangyaharan today are successfully practicing as freelance anesthesiologists. Some of them have joined some institutions and are highly proficient in anesthesia. They are providing their services to surgeons and gynecologists of Indian system of medicine as well as modern system of medicine. Unfortunately, in 2016, the governing body of CCIM discontinued this viable postgraduate subject, and this course of MD Sangyaharan was stopped by MUHs. And it is an irony, and I'm really surprised that no stand has been taken against this move of CCIM till now. We all know that without anesthesia, all the surgical branches will get crippled. At present, our surgeons are practicing at the mercy of modern anesthesiologists. Now you have to request them to please come and attend calls in our hospitals. The associations of modern system of medicine are really strongly against the surgeries being performed by our postgraduates of Indian system of medicine. And the day is not very far that these people will stop their services, providing their services to our postgraduates. And what will happen? The surgical branches will come to a standstill. Is it not the responsibility of all those who are performing surgeries today to safeguard their futures? Is everyone under the impression that whatever surgical practice is going on today will continue as it is in future? I'm really sorry to say, but the answer is a big no. It is high time that all of us wake up and start making attempts to safeguard our own future. It is my humble request to all the surgeons present here today to create an awareness among our postgraduates to make efforts to restore this viable branch of Sanghaharan. We desperately need more anesthesiologists to serve our surgeons. At present, our ISM anesthetists are rendering their services to our surgeons, but they are only a handful. How many are there? Few are in Banaras, few are in Pune, and few are scattered somewhere near Maharashtra, but they're really a handful. Will they be sufficient to cater to the needs of hundreds of hospitals of our PGs and Indian system of medicine? Time to think about. The newly formed NCISM looks to be promising as they are trying to improve the standards of Ayurveda education by setting up adequate norms for colleges to fulfill. It is our duty also to increase the standards of education and training of our postgraduates from clinical branches. The Gazette notification given by the government stating the list of surgeries that can be performed by the practitioners or surgeons of Indian system of medicine can be considered as a stepping stone in the upgradation of our postgraduates. Initially, only surgeons from UP and Maharashtra were doing clinical surgical practice. But however, this Gazette notification has developed an urge for learning surgeries in students of other states too. If this is the scenario in near future, everyone all over India will need our own anesthesiologists to help our surgeons. Where will we get them from? It is high time now that we have to convince the NCISM to restore this vital branch of Sanghaharan in postgraduate education in Ayurveda. It is the need of the hour that all of us should stand united. All the postgraduates of Shalya, Shalakya, Strirok Prasiti Tantra should come together on a single platform and approach the NCISM to revive this MD Sanghaharan course and with legal rights to practice. Dr. D.N. Pandey sir and his colleagues have already started the mission for Sanghaharan restoration in a full swing. I also appeal to all of you to join hands with him and come forward for this noble cause, not for the sake of anyone else, but just for the sake of your own surgical practice in future. We still have a long way to go. The woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep and miles to go before I sleep. I thank you all for patiently listening to me, and I thank the organizers, Dr. Sheetal and Dr. Naveen sir, for giving me an opportunity to share my views on this platform. Thank you very much.
Thank you very much, ma'am. Thank you for your very wonderful and informative, precise knowledge about anesthesia. Thank you very much, ma'am. Now, we would like to take the next presentation. Kanchan, ma'am, your problem is solved now. Shall we take your presentation?
Yes. Am I
Kanchan
audible?
Shekhar, ma'am.
Yes, am I audible?
Yes, you are audible, ma'am.
And my slides can be
You can
visible?
share your screen. No, screen is not visible yet.
Screen is not visible. Okay. Share. Yes, now?
No.
Hello?
No, ma'am. Screen is not visible. screen is not visible.
Okay. डॉक्युमेंट रीडर दाखवते ना ते.
Kanchan ma'am, you can send your PPTs to us. We will share this.
Okay, ma'am. There is technical issues, so I cannot sort it. I am sharing your my slides to you.
Okay, okay. Shivam, are you there?
Yes, ma'am. I am.
Yes. Ma'am, Kanchan ma'am, your screen is sharing now.
Okay.
But PPT is not visible still.
Okay, I am opening my
Opening
PPT.
only.
Yeah.
Only.
Now?
Yes. Diagnostic and therapeutic evaluation of varicose vein, na, ma'am?
Yes.
Yes, yes.
So lastly, we are going to start our presentation.
Yes, ma'am. Please hurry up, है ना?
Yes, diagnostic and therapeutic evaluation of varicose vein, and I am carrying on my PhD on this topic, varicose vein, under the guidance of Dr. Vijay Uphalkar sir. He is HOD and Professor of Shalyatantra Department, GSC Nanded, and I am very thankful for his constant guidance to me. So let's start with the background of today's lecture. In modern surgical discipline, there are a number of modalities for diagnosis and therapeutic parameters to handle a case of varicose vein. The diagnosis of varicose vein based on history, physical and clinical examination. As we all know that clinical examination contains a Trendelenburg test and tourniquet test, Pratt's test, Figen's test and all these things. And radiological evaluation also. Unfortunately, there is a lacuna of resources of primary diagnostic evaluation, medical literature to common people. Physical and clinical examination requires special training, depth of knowledge and expertise of medical person to achieve perfect diagnosis regarding varicose vein. Radiological evaluation of varicose vein is highly expensive to rural and urban population in the developing countries. As per Ayurveda view, varicosity can be expressed in terms of non-inflammatory sacculation or grathana in relation with veins and its surrounding structure. But before appearance of the sacculation, there must be pre-stage of dilatation, elongation, and tortuosity. And finally, this correspondence appearance is termed as Grathanat Granthi, especially in relation with Sira, Pranavayu, Ranjak, Pitta, and dhatus like Maunsa, Meda, and Rakta. As per Ayurveda literature, varicose vein is a condition occurs due to vitiation of vata dosha, aggravated vata dosha when localized in sira, then stasis of blood occurs in the vessels. It produces shula, that is pain, akunchana, which means contraction, and it presents as a varicosity of veins, and purani, which means fullness of blood vessels, that is dilatation, elongation, and sacculation. Then Ayurveda also express the symptoms in terms of sankocha sampida, that is a night muscle cramps observed in patients of varicose vein, and vakrikuta, that is tortuosity. So varicose vein is caused due to the vitiation of vata dosha. The imbalanced vata dosha creates increased pressure affecting the walls. Yeah, and elasticity of sira and its related structure. So Ayurveda recommends treatment directed towards specification of vata dosha. The stress and pressure wearing condition weaken the walls of vein, leading to the loss of elasticity, and which occurs due to the disturbance of vayu. The vitiation of dosha, mainly Ranjapitta and Vanavayu, with Kapha dosha, takes place at specific sites and calf and ankle due to the weight bearing stress. These imbalanced dosha disrupt flow due to the obstruction in blood vessels. Ultimately, veins become dilated and stasis of blood occurs, especially at their weak points. And Siraj Granthi resulted, which commonly popular as Sira Kutilata. Ayurveda elaborated causes, symptoms, and treatment of many pathological conditions. Ayurveda also emphasizes common incidence of varicose vein on uncommon health issues like Ashtonindita persons, that is Ati Dirgha, Ati Krusha, and Ati Sthula personalities. Varicose vein is one such health complaint which mainly observed in people those involved in specific occupation of continuous sedentary lifestyle like Ati Asana, that means constant sitting job or sedentary lifestyle. Then Ati Chakramana, Ati Vyayama, Rathak Shobha Janita Vikara, that is those persons who are constantly traveling. Then Sadatura, the term explained by Charaka, Sadatura, and it includes some professions, that is Shrotriya, those who are constantly listening or sitting. Then Panyajivi, that means the businessman or shopkeeper. Then Rupasevi, it includes security guard and watchmen, policemen, and like job. And then Vibandha, that means we can correlate it with constipation. Bahuprasava, in female, multiparas are included in these terminologies, and in case of female there are also some etiological factors like consumption of oral contraceptive pills, hormone replacement therapy, and menopause. So fatigue and damage to walls and faulty habits of sitting and disease conditions sometimes also affect movement of blood flow, which resulting in condition of varicose vein. Similarly, deficiencies in diet or malnutrition, wearing tight clothing, and lack movement or flexibility can also lead to varicose vein. Ayurveda describes various modalities for the diagnosis of such condition. So, diagnostic approach according to Ayurveda is after reviewing ancient literature, diagnosis of varicose vein can be carried out with Purva Rupa, Rupa, Nidana, that means etiological factors, Samprapti, we have already explained, and involvement of Dosha Dushya, Upashaya, Anupashaya, and Upadrava as per particular stage of disease. So, examination can be done with the help of Trividha Pariksha, that is Darshana, Sparshana, and Prashna Pariksha, Shadvidha Pariksha, and Ashtavidha Pariksha also. The clinical stages of venous disorders are classified under 6 stages, and in 0 stage there are no visible palpable signs of venous disease, but in class 1 spider veins are present, in class 2 varicose veins. The veins more than 3 mm in diameter are present. In spider veins, the diameter of varicose veins are less than 3 mm. Then in 3rd stage, edema, pigmentation, 4th stage, pigmentation and lipodermatosclerosis. In class 5, healed venous ulcer, and in class 6, active venous ulcers are present. So these are some photographs of patient presenting with spider veins. Slides are not visible, ma'am.
We are not able to see your PPTs.
Okay, now.
Yes, ma'am.
Okay.
Some ad just like.
So these
Now
are
we are
the
able to
photographs.
see.
Yeah, so these are the photographs of patients presenting with spider veins. There is class 2 stage, that is varicose vein. Then you can see class 3 edema, class 4 lipodermatosclerosis, healed venous ulcer and active venous ulcers. And these are the photographs of some complications of varicose vein, that is eczema, dermatitis, lipodermatosclerosis, hemorrhage, thrombophlebitis, and venous ulcer. According to Acharya Sushrita, he also stated that the disease should be treated in initial phase. So, as we have observed that the 6 stages of venous disorders and varicose vein and spider veins are the initial phases of this disease. So, there is necessary to diagnose and to evaluate or to provide a proper treatment to patient in this phase of the disease, so that the disease should be treated and helps to break down the further pathogenesis and further progress of the disease, and so that we can avoid the untoward complication of the disease. If above principle is not followed properly, pathogenesis go to deeper dhatugath structure and it becomes vrikshsadhya or asadhya. In later phase of disease, varicose veins mostly require surgical management to stabilize the patient as well as to improve quality life of patient. But in developing countries, such type of treatment modalities were avoided because of pain, fear, other psychological factors, longer hospitalization, and also economical expenses. So the purpose of present scenario is to prevent further progress of disease in initial condition and to prevent delayed complications like deep venous thrombosis, venous ulcer, edema, etc. With consideration of above facts, there is need of allied health sciences like Ayush system to fulfill above lacunas, especially patients' self-awareness and self-assessment, because in initial phase the disease is asymptomatic most of the time. So patients are not aware of them. So self-awareness is necessary. Then clinical techniques for medical person and substitutes for radiological investigations for varicose vein is also necessary. It will be beneficial to diagnose, palliation, cure, prevention of recurrence of varicose veins. As per modern surgical literature, there are 4 regimen for treatment. That is non-medicinal treatment, where leg elevation, application of soothing agent, compression bandages, and avoidance of etiological factors can be included. In medicinal treatment, there are drugs like calcium dobicelate, diosmin, and hesperidine, which are effective oral medication, but there are limitations. Though they are effective in varicose vein, they are not 100%. They had not 100% cure for the varicose vein. So they are useful only for palliation as well as prevention of recurrence of. In minimal surgical modalities, there is injection therapy with fluidocanal sclerosing agent, but it requires perfect assistance, and the therapy is easy, economical, safe, but for temporary palliation and requires expertise operator with minute observation to prevent ulceration, drug allergy, accuracy in selection of patient. And in further stages of the disease, surgical modalities are required for treatment. In day-to-day practice, endoscopic surgical technique is supreme choice, which was evaluated from other traditional methods like phlebectomy or Trendelenburg operation. Present supreme method needs less operative screening, causes operative tissue destruction and post-operative complication with laser curative outcomes and not in renowned status. Means the common sufferers could not accept such surgical corrections due to unsatisfactory outcomes, highly expensive treatment, non-availability of higher centers in their surroundings. So as per Ayurveda, there are some therapeutic use like Veshtana, Siraved or Jalokaucharan, exercises like Yogasana, Abhyanga or massage, and Basti treatment. So some herbs which are beneficial in treatment of varicose veins like Manjishta, Sariva, Eranda, which helps to relieve pain and act as an anti-inflammatory activity. Punarnama, which reduces the swelling in patients of varicose vein. Local application of Searcher oil and Snuhi oil helps to maximize venous return supply. The resolution of Grathana formation occurs due to Ushna, Tikshna, Sukshma, Vyavahi, Vipasi, and Shonita Sangat Vinnati properties and results in minimizes of Sira cutilar. Great care must be taken to not massage any oil right on the varicose vein, as it would increase pressure on them.
A simple application is sufficient with no pressure being exerted. Some Ayurveda medicines are also effective in case of varicose vein, such as Amalki, Arjuna, Ashwagandha, Brahmi, Guruchi, Gugula, Shatavari, Chandraprabhavati, Nagarjuna Rasa, and Punarnavadi Gugula. Also, Sarivadya Siravilvadi Kashai, Kaishar Gugula, Rasnairandadi Kashai, Punarnavashtak Vatha, also suggested for inflammatory conditions and to relieve pain and swelling. Horse chestnut seed extract is useful to improve circulatory functions. Some exercises like Uttasana, Tadasana, Viparitakarni, Navasana or Naukasana, Shirshasana, Pavanamuktasana, Matsyasana are useful exercises which strengthens the muscles, maintain flow and improves elasticity of vessels. Yoga poses of varicose veins, like simple exercises such as walking, biking, swimming, and extending the legs while sitting on a seat, also help to reduce the engorgement or congestion of blood in the vessels. So avoid too vigorous exercises, and after any exercise requires a short period of relaxation, avoiding bathing in overly cold water. Daily exercise is vital for improving circulation and reducing varicose veins. Inverted yoga poses can be particularly valuable in restoring the normal flow of blood from the leg to the center. In this way, Western bloodletting, therapeutic enema, oil massage or abhyanga, and Ayurveda medicines, and yoga, etc. are some approaches suggested in Ayurveda for the management of varicose veins. There are some lifestyle modifications to prevent the disease pathogenesis and to prevent the recurrence of the disease and to ease the pain of varicose vein. So, though the varicose vein cannot be cured completely, the best course of action is prevention. Some self-care measures that can be helpful in prevention of varicose vein that are avoid crossing the legs while sitting, avoiding tight clothing that constricts the leg, groin or waist, regular exercise, avoiding constipation, low salt diet, high fiber diet, avoiding long periods of sitting or standing and leg elevation at resting period, which can ease the pain and prevent varicose vein from getting worse. Conclusion: after revalidation of described modern treatment modalities and Ayurveda treatment modalities, there is need of integration of Ayurveda and modern approach for early diagnosis, the evaluation of better treatment regimen, prevention of complication and recurrence of the disease for better health quality of the patient. Therefore, in view of my experiences, diagnostic and therapeutic evidence-based modality is the scope for the solution to difficulties faced by health professional and patient to achieve satisfactory and successful outcomes. It is very important that we should focus to modify lifestyle with Ayurveda regimen to achieve disease-free life. Above mentioned integrated vision and mission is useful for worldwide population. Such diagnostic therapeutic evaluation of varicose vein help to improve the condition of varicose vein from non-curable to curable condition, that is from asadhya or krishyasadhya avastha to sadhya. So, thank you very much. Lastly, I express my thanks to Ayush Darpan for giving me an opportunity to share the knowledge, and I also express special thanks to Sheetal ma'am, Naveen Joshi sir, and Madhuri ma'am. I am also thankful to Dr. Anand Kumar Shekokar sir for his constant motivation to me. I am also thankful to my PG scholar for their technical assistance. Lastly, I want to give a suggestion, or I had listened the lecture of Shilpa ma'am, and I agree with her to restore the branch of anesthesiology. So I request all the seniors of working in this branch to great going for the restoration and development of this branch. So thank you very much.
Thank you. Thank you very much, ma'am, for your very informative and wonderful session on varicose vein. You have just focused on your integrated vision and mission. Thank you. Thank you very much, ma'am. Now, I would like to hand over mic to Dr. Kiran Mandekar, ma'am, to carry out further sessions. Dr. Kiran Mandekar, ma'am.
Yes. Thank you, ma'am. I would like to request Dr. Lata Kale, ma'am, to present her topic, the choice of treatment, surgery, or conservative in anorectal disorders in females and pediatric patients. Lata Kale ma'am is a owner of Kale Piles Hospital and Laser Surgery Center, Nagpur. She is MS Shalyatantra. She has completed her KARD fellowship in anorectal surgery from YMT Ayurved Medical College. I would like to welcome ma'am to present her topic. Dr. Lata ma'am.
Hello. Hello. Am I audible?
Yes, ma'am, you are audible.
Okay. Just give me a second. Hello. Okay.
Yes, ma'am. Yeah, you can share your topic.
Yes, ma'am. Screen share करना. Screen share. Yeah, share screen. Ma'am, is my screen visible? Hello? Hello? Ma'am, is my screen visible?
Yes, your screen is visible, ma'am.
Okay. Yes, ma'am.
इसको ये पूरा विजिबल नहीं हो रहा ना? Hello? Ma'am, am I audible? Hello?
Yes, ma'am, you're audible.
Is my screen visible, ma'am?
Yes, it is visible to us. Yes, ma'am.
Okay, ma'am.
Please go ahead.
Yes, ma'am. Good morning, everyone. And good morning to all the dignitaries, all the organizing members. And it's really thanks to all for giving me an opportunity to present here. Today, the topic which I am presenting, it's completely related with my clinical experience. And it is less related with, you can say theoretical, but more related with clinical things. My topic is choice of surgery or conservative management in anorectal disorders in case of females and pediatric patients. Especially, I have taken this topic for females and pediatric patients because they are more prone to these things nowadays. As the small children, they are consuming lots of junk foods and all, and their lifestyle have been changed a lot, and parents are not aware of that. They are facing many anorectal problems, and females are always prone to these diseases because of their change in their lifestyles, due to their change in families habits, and even in pregnancy is a major problem where the patient faces this anorectal problem. So I have taken females and pediatric patients. Ma'am, am I audible? Hello?
Yes, ma'am, you're audible.
As you all know, anorectal disorders are lifestyle disorders and can be frequently come across throughout the life depending upon the lifestyle. Lifestyle, as you know, a lifestyle includes not only the diet but also it is affected by sleep, type of work, timings of meal, and exercise. Any loophole in these parameters can give rise to a common anorectal disorder like fissures, hemorrhoids, fistula, anorectal abscess, pilonidal sinus, anal warts, anal dermatitis, and proctitis. These are some of the diseases which we commonly see in anorectal region. And common causes of these disorders are consumption of spicy and junk foods, irregular timings of meals, low fiber diet, sleep disorders, digestive disorders like APD, IBS, IBD, constipation, irregular bowel habits, lack of exercise, and long-term sedentary work, pregnancy in case of females. Also, another points I want to add that nowadays the lifestyle has become very speedy. That is also a cause, and anxiety is another one of the cause, which is again a cause in constipation and indirectly causing anorectal disorders. As most of the anorectal disorders are lifestyle disorders, they recur even with a small change in lifestyle again and again. Surgery should be avoided as far as possible because surgery cannot be done again and again, but conservative treatment can be given any number of times. So my motto is to prefer conservative treatment wherever possible. That's why I have chosen this topic. But about this fact, doctor has to educate the patient properly and explain them the proper cause of this disease and advise them accordingly. Because if the patient have more pain, he's not willing for medicine sometimes. But when we are the actually decision, we have to make the decision whether the patient can be treated with medicine or he has to go for surgery. If this fact is explained very properly to the patient and if he is assured that he can be treated with the medicine, then he'll definitely prefer the conservative treatment. And that is very important because anorectal region is a very small region and we can't do surgery again and again in such a small area. Cases where the conservative treatments are the good choices. Fissure is a very, very common disorder because constipation, hard motion is a very common problem faced by every person at least once in a month or once in a week. There are two types of fissures. Primary fissure, there is a causes the constipation, and secondary fissures are the causes are like secondary diseases like IBD, IBS. Treatment is treat the root cause and give a long-term result. Chronic fissures where the fissure beds are fibrosed and sentinel tags are large with severe spasm and patient is facing the problem again and again. The frequency of recurring is more, then the choice is surgery. As you all know, fissures with an infected sentinel tag, there is a chance of forming fistula, so surgery is the better choice. This is a picture which I have displayed on my screen. This is a picture of fissure with a swollen sentinel tag. It can be initially treated with medicine. If the patient is not having any infection in this tag, he can be well treated with medicine. But once this kind of tag is infected and it forms a loanal fistula, then we have to go for surgery only. So both options were available with that patient. This is a patient with multiple sentinel tags with a hypertrophied papilla inside the anal canal. This is purely a case of surgery. If this patient is, advise him medicine, it's a time pass for the patient and for us also. It's better to go for surgery. Ma'am, am I audible properly? Hello? Hello? Am I audible?
Yes, madam. Yes,
Okay.
madam, you are audible.
Shall I continue then?
Yes, ma'am. Yes, ma'am.
So this is a picture of hypertrophic papilla, and this is with multiple sentinel tags. This is a purely case of surgery because the patient can have any kind of infection in such tags and he can have fistula, secondary fistulas. So it's better to operate such kind of patients because the patient can face again and again fissures and that can be infected anytime. This is again a case of fissure with infected sentinel tag with formation of fistula with a small abscess cavity. This is purely a case of surgery, and here we can't give the time to the patients and he should be advised immediately for surgery. Another cases where we can take the chance of conservative or surgery are grade 1 and grade 2 internal hemorrhoids. Here also causes constipation, straining, IBD, IBS, pregnancy, lax mucosa, irregular bowel habits, etc. Treatment is treat the root cause and correct the dietary habits. If the hemorrhoids, grade 1 and grade 2 internal hemorrhoids can be well treated with medicine. There are lots of medicine which can treat grade 1 and grade 2 internal hemorrhoids. In Ayurveda, that Lajjalu Ghana is acts good on grade 1, grade 2 hemorrhoid if given in good proper dose. Grade 3 and grade 4 prolapsed hemorrhoids, these are the cases where surgery is the only choice. But if the patient is old age and he can't operate, then we can go for medicine or only laser therapy in grade 3 hemorrhoids. But in case of grade 4 prolapsed hemorrhoids, surgery is the only choice. If the patient is fit, even in old age, he can be operated. This is a case of grade 2 internal hemorrhoids where laser can be done or conservative treatment can be done. Thrombose hemorrhoid with anal hematoma. Cause is constipation or straining or hard motion. Treatment root cause should be treated and dietary habits should be corrected. Anti-inflammatory gives a very good response in such cases. Thrombosed strangulated hemorrhoid. Surgery is the only choice because here the thrombosis cannot be relieved and strangulation, if not relieved, there can be a chance of gangrene. So it's better to go for surgery. Mucosal prolapse or partial rectal prolapse. Cause is congenital anomaly, excessive straining or constipation. Treatment, Kashaya Drava Avgahan, Pichudharan, sphincter exercises. These are conservative exercises along with medicine we can give to the patient. And in case of complete rectal prolapse, it's a case of surgery. Surgery is the only choice. Anorectal sinuses. Causes, personal hygiene and crept infections. Conservative management with paramedical procedures like Char Sutra on OPD basis can be done. Surgery is a choice depending on the situations. Pilonidal sinus. Cause is negative pressure in the buttock cleft with hairy region. Treatment is Char Sutra on OPD basis, and surgery is a choice depending on the situation of the patient. Exclusively surgical procedures are conditions are anorectal abscess. Abscesses are the conditions where surgery is the only choice because excision and drainage is must in case of abscess. There is no choice. There is no other choice. Anorectal fistulas. Anorectal fistula should be operated because they can't be completely treated with medicine only. Char Sutra can be used wherever possible. But Char Sutra are somewhat painful. If fistulectomy is possible, we should do fistulectomy with sparing the sphincters. Sphincters sparing is very important in fistula surgery because many patients are afraid of the sphincter cutting and that loss of sphincter control after the surgery. So we should explain them and convince them that it's not every time, it doesn't happens every time. Only 0.1% cases are like that, and fistulas can be operated well. We have to convince the patient for that. Anorectal polyps. If the polyps are bigger and they are bleeding again and again, they have to be operated. But if they are small, we can conservatively manage it. Anal warts, they are also a condition of operative procedures. But if the small warts are there, I have seen in my OPD, it was my, you can say, I have just taken a trial on some patients. They were having small warts. Char has given me a good results. Initially, the patient have some ulcerations over the skin, but the anal warts, they slough out and the patient have a normal skin. That I have got a very good results in 2 or 3 patients, female patients who were not ready for surgery. Rectal prolapse, it's a complete case of surgery. Here, there are different types of surgery in rectal prolapse depending upon the grade of prolapse. These are some of the, these are some of the pictures which I have taken with endoscopy machine which I am having. I used to do endoscopy, rectoendoscopy of my patients, which gives me a very good view of the disease. This is a patient with grade 1, grade 2 internal hemorrhoids with a grade 3 hemorrhoid at 7 o'clock and fissure with sentinel tag at 12 o'clock. This patient I have treated well with medicine. The grade 3 hemorrhoid reduced to grade 2 and other hemorrhoids responded well with the medicine, and fissure was very well responded with the medicine. That tag also reduced and the patient is very happy. He's now since 1 year he's good. This is another picture which I have displayed on my screen. This is the patient with grade 1 hemorrhoids with lax mucosa with fissure with sentinel tag. This is another case where conservative management has been carried out in our hospital. This is a patient with multiple sentinel tags, with papillas, with hemorrhoids and with bleeding. The patient was having a long history of fissure and recurrent bleeding. This was the case of surgery. We have operated this patient and he's well now. This is another case where the patient was patient's age was 80, but patient was very confident and he himself was ready for the surgery because the case was likely for surgery only. She was having severe anal spasm, bleeding and recurrent bleeding and severe pain. Constipation was as usual because of her age, and because of the patient's willingness, I operated this patient recently and she is very happy. Surgery was carried well. I operated this patient under the critical care hospital under the observation of cardiologists and physicians. They were present in the OT and I keep the patient for 1 day in ICU for preventing her from any side effects of the anesthesia and keep a watch on the patient. Thanks. Thank you. Thank you all for listening me and giving me a chance. That's all from my side. Thank you all. Thanks,
Thank you so much, Dr. Lata Kale, ma'am. It was a wonderful session. You have very well explained on the different anorectal conditions and specifically the fissures and the hemorrhoids. Thank you so much for the presentation.
Thank you, ma'am. Thank you.
Yeah, thanks. Okay. So I would like to request Dr. Foram Joshi, ma'am, to present her next topic. Her topic for the presentation is briefing of Shashti Upakram in clinical practice. She is assistant professor Shalatantra Ayurved College, Nadiad, Gujarat.
वो बंद करना पड़ेगा.
Yeah, Kale ma'am, you can please mute yourself.
Yes, ma'am. Yes, ma'am. I'm muted.
Stop screen sharing.
Yes,
so
ma'am.
that Forum ma'am can share her screen. Yeah, Dr. Forum ma'am is a assistant professor, Department of Shalyatantra, Nadiad, Gujarat. She has completed her MS Shalyatantra from IPGT RA GAU Jamnagar in October 2016. She is a PhD Shalyatantra from IPGT RA Government Ayurved College, Jamnagar, July 2021. She has immense work experience in clinical as well as in academics. Yes, Dr. Forum Joshi ma'am, you can please proceed with your topic presentation.
Yeah, surely, ma'am. Is my slide visible, ma'am?
Yes, yes, your slide is visible.
Yes, and am I audible? Yes. Okay.
Yes, you are audible to us. Please start screen sharing. Yeah, please.
With my
thank you.
bowing hat to with my is I am visible, madam?
Yes, you are. Yes.
Am I visible?
Yes. You can put on the screen PPT presentation mode, madam.
Okay.
Slideshare mode.
Is it now?
Yes.
So very well, very good afternoon to everyone, and I will start my presentation with my bowing head to all the respected Varshneshwar, the Lord Dhanvantari, and the live Sushruta of this event. And I would like to also thank my guide also. I am speaking about briefing of Sasti Upakrama in clinical practice. That was from one of this was my PhD topic. So that's why I'm tweaking. Why we are discussing today? It is just because the need of the discussion is we are having the discussion because we are having the lots of the collection of the trends and classical references in our books and the local applications also. But what happens that we fail somewhere and our results goes negative, and some people in the other paths also criticize us that these are the quacks and these are the jhola chap doctors, etc. But what we are missing that is needed to be discussed first. What we are missing, the diagnostic methodologies, the advances in the medicaments we are lacking, or the applications of the upakrama in the clinical practice, what we are lacking. So after reading lots of the survey studies and research works, and I came to conclusion after also reading with the Samhita, I came to know that what we are missing is there is a weightage of diagnostic methodologies and applications of upkramas as well. Why I am not stating the medicaments? Just because if the medicament advancement would have that much of the impact, then modern medicaments or modern things have excelled in the wound healing, and they may not refer to us. But what we have reached up to right now in the our Ayurveda practices and the different sectors, that after some limit they refer it to Ayurveda sectors. Why so? Because they also inside believe that there is something and they respect other paths also. In the treatises, we see that there are references of wound management in the Charaka Samhita, Sushruta Samhita, and Ashtanga Hridaya, all three treatises speaking about differently for the Vrana management. What is that difference? We are having in the same Samhita, that is in Sushruta Samhita, we are having Saptokrama also and Shashti Upakrama also. But when we see properly, the 60 Upakramas are the magnifying view of the 7 Upakramas. And these are the my understanding that I have seen that what are the Vimalapan, Ausechan, Upanaha, Patana, Shodhana, Ropan, and Vaikritapaham. And then I have applied in my clinical practice also, and my many other students are also practicing that. I have learned it from the Samhitas and after looking so many stalwart practitioners. So this is the gross plan of wound management that is given in the Samhita, and what we consider in current clinical practices. We will see some of the cases after looking towards the selection of the patients, on which base we should select the patients. These are the levels of the wounds to be treated, right? That once we start having the diabetic foot clinic or some kind of the podiatry clinic in Ayurveda, then we should not take all the cases. But firstly, we need to see that what are our limitations, what are the patients and other pathos limitations. So see the level of wounds to be treated, then comorbidities that patients are having already, neurovascular support to the wounded area, and the food and regimen. That is very, very much important, and that is having more than 25% roles in that food and regimen in the clinical practice. These are the checklist leads that we can take from the upakramas, that okay, this needed to be done in some of the cases, and which kind of cases I will discuss. For the first time, that is apatarpan, that is given very first in the Samhita and the Chikitsa Sthana. What happens that this was the case where what we treated in IPGT in RA Jamnagar. What happened that this patient was a case of Santarpan-janya prameha, and that developed diabetic foot ulcer with the Wagner grade classification number 3, that is grade 3, that is osteomyelitis was already established in that case. And when she went to the modern practitioner, he prescribed for the amputation, but as she was not convinced, she reached to us, and we applied some of the upakrama, and the results you can see that. Which upkrama we applied were apatarpan, lekhan, kashayvarti, tel, and ahar. I again emphasize ahar. Why? Because in this case, apatarpan and ahar both are given. In the initial phase, we prescribed the patient apatarpan, and what we prescribed was apatarpan. It's abhojan. Abhojan, that means it doesn't mean that the complete cessation, but whatever the patient is consuming by unethical practice, and whatever it was harming to that patient, we removed that everything. Okay, and then after, when applying ahar, we are giving the pathya aharas, that I will show you in the next further slides. In alep and parishek, exclusively in the acute cases where we require this two particular upakramas while considering to vrana. And also parishek is also being used in the cases of the rehabilitation cases also, that we receive from after surgery, post-operative cases, or we are receive the cases in which there are external fixations are done, and then after we treating those cases of the fractures with the parishek treatment also. So parishek is being given in the both conditions. In Sushruta Samhita, Sushruta states that Alepa Adya Upram also and Aptarpan Adya Upram also. So while considering the phases of the treatment and phases and the cases, when we compare, it is very much clearly stated that Alep should be considered in the Sadhyavrana condition, and Aptarpan should be considered first in the cases of the Nijavrana considerations. This was the case we received with burns, superficial burn it was, and we applied some of the upakramas, and this was the result. The third image is the showing the result of that case. Then Lekhana Upakrama we started in a case, that was a case of diabetic foot ulcer, which was already having a raised amputation previously, but then after again he developed an ulcer. It is already stated by Acharya that Lekhan is indicated in which kind of particular wounds, that is Diryamanan Puna Puna. That means recurrent ulcers. Recurrent ulcers, and with the hard margins, fibrous tissues which are having. By seeing the wound in the very first day, it was looking like it will not get healed, but this get healed very, very good. It healed in 3 months of duration. Again, there was another case. In this case, we can see there is necrosis also there. But in this case also, we applied Lekhan, just the mechanical debridement we did. And then after we applied leeches in this case, and then after we can see the result. These were the upakramas that were taken in the consideration, and we applied that. This case got healed within the duration of 2 months. Then again, the concept of Shonita Mokshana, that is Acharya has clearly stated Vedana Upshaman and Pakshamayartha. This was the case with which we received with the infection and insect bite. So that patient came to us with this kind of images, that was the case, and we applied leech. As Sheetal madam has completed all the narrations about the reason and indications about leech therapy. I have my little experience. What happened that when we applied this leech, very soon after the removal of the leech, it got very dry and it died suddenly. So we found that this patient, whoever was having this wound, that was having some kind of poisonous experience, and then after, with the application of avachrunan and other rakta mokshan etc. upakrama, we got the wound healing within the 3 months of duration. This was the exclusive case of Char Karma, and we see the progress that on the day one patient when received was having the venous ulcer with excessive slough. Then after we applied Char Karma, and then after we can see that wound was promoting towards the healing. This was the case of Pandu Karma in the pediatric age group patient who was having blisters of 2 years of history. See, this was not the burns case. If this would be a burns case, then we may have applied another upakarma. But this was the case of blisters. So what happened that that patient was having it from 2 years of the history. In Ayurveda, we consider it as a vispota. So we started internal medicament along with the local treatment. And then after we see the second image, that patient came after 15 days and the wound converted to that. And after another 15 days, that after applying Pandu Karma with the Haritaki Phal and Ajakshir. Haritaki dry fruit and Ajakshir, we applied it over that. It was also procured from our own botanical garden and the local market source. We get the Ajakshir and then we applied it. And just after the 15 days, the image, the third image that is showing Pandu Karma. In Sarpi Upakrama, this was the case we have received in IPGT and RA with the patient was already amputated in another leg, and in this right leg also he was amputated from the mid-stalk tibia, and then he was again advised for the amputation. But what happened that he was having the excessive neuritis and was having excessive pain and burning. So what happened that whenever we were applying the medicines, the patient was screaming in. And also he was having the big history of smoking and alcohol also. So we can understand that it was a clear case of the peripheral arterial occlusive disease. And then after the wound was arised, so we applied Jatyadhigrit and Yashtimadhugrit over that. And we can see the images. This case was also got healed in 45 days. Ausadan, Tel and Bandhan. This case was we received with the history of trauma due to an accident. And we can see that the internal anatomy is already exposed. So what happened that in this condition we applied the Avasadan Karma, where when there was hypergranulation in that tissues, by applying the oils and other things, the wound was hypergranulated. And then what we did is Avasadan Karma, because Utsanna Mridu Mansanam. And that is the clear-cut indication Acharya has given for the Avasadan Karma. So Char application was done on that wound, and we use that Tunkan and NS solution. We can also use distilled water. We can also use warm water with that, and the properly prepared a solution of Tunkana. We applied it on that, and then after we received the results as we are seeing in the images. Kashay, Lekhan, Raktamokshan, Tel, Bandhan, Ahar, and Dhupana. This was the case we received on the very samely, if I say that before 3 years in IPGT and RA. And after applying a Kashay wash with Panchavalkala, Lekhan with some kind of powder drug, that is Haritaki. Then after Leech application and then Apamarga Kshar Tel application, we received this kind of progress within 60 days. So that wound was also completely healed. This is the axillematous wound we can see. In the case of Vran Krumi, this was the exclusive case of anal myiasis we can see. And these were the maggots we removed from the piles. This was the case which was having the history of alcohol. And whenever he was developing pain, he was just taking alcohol and the pain was subsiding. He didn't consulted anyone. And also he admitted the history that there was a poor sanitization in the village area, tribal area. And what happened that just after the defecation, the patient was using stones and grass to clean his local parts. And by that, the insects were administered through larvas. We removed the krimi and then we did hemorrhoidectomy, and you can see the images. This was the reference I got from Sushruta Samhita, Makshika Vranam Agadya, Nikshipanta Yadakrumin, and this is very beautifully described by Acharya in that. This was an example, and a Kashay Varti, Tel, Autrunan and Bandhan. After amputation, we received this case from the Civil Hospital, Jamnagar, and the case presentation we can see from very first day, whatever it was. And then we treated the case. This case was also got healed in 90 days. These were my assessment criteria, and by comparing this, we were analyzing the cases whether they are falling into the study, whether they are not falling into the study. While I was sticking to my dissertation, thesis topic, I was exclusively taking the diabetic foot ulcers, and I was enrolling them. Beyond those cases, what I have shown, the varicose ulcer and the meiosis cases, they were not included in the thesis, but they were seen by me and my juniors and my colleagues at my workplace Nadiad and also at Jamnagar. These are the Patya Ahar Acharya has given, and from which whatever we are practicing is according to patient's diet. If the patient is vegetarian, then accordingly give to that. If the patient is non-vegetarian, then give according to that. And by modifying that diet, we give to the patient, and along with that, we assess the case. These apatyas are described by Acharya, and what we remove from the patient's history is very much important, that whatever the harmful substances are there, if the patient is consuming, then only remove it. These are the cautions, just because this is given by acharyas, but what are the purposes, that I could get understanding that this is for balakshaya, ruja and upadrava, that if the patient is consuming that, then it may, and then he or she may develop. And that's why what we do in our practice is we exclusively, whenever the patient comes to us, we hospitalize, and after hospitalization we apply the treatment principles. And this is the treatment principle given by Acharya Sushruta in Sushruta Samhita also, just because wound healing is not just an application of any kind of local medicament and just bandage and the patient let to go. If we are practicing like that, wound healing is not going to heal. And what is needed to be focused is what are the regimens are given by the Acharya and what are the scientific interpretation and inclusions that should be done. Concluding it, what I need to say is Chaturvi Sadhyate, Chaturvi Vaidyaha, Atura, Paricharaka, Aushadha, iti artha. What is the important? All the four are important, but Vaidya is main in this consideration, because whatever we are deciding for the patients will lead to our pathy and also will lead to the heights to our pathy. This is the only thumb rule, and this is highlighted mantravat samprayoktavyo, just because whenever we are following our rituals or any kind of regimen, we do not question on that. So when the Samhita is giving us, it is our understanding that is needed to be developed, and we need to search again and again. But whenever it is questioned to us, it is our responsibility to answer them. So that's why I understood this, and I give my sincere acknowledgement to all these stalwart speakers. And after those, I am just like a star. I am just like a lamp in presence of all the stars and sun-like stalwart speakers. Thank you very much.
Thank you so much, ma'am. It was a really wonderful session, and it was an outstanding efforts that you have shown to us for implementation of Shashti Upakrama for Dushtabran. So thanks to you. Hello, am I audible?
Yes.
Okay, thank you so much, ma'am. Thank you.
Yeah, thank you.
Yeah. Now I would like to welcome Dr. Sarita Meena, ma'am. Sarita Meena, ma'am, you there with me?
Hello, yes, ma'am.
Yes. The topic of presentation of Sarita Meena, ma'am, is local anesthesia in anorectal disorders. She is a Sanyaharan specialist in All India Institute of Ayurveda, New Delhi. She has achieved her MD anesthesia from Institute of Medical Sciences, BHU, Varanasi in 2018. She passed with the first division. She is also a PhD scholar at Varanasi Institute of Medical Sciences. I would like to tell you, ma'am, please share your presentation. Thank you so much.
Hello.
Yes, ma'am.
Hello. I am
Yes,
audible,
ma'am.
ma'am.
Yes. Yes, you are audible
Is
and
my
your
slide
slides are
is
also
visible?
visible. Yes, ma'am. Your slides are visible to us.
Okay, thank you,
Please
ma'am.
go ahead. Yeah.
Okay, thank you, ma'am. Good morning, respected chairperson, Vashni sir, ma'am, Professor D.N. Pandey sir, and all speakers, Chetan Meena, Sangharan specialist from All India Institute of Ayurveda, New Delhi. I will present on the topic of local anesthesia in anorectal cases. Now, introduction. Ayurvedic surgery, major part is Char hemorrhoid, anorectal surgery has a dense sensory nerve supply. Deep anesthesia for anorectal persons can be achieved using different form of anesthesia, including general anesthesia, regional anesthesia, local anesthesia. Sometimes local anesthesia at the time. Anesthesia, general anesthesia, but they have some limitation or advantages. Advantages of local anesthesia is that local anesthesia is cheap, comparatively safe, can be given respiratory compromised patient, not require much attention on vital parameter like level of consciousness. Day care surgery can be done. इससे पेशेंट को एडमिट होने पेशेंट को हम उसी दिन डिस्चार्ज कर देते हैं. अननेसेसरी इन्वेस्टिगेशन की भी जरूरत नहीं होती है. Limitations of local anesthesia is that the chances of spread of infection, area above pectoral line is not anesthetized, anal canal not fully relaxed due to spasm, surgery is difficult. Local anesthesia की जो limits overcome करने के लिए spinal anesthesia की जरूरत होती है. पर भी advantages और limitations होती है. Advantages है it gives more relaxation than local anesthesia and general anesthesia without undesirable depression or respiratory system, cardiovascular system, require minimal patient cooperation, anesthetize whole anal canal. But limitations of spinal anesthesia is that patient refusal, infection at local site, patient on anticoagulant, raised intracranial pressure, severe hypovolemia, sometimes they may be seen spine deformity. Now, general anesthesia advantage can be given in uncooperative patient with good relaxation. ये mostly बच्चों में होता है क्योंकि जो छोटे बच्चे होते हैं उनको एनोरेक्टल सर्जरी भी होती है तो वो कॉपरेट नहीं करते हैं तो जनरल एनेस्थीसिया देना पड़ता है. Limitations of general anesthesia avoided systemically compromised patients. Now, local anesthesia. Local anesthesia is a reversible loss of sensory perception, especially of pain in a localized area of the body. Now, classification of local anesthetics. Classification on the duration of action and potency. Chloroprocaine, procaine are short duration, low potency. Lignocaine is a intermediate duration and potency. Bupropion is a long duration and high potency. Now, on the basis of chemical structure classification of local anesthesia, amino esters and amino amides. Amino esters have high allergic reaction, but amino amides have a low incidence of allergic reaction. Now, mechanism of action of local anesthetics. Drug is in ionized form, penetrate axonal membrane, then get ionized and bind to receptor situated in sodium channel, thus blocking channel and prevent differentiation and stop action potential. Now about lignocaine. Lignocaine is a drug, anesthetic drug, which we used commonly. Concentration we used for local anesthesia 4% and 10%, for nerve block, epidural infiltration block 1%, 2%, for urethral procedure or per rectal examination as a jelly 2%, for spinal anesthesia 5%, IV regional anesthesia 0.5%. Metabolism of lignocaine in liver excreted by kidney and half-life is 1.6 hours. Duration of effect of lignocaine without adrenaline is 45 to 60 minutes per kg. With adrenaline, lignocaine is 2.3 hours because it delay absorption of anesthetic drug. Dose is 7 mg per kg. Now about bupivacaine. Bupivacaine is 4 times more potent than lignocaine, but highly cardiotoxic. Metabolism in duration of action of bupivacaine without adrenaline 2 to 3 hours per kg, with adrenaline 3 to 5 hours, and dose is 3 mg per kg. Now concentration of bupivacaine for nerve block 0.5%, epidural 0.1 to 5 to 0.5% for spinal anesthesia. Now local anesthetics with adrenaline, sensory and motor block, daily absorption of local anesthetic drug, and to prolong and enhance its anesthetic effect, it causes vasoconstriction, therefore less bleeding at site of absorption. But lignocaine with adrenaline should not use for spina, because they are end arteries, and so may cause damaged tissue and gangrene. Inhalation agent, especially halothane, which sensitize myocardium. Now systemic effect and toxicity. Central nervous system, lignocaine is a more sensitive than bupivacaine for central nervous system. Neurologic symptoms we can see circummoral numbness, dizziness, tongue paresthesis, visual auditory disturbance, muscle twitching, tremors, convulsion, tongue tingling. Management is for that adequate ventilation or oxygenation. If convulsion present, diazepam and thiopentone or propofol 20 to 50 mg may be given. In cardiovascular system, all anesthetic have a negative inotropic action on myocardium, so very high dose may block conduction of SA node or bradycardia or ventricular arrhythmia. Hypotension may cause cardiac arrest. For management of it, CPR with adrenaline, and choice of drug for ventricular tachycardia due to bupivacaine is bradykinin, but phenytoin is alternative. Amiodarone and lignocaine may be given. If all drugs are not responsive, then we should use a defibrillation. Allergic reaction, local anesthetics, esters group are have more allergic reaction than amide group because of presence of methylparaben. Now local anesthetic of local anesthesia, local toxicity of local anesthesia, neurotoxicity when we directly use in nerve, cardiac venous with lignocaine if used with a continuous spinal catheter, myotoxins when direct inject into muscle. The conclusion is many surgery in anorectal region can be performed under local anesthesia, and if required, its effect can be augmented with use of IV sedation. During procedure, local anesthesia complication like anorectal spasm, vasovagal shock को मैनेज करने के लिए एनेस्थेटिक्स का प्रेजेंट होना भी बहुत जरूरी होता है, इसलिए मैं संज्ञान रेस्टोरेशन के बारे में भी कुछ कहना चाहूंगी. संज्ञान एक ऐसी ब्रांच है जिसकी हमारे अष्टांग आयुर्वेद में कहीं ना कहीं जरूरत होती है. हेलो मैम, आई एम ऑडिबल?
Yes, ma'am, you're audible. Yes. Okay, yes, you're audible, ma'am.
संज्ञान एक ओके मैम. संज्ञान एक ऐसी ब्रांच है जिसकी हमारे अष्टांग आयुर्वेद में कहीं ना कहीं जरूरत होती है, जैसे कि शल्य तंत्र में क्षार सूत्र, क्षार कर्म, कोई भी मेजर माइनर प्रोसीजर हो बिना संज्ञान के पॉसिबल नहीं है. Sometimes during procedure, shock may be faced. For its management, संज्ञान will be required. शलाक के तंत्र, कुमार व्रत, प्रसूति, पंचकर्म के कॉम्प्लिकेशन, इन सब में भी संज्ञान की जरूरत पड़ती है. क्योंकि मैंने अभी ही ऑल इंडिया इंस्टीट्यूट ऑफ आयुर्वेदा में अभी ज्वाइन किया है और मैंने स्टूडेंट्स का जो फीडबैक लिया, यहाँ पहले आयुर्वेदिक एनेस्थेटिस्ट नहीं थे, जो मॉडर्न के एनेस्थेटिस्ट आते थे वो उनकी वजह से उनको दिक्कतें होती थी. दिक्कतें मतलब जैसे जो स्टूडेंट आते थे उन्हें एक्सपोजर चाहिए होता था, और जो एनेस्थेटिस्ट आते थे वो 1-2 ओटी के लिए वो आना पसंद नहीं करते थे, और उनको कम से कम 5-6 ओटी होनी चाहिए, और आते थे और फिर उन्हें जल्दी ही जाने का मतलब वो कहते थे कि उन्हें केस पहले से ले रखा है तो उन्हें जल्दी जाना होता था. इस वजह से स्टूडेंट का एक्सपोजर नहीं हो पाता था, और कभी कभी पेशेंट टेबल पे आके भी कैंसिल करना होता था क्योंकि उनका प्रॉपर प्री एनेस्थेटिक चेकअप नहीं हो पाता था, और पोस्ट ऑपरेटिव कॉम्प्लिकेशन अगर हो गया तो मॉडर्न के एनेस्थेटिस्ट नहीं आते थे. तो इन समस्याओं को ओवरकम करने के लिए और हमारी आयुर्वेद की धन्वंतरी शाखा के विकास के लिए संज्ञारण का रजिस्ट्रेशन होना बहुत जरूरी है। थैंक यू।
Thank you, ma'am. Thank you, Sarita ma'am. It was very wonderful presentation. Yes, I would like to welcome Dr. Smita Mohol ma'am. More ma'am. Dr. Smita Mohore ma'am is a BA-MS MS Shalya Tantra from ASS Ayurved College Nashik. She is currently pursuing PhD in Shalya Tantra from Tilak Ayurved Mahavidyalaya Pune. She is a HOD in Shalya Tantra from in Ashtang Ayurved College Pune. She is having a specification of for treating patients of surgical disorders by using Ayurvedic principles and therapies. Her topic of presentation for today's webinar is assessment of comparative treatment protocol in management of osteoarthritis knee with special reference to Janu Shul. Smita ma'am, you there with me?
Yeah. Good afternoon.
Yeah.
Hope I am
Yes.
audible and my screen is visible.
Yes, ma'am. You are audible and visible to us. Please present your topic, ma'am. Thank you. Thank you so much.
Thank you. Good afternoon, the respected dais and all my dear lady surgeon friends. A very happy V-Day to we all. This event is a special feast and gift to all of us on this occasion. Firstly, I pay my respects to my honorable guide, Dr. A. Avsar sir, who gave me the confidence to practice surgery as well as the orthopedics. I also pay my homage to Dr. Premavati Tiwari ma'am for her tireless efforts in the field of clinical surgery. Now I'll move on to my presentation. Om Dhanvantaraye Namaha. Myself, Dr. Smita Mohole. I'm not considering I have completed my PhD from Tilak Ayurved College in 2018. Right now I am HOD Shalya Tantra in Ashtanga Ayurved College, Pune. My topic for PhD as well as today's presentation is assessment of comparative treatment protocol in the management of Janu Shul with special reference to osteoarthritis knee. Now, why knee joint? As we all know that knee joint is the most weight-bearing joint, prone for age-related degeneration and is most susceptible for trauma. And yes, pain in knee is the penalty for erect posture to human being. As we all know, the theoretical aspect of osteoarthritis, I'll not go in the details, but I'll directly jump to the knee management because it is the management is the topic of research in my current study. As we all know that modern medicine has NSAIDs, steroids as treatment for osteoarthritis knee, but the relief is very short lasting with lots of fatal side effects as we all know of the NSAIDs and steroids. And if there is no relief from the conservative treatment, surgeries like TKR, total knee replacements, are advised, which are very expensive and with their own limitations. Then what can be the relief? Yes, Ayurveda remains the hope. Ayurvedopadesheshu Hidaya Paramadara. So my purpose of today's study is to find out a treatment protocol in the management of Janu Shul in osteoarthritis knee, which should be affordable to the patient, non-toxic, easy for administration, long-lasting, effective, and safe. Aim of the study is assessment of comparative treatment protocol in the management of Janu Shul with special reference to osteoarthritis knee. And the objectives are to bring down the morbidity due to Janu Shul, to maintain the routine activities of patients symptom-free, to slow down the progress of the disease, and to postpone the surgical intervention in cases of severe osteoarthritis. Osteoarthritis knee can be compared very well with Janu Shul or Janu Viddhata as per Ayurveda. In the current clinical study, the material used in the treatment modalities were as follows: capsule pyrox, that is pyroxicam 20 mg, Tiktakshira Basti, which included Guduchi Kshirapaka with honey, Goghrita, and Tilataila, and Nirgunti Patra Potali, which comprised of Nirgunta Patra along with Tilataila. In methods, the patients were divided into three groups, group A, B, and C. Group A comprised patients who were treated with capsule paroxicam 20 mg OD. B group was of Nirgundi-Patra Potali swathe alone, and C patients were treated with Nirgunda-Patra Potali swathe along with Tiktakshira Basti. All these three protocols were advised for a week, and follow-up was for 12 months. The sample size was derived from the following formula, which came out to be 147, which was rounded to 150, and the sample size was divided equally into 3 groups, 50 in each. Randomization of the sample was done. The inclusion criteria was pain in the knee joint, restriction of movement of the joint, varus deformity due to pain if present, crepitation in the knee, and the exclusion criteria was history of fracture of any bone in the joint and knee pain due to systemic conditions like rheumatoid arthritis, gout, tuberculosis of the joint. Investigations for inclusion of patients were X-ray of the affected knee joint epilateral view, bone mineral densitometry, that is BMD, hemogram with ESR, RA factor, and serum uric acid. Some SOPs were followed. SOP for Nirgundi Patra Potali was fresh leaves of Nirgundi plant were cut into small pieces and fried in a saucepan over a gentle fire in Tila Taila, which were divided into 2 equal parts to form 2 boluses. Boluses were heated over a gentle fire for a few minutes, and the first bolus was applied on the affected knee of the patient at a comfortable temperature and gently massaged. The procedure was repeated with the second bolus when the first bolus lost its thermal energy. This procedure was repeated for 15 to 20 minutes or more till profuse perspiration appeared, and such procedure was repeated daily for a week. The patients who were treated with Tiktakshira Basti were given Tiktakshira Basti made up of Guduchit Shira Paka, which was taken 60 ml, along with 30 ml of Gogrita, 30 ml of honey, 30 ml of Tila Taila, and this mixture was infused per rectal at a very slow rate. The procedure was repeated daily for a week. Time of Basti was every morning on full stomach, preceded by Kati Abhyanga. Laghu Bhojan and milk products were advised as Samsarjana Krama. The patients who were treated with capsule paroxicam were given 20 mg of paroxicam capsule once daily for a week. The assessment parameters were relief from the pain in the knee joint, correcting in the varus deformity if any, and relief from the restriction of the movement of the knee. The data was assessed and evaluated as per the Cincinnati knee rating system. The data was statistically analyzed based on the Z, that is a Wilcoxon assigned rank test, the F test, that is ANOVA test, and the simplest to understand for we people was percent change test. Now we'll see the observations and results after completion of the study. Group A gave maximum score after 1 week of consuming medicine, which continued for around 28 to 35 days and then started coming down. In severe osteoarthritis, it further came down after 7 to 8 months. In 80% of the patients, the symptoms were back with the original score. In Group B, optimum score was seen around 14th week. 2 score rise in almost 80% of the patients remained till end. If more than 2 score rise, it came down by 1 after 7 months, and that was seen in 5% of the patients. In Group C, 75% of the patients had a score rise of 3 and above after 21 days, which remained constant for 3 to 4 months and then came down by maximum 1 score. Thus, it can be observed from the data that the Group C, which was patients treated with Tiktakshira Basti along with Nirgundi Patra Potali swathe, was affordable, non-toxic, easy for administration, long-lasting, effective, and safe, which proved which satisfied the purpose of my study. Now let us come to the interesting part of discussion. First, we'll see why Basti Chikitsa. As we all know that Asthidhara Kala is Purishdhara Kala. Hence, Purishdhara Kala route is the best route to treat the Asthidhara Kala. Now, why Tiktakshira Basti? Here we'll go in basics of Ayurveda and we'll consider the Ashraya-Ashrayi relation. As we all know that doshas are the Ashrayi, that is contains, and the dhatus are the Ashraya, that means they are the containers. And when we consider Asthi Dhatu, it is closely related to Vata dosha. But the irony is Vayu Vriddhi leads to Asthi Kshaya, and this Asthi Kshaya leads to pain in the bones. So what we need is, in Asthi Kshaya, lubrication, that is use of Snigdha Dravya, is a key point. But If we use the Snigdha Dravya alone, it will make the bone soft, and hence we need Snigdhata, which will induce rigidity and not softening of the bone. Thus, Medogata Sneha should be acted upon by Ushnatva and Kharatva, and hence Tiktakshir is the best choice, as it contains ghee, milk and oil, which adds to the Snigdhata. Ushnata, as it is a Kshira Pakalpana. There is Kharatva with Kharagunatmak and Tiktarasatmak Guruchi. Also, the Kshira in Tiktakshira Basti is considered to be the best dravya in nourishing the Asthi Dhatu. It counters the Rukshatva and sclerosing effects on the bone, thus increases the Shleshak Shleshma in the joint, and thus allows the joint to move freely without any restriction. Guruchi is Tikta, Ushna and Labhu. It is Vata Shamak as well as Rasayana. That is a good rejuvenator. Honey has the unique property of Chedana along with Sandhankar. Gogrita is very effective in Vata Prashamana and also in the diseases due to toxins. Tila Taila, it possesses the properties like Tikshana, that means it penetrates deep into the tissues. It is Vyavayi, that is spreading throughout the body very fast. Sukshma, that is capable of entering into even minute pores, and with appropriate processing, it can cure many diseases. Now we'll see the role of Madhu as per the modern pharmacology. As Madhu contains formic acid, it irritates and stimulates local nervous plexus. Parasympathetic nervous system increases overall degree of activity of GI tract, leading to increased peristalsis and relaxing sphincters, leading to rapid propulsion of contents, and hence the toxins present in the body are removed very fast. Also, Meda Dhatu, mainly the Medokata Sneha, when acted upon by Kharatva and Ushnatva, forms Tarunasti, which is the lead in osteoarthritis. Now we'll see the probable mode of action of Basti after food and fat digestion. It's very interesting. Tiktakshira Basti comprises of fat portion, but as we know that there is no digestion, there is no fat digestion taking place in the large intestine. Hence, it needs to take place in small intestine. After consumption of food, there arises gastroileal reflex, which relaxes ileocecal sphincter, and hence the contents enters in the small intestine, where enzymes and bile missiles get digested, and hence the fat digestion is also taken place over there. The Sneha in the Basti facilitates the drug absorption, and the left lateral position for Tiktakshira Basti infusion gives unobstructed proper passage of Basti Dravya to reach up to the cecum. Now we'll see the interpretation of mode of action of Basti as per modern physiology. Lower rectum is drained by lower and middle hemorrhoidal vein, which bypasses the liver, avoiding the hepatic first pass effect, exerting systemic effect prior to liver metabolism, and hence hastening the action. In nutshell, we'll see the advantages of rectal route. It possesses limited absorption in the upper GIT, useful in the medicines which are unstable to proteolytic enzymes, exhibit a high hepatic first pass effect, does not cause irritation to the gastric mucosa. Drugs which need high doses can also be given by this route, and useful in medicines which cannot easily be formulated in oral solid dosage forms. Also, rectal region is drained by lymphatic circulation, which increases systemic absorption of the lipophilic drugs. Also, rectal epithelium is made up of columnar or cuboidal epithelium and goblet cells similar to upper GI tract, giving rise to comparable abilities to absorb the drugs. Now we'll see why Svedana. The conditions which cause severe stambha as well as sankocha are well treated with Svedana. The pain in Pada, Janu, Uru, Jangha is best treated with Svedana. And Nirgundi in it is a best Vedanastapak dravya. In short, we'll see the probable mode of action of Patrapinda Sweda. Raising the skin temperature increases skin permeability, body fluid circulation, blood vessel wall permeability, drug solubility. External heating dilates the penetration pathway in the skin, increases kinetic energy and movements of the particles in the treated area. Local heating of the cutaneous tissues causes increase in subcutaneous blood, increases blood flow, increases metabolic activity, stimulates the neural receptors in the skin or tissues. In short, we'll see the procedural effect of this Vedana. Massage is exceedingly beneficial to the skin as it works directly on the lymphatic system. This system is supplementary to the blood vascular system and offers an alternative route of the return of tissue fluid to the bloodstream. By stimulating lymphatic flow and generating heat through friction, that is rubbing and application of the oils, massage cleanses and vitalizes the body without causing the buildup of toxins. Thus, oil massage quickens the circulation of blood and lymph and dislodges the toxins and increases the vitality of the tissue. As we all know the drug effect of Nirgundi. It is Vatashamak, Vedanasthapak, and mainly very freely available, at least in state of Maharashtra. Thus, Nirgundi Patrapotali Swed along with Tiktakshira Basti increases the pain relief in osteoarthritis knee multiple folds when applied together. Conclusion of my study. On the basis of the thorough study conducted, it can be concluded that capsule pyrox 20 mg OD for a week is a good drug to relieve the symptoms of osteoarthritis knee, but the effect is very short term. Also, the consumption of capsule pyrox for long use can be harmful to the human body. The use of Nirgunti Patrapotali Swed for a week gives encouraging results, but the relief is for moderate scale. The use of Nirgunti Patrapotali Swed along with Tiktakshira Basti is convincingly significant as it fulfills all the purpose of the study. These are some or many references for this study. Thank you. Thank you, Sheetal ma'am, for trusting me to be the part of this jumbo event, and hope I have given some insight to UG and PG students for further research in treatment of orthopedic conditions like osteoarthritis. Last but not the least, as we all are aware of the important 4 A's in surgery: artery forceps, asepsis, antibiotics, and last but not the least, anesthesia. If we have separate syllabus for surgery, why not for our own anesthesia? Hence, on behalf of we all, I strongly support the movement for restoration of Sangyaharan for a post-graduation course, as well as I would like a step ahead to demand for a separate Sangyaharan department in every Ayurvedic colleges. Thank you. Thank you very much.
Thank you, Dr. Smita ma'am. You have elaborated the topic very well. You gave us a detailed information about the complexity of knee joint and the line of treatment from Ayurveda perspective. Thanks a lot. It would be very much grateful for all of us. Thank you so much, ma'am.
Thank you. Thank you very much.
Yes. Now I would welcome Dr. Pooja Srivastav ma'am. Her topic of presentation for today's webinar is Scope of Research in Shalya Tantra. Yes, Pooja ma'am is Assistant Professor in Department of Shalya Tantra, Mahatma Gandhi Ayurveda College and Hospital Research Center, Salod, Wardha. She pursued MS Shalya Tantra. She has achieved a gold medal in UG and PGs for securing highest marks. She is a PhD scholar. She is having a wide academic experience of 5 years in teaching and 8 years in clinical practice. We welcome you, ma'am. Please start your topic of presentation. Dr. Pooja, ma'am.
Ma'am, I will need some time. Sorry. I have connectivity issue, therefore I will need some time.
Okay. Shall we go ahead with the next presenter?
Yes, ma'am, you can.
Is it okay? Okay, yeah.
Yes, ma'am. Ma'am.
Ma'am. Yes, Vaikari ma'am is there. Hello.
Yes, ma'am. This is
Vaikari
Dr.
ma'am.
Pooja, ma'am. Yes, ma'am.
Who is going to present? I have given you. Pooja ma'am, are you ready to present the topic? Hello. Or I should take up Vaikari ma'am till then.
Hello.
Yes, Pooja ma'am. Okay. Sorry, you're not audible, madam.
Am I audible, ma'am?
Yes, ma'am. Pooja ma'am, we will proceed with your topic. Okay, ma'am. Hello. Am I audible to you? Hello, Dr. Pooja ma'am. Pooja Srivastav ma'am. Okay, Dr.
Am I audible?
Yes, you are audible and visible. I am waiting for your response, ma'am. Okay. You are ready for your topic presentation? Yes.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Okay. I want your response. So Dr. Pooja Srivastav ma'am is going to present her topic for scope of research in Shalya Tantra. You can start presenting your topic, ma'am. Start sharing your slides.
Time for that only, ma'am. Just you are disabled me for sharing my screen.
Okay, give me a second, ma'am.
Ma'am, you can start your presentation.
Ma'am, your slides are visible. Please put on your slide share mode.
Shall I start? Am I audible?
Yes, ma'am. You are
Yes,
audible.
ma'am.
Am I audible?
Yes, ma'am.
Yes, ma'am. Yes.
A very good afternoon to all the respected dignitaries, speakers and delegate. I feel very glad to be the part of this national web conference on the occasion of International Women's Day, organized by Ayush Darpan Foundation, India, in collaboration with MGSH and RC. Namami Dharmantarim. On this special occasion, I would like to bow my regards to my guru, Dr. Subhashandra Vashnia sir, and my guide, Dr. Kiran Khandare sir. I would also like to wish all the ladies present over here a very happy Women's Day. I would also like to thank Dr. Sheetal Asutkar ma'am for providing, giving me this opportunity to be the part of her vision. Thank you so much. Now I will start my topic. Of presentation is scope of research in Shalya Tantra. So by choosing this topic, an attempt has been made by me to highlight the thrust areas of research in Shalya Tantra. Scientific research and scientific studies in the field of Shalya Tantra are more evident if makes Shalya Tantra more evident if which is the need of the hour. So content of my presentation will be introduction, methodology, thrust area of research in Shalya Tantra, and discussion conclusion. Am I audible to all?
Yes, ma'am.
Yes, ma'am. You are audible.
So I will start with my introduction. Shalya Tantra is one of the distinct branches in the Ashtanga Ayurveda. Shalya Tantra explains the demonstrate Shalatantra explains and demonstrates surgical knowledge and procedures that were performed and used since thousands of years and are useful even today. Nowadays, world is turning towards Ayurveda comprehensive treatment of diseases. For comprehensive treatment of diseases. Surgical knowledge and treatment of diseases described in Shalatantra can be researched and used in diseases with minimum complications and side effects. So, as I told, purpose of my study is to explore the scopes of research in Shalatantra, and the method which I followed for the same was thorough analysis of Susha Samhita, modern medicine texts, and net surfing for various research articles. So I will start with the thrust areas of research in Shalatantra. The first topic which I found very interesting for the purpose of research is Sandhan Karma. Its description by Acharya Sushruta would have remained myth if it would not have been seen by the British physician during a war with Maratha. Now it is scientifically accepted and propagated by the surgeons of the West. It is emerged as a science of a branch of surgery in the form of plastic or reconstructive or cosmetic surgery. But still, if we talk about the research on Sandhan Karma in Ayurveda, it is very less. So it can also be taken for the research work in Shalatantra. Next interesting topic that I found for research is Char Karma, is useful as a substitute of surgical instrument. It has gained its popular role in anorectal diseases on the basis of route of administration. It is of two types, Pratisarniya Char and Paniya Char. Pratisarniya Char, that is external application in the form of Char Patan or Char Sutra, Char Tel, are very useful in curing various diseases like hemorrhoids, fistulae nano, fissure nano, warts, and many more. While Paniya Char, that is internal administration, is indicated in various disorders like Anaha, Ajirna, Shmari, Visha, Aruchi, etc. So various research work on Char has been conducted and still going on because of its miraculous properties like Tridosh Shagnatva, its Lekhan Karma, Sharan Karma, then Shodhan Karma, etc. As compared to Pratisarniya Char, Paniya Char के ऊपर कम researches हुए हैं, जबकि Pratisarniya Char में like Char Patan in hemorrhoids, या फिर मैंने अभी कुछ दिनों पहले कुछ research works पढ़े like umbilical granulomas में application of Char, या फिर नेजल सिनिकी में एप्लीकेशन ऑफ चार, बहुत सारे रिसर्च वर्क्स उसके ऊपर हो रहे हैं। और चार सूत्र के ऊपर तो इतना सारा आज वर्क हम लोग को देखने को मिलता है और हर बार एक अच्छी एफिकेसी के साथ में वो ऊपर कर आ रहा है। एंड इट इज ऑल्सो कंपेयरिंग विद द मॉडर्न मेडिसिन, मॉडर्न सर्जरी ऑल्सो, लाइक उसमें भी एफिकेसियस प्रूव हो रहा है। सो देयर इज लॉट ऑफ स्कोप इन फॉर रिसर्च in the field of Char Karma. Next topic that I choose is Jalokapchar, and it is the best way to relieve pain, different skin diseases, localized edema and inflammation. It is indicated in blood vitiated with Pitta doshas, children, old aged, frightful, debilitated women and person with the tender constitution, diabetic ulcer, varicose veins, gout, arthritis, acne, chronic skin diseases, herpes, etc. Each indication of Jalokapcharan can be the topic of research. It was very well explained by Dr. Sheetala Sudhakar ma'am, therefore I'm not going to touch it much. Next topic that I found very interesting is Agni Karma. It is the best therapy for management of various kinds of pain. It also causes coagulation. It is also said that diseases do not recur if once it is treated by Agni Karma. So itna importance Agni Karma ko hamare shastra mein diya gaya hai. It is performed by using different heat producing agents like jaggery, oil, ghee, shalakas, etc. Agni Karma is indicated in various disorders like osteoarthritis, backache, frozen शोल्डर, नर्व रिलेटेड डिसऑर्डर्स एक्सेट्रा, जिसके ऊपर बहुत सारा रिसर्च वर्क हो भी रहा है। लेकिन अग्निकर्म के मोड ऑफ एक्शन के ऊपर या डिफरेंट ट्रीटिंग मॉडलिटीज के ऊपर भी रिसर्च वर्क होना चाहिए और अच्छी तरीके से। देयरफॉर ये भी एज अ रिसर्च टॉपिक हम लोग रिसर्च के लिए आज भी ले सकते हैं। नेक्स्ट टॉपिक दैट आई चूज इज व्रण. Any kind of surgery will start with व्रण and will end in व्रण only. So wound management is the fundamental concept in the surgery. Shodan and Ropan are the two vital principles involved in healing of the wound. Ayurveda explains cardinal group of drugs involved in Shodan and Ropan process. Scientific study to analyze these drugs and different modalities of their application can be done. Acharya Sushruta has very well explained about the Shashti Upakramas in treating the wound, जो कि एक बहुत बड़ा रिसर्च टॉपिक हो सकता है जिस पे रिसर्च हो रहा है और अभी और होने चाहिए with evidences. Next topic that I choose is orthopedics in Ayurveda. Role of Ayurvedic aspects of orthopedics in the field of research is very fast. Application of different lepas plays a major role for local anesthesia and early healing of the wounds. Different sandhanak dravyas also have eye-fetching researches in the bhagnas. बहुत सारे folklore sandhanak dravyas भी आज emerge हो रहे हैं जिसके ऊपर बहुत सारे research works आज हम लोगों को देखने को मिलती है जो कि होनी भी चाहिए. Next topic is Sangyaharan, also known as anesthesia in modern science. Surgery of any kinds involve pain unless the surgeon is able to conduct it painlessly. Patient cannot suffer and accept the pain. Nowadays, anesthesia is the expeditious growing branch in the modern medical science. We find a reference of Sangyapanan Dravyas and Madhya Mohitavya. Except one or two references like this, all the operations were being conducted by holding the patients. Some researches has been conducted, but have not been improved and successful and marketed. Now, if anybody conduct research on anesthesia on Ayurvedic line, it would be a great contribution to the research field in Shalyatantra, and therefore I fully support Sangyaharan's restoration. The next is Dagdha. Burn is the another area of which is having the scope of research. Many local applications of Ghrutas and Lepas has been. Clinical studies can be done on the evaluation of these drugs. Next is Yantras and Shastras. In the era of robotic and keyhole surgery, still there is the scope of research in the classical instrument, which is explained in the Shalyantra. The classical instruments are very precisely figured out, which can give the best instruments in future if studied well. Next is Yogya Vidhi, that is practical training. Acharya Sushruta elucidated the surgical model for training the hands before performing the surgery on the actual patients. This kind of practice holds its importance even in today's era also. So there is great scope of research in making the surgical training models. Simulations के रूप में आज बहुत सारे models available है और बन रहे हैं जिसके ऊपर योग्य विधि या फिर practical training in hand students को दी जाती है, which will enhance their clinical skills या surgical skills. Now discussion. Sushruta Samhita, which is known for its highly praised, precise illustrations with the clinical and practical approaches towards the disease, can be taken up for the research study as a whole. If the study is to be more specific and unambiguous towards a single concept, then the single point of the Sushruta Samhita is the best hub for the researchers. Almost all kind of research can be conducted in Shalyatantra, like fundamental research or clinical type of research or drug pharmacological research, even literary research also. So there is great scope. Conclusion that I've drawn, where analysis of the particular topic of Sushruta Samhita can be a research topic for the comprehensibility, more surety, and incontrovertibility of the obscure or hidden concept. Hence, there is a wide scope of research in the field of Shalyatantra. So my take-home message for today's session is research is to see what everybody else has seen and to think what nobody else has thought. बहुत सारे thrust areas हैं, मैंने बहुत ही shortage of time के कारण बहुत कम thrust areas को choose किया, जबकि ये सारे काम हम लोग कर चुके हैं, देख चुके हैं, लेकिन हमें ऐसा कुछ सोचना है जो अब तक नहीं सोचा गया, and then research will be done and एक नया revolution शल्यतंत्र में आ सकता है. So thank you so much for the patience listening. Thank you so much.
Thank you so much, Pooja. Hello, am I audible?
Yes, ma'am.
Yes, thank you so much, Dr. Pooja. You have presented the topic very well. Hello,
yes,
am I audible?
Yes, ma'am. Thank you.
Thank you so much. Thank you so much. Now I will welcome Dr. Madhuri Banaras ma'am for her next topic of presentation. Dr. Madhuri Bhandare, ma'am. Are you there? Dr. Madhuri Bhandare, ma'am. Hello. Am I audible?
Yes, she is not in the meeting, I guess.
Not in the meeting. Okay. Okay, then we will proceed with our next speaker. Dr. Vaikhari, ma'am.
Yes, ma'am.
Yeah, you are there with me.
Yes, ma'am.
Yeah. Dr. Vaikhari, ma'am. Dr. Vaikhari Dhurve, ma'am.
Yes, ma'am.
Yes, she is a BAMS MS Shalyatantra. She pursued her BAMS MS Shalyatantra from Government Ayurved College, Nanded. She is a PhD scholar. Right now, she is pursuing the PhD from Gujarat University from Institute of Postgraduate Teaching and Research in Ayurveda. Her topic of presentation is diagnostic techniques in Bhagandara. I would welcome you, ma'am. Please present your topic.
Thank you, ma'am. My PPT is visible?
Your PPT is not visible, ma'am.
Hello, ma'am.
Yeah, ma'am, just wait for a second. We are just making the slides visible.
Okay, please.
पोस्ट बना दिया
Are
yes, ma'am.
Slides visible?
Yes, ma'am. You put on the slide share mode, ma'am. Your
Yeah,
slides are visible to us. Yeah. Okay.
Thank you, ma'am. Good afternoon, all. My presentation topic is diagnostic technique in Bhagandara. Introduction. Acharya Sushruta has included Bhagandara in Ashtamahagar due to its recurrent nature and can be correlated with fistula in ano. Fistula in ano is an inflammatory tract which has an external opening in perianal skin and internal opening in the anal canal or rectum. Diagnosis of fistula is made on the basis of history taking, clinical examination, and radiological investigation. Radiological techniques are helpful to choose the best surgical treatment, significantly reducing recurrence of the disease. Clinical features of fistula in ano: on inspection, an external opening around anal canal, but in patient with intersphincteric fistula, there may be no apparent external opening. Anorectal fistula present with purulent discharge around anus and formed within anal canal. Discharge is associated with impaired anal hygiene and soiling. A patient gives a history of an abscess which had burst spontaneously or requires surgical drainage. Some patients with fistula have already had one or more operations for this condition. Itching and soreness at perianal skin. Classification of fistula in ano:
Milgan and Morgan classified fistula in ano according to their relationship to the anal sphincter and in particular to the anorectal ring. Low fistula opening to anal canal at the level of pectinate line, submucous fistula in ano, subcutaneous fistula, transpectic fistula, high fistula, all other varieties of fistula like extrasphincteric fistula. Standard classification by Goliger: subcutaneous type, submucous type, low anal fistula, high anal fistula, anorectal in which istiorectal and perirectal variety. Pathological classification: tubercular fistula, secondary to ulcerative colitis, secondary to Crohn's disease, secondary to colloid carcinoma of the rectum. Past classification of fistula in ano gives an accurate description of the anatomical course of fistula's tract: intersphincteric fistula, transphincteric fistula, supralevator, and suprasphincteric fistula in ano. Classification according to St. James University Hospital. This classification is based on axial plane, primary fistulous tract, secondary extension, and abscesses. Grade first, simple linear intersphincteric fistula. Grade second, intersphincteric with secondary tract or abscess. Grade third, transphincteric. Grade 4, transphincteric with abscess or secondary tract in istiorectal or istioanal fossa. Grade 5, supralevator or translevator extension. Diagnosis: clinical examination, inspection. On inspection, one or more external opening with elevation of granulation tissue with first discharge. Char of previous anorectal surgeries like abscess, fistula, and ano, hemorrhoid may be seen. Palpation: on palpation, induration may be felt from external opening to the anus. A first discharge on palpation show improper drainage and tenderness present if inflammatory condition of fistula. Tract of horseshoe fistula, when it hurts, like induration on one or both sides and posteriorly above the level of anorectal ring. PR digital examination is useful to reveal the area of induration and internal opening. Proctoscopy: internal opening as felt as a dimple and hypertrophic papilla. Other disease condition can be revealed by proctoscopic examination. Probing: it is essential for diagnosis of tract of fistula. Gentleness is required while probing, otherwise false tract occurs. As probing done after preliminary survey has been made by inspection and palpation. Dye for patency: this is helpful to know whether the fistula is complete or not, and also to locate the internal opening. Investigation: X-ray, it is oldest radiological investigation. Merits: useful in the detection of luteal or perianal abscesses. Pathological condition like tuberculosis and osteomyelitis of pelvic or spinal region may be revealed. Demerits: it is not very helpful in fistula imaging. This is X-ray fistulograph. Fistulography: X-ray will be taken after the radio-opaque dye is passed through the external opening, which show the course of tract with branches and internal opening of fistula. Merits: it provides enough information to avoid more invasive procedure. Demerits: anorectal musculature is not imaged. Identification of the level of internal opening is also often difficult due to lack of precise landmark. Minor pain and infection from the catheter incision and allergic reaction to the contrast material. Deshpande's technique of double contrast X-ray fistulography is modified form of fistulography. Fistula anatomy can be interpreted in relation to the anal canal, rectum, anorectal junction, and other anatomical landmarks which provide more information in comparison to the conventional X-ray fistulography. Endoanal or transrectal ultrasonography, it is first technique to demonstrate the detailed anatomy of anal sphincter complex. TRUS is widely accepted as a popular imaging modality for evaluating various anorectal diseases. Merits: it provides excellent visualization of the layers of rectal wall and the anal anatomy. Three-dimensional ultrasonography, useful to differentiate between low sphincteric, low transphincteric, suprasphincteric, or high sphincteric tract. Its direct use in intraoperative to assist surgical exploration. Demerits: it is operator dependent. Its inability to differentiate between the area of fibrosis and infection, which is particularly important in case of recurrent fistula. This is trust report. Course of fistula tract, internal opening and anal canal. MRI resonance imaging. MRI is an essential useful tool in preoperative evaluation of the perianal and anal fistula. Merits: it provides high resolution image of the anatomy of the anorectal region with dedicated depiction of the fistula tract with their associated secondary ramifications and abscesses. MRI has emerged as a gold standard imaging modality in the management of fistulas. It provides 100% accurate description of the fistula. Demerits: high cost. It is contraindicated in cases where patient having impaired renal function. Grade first, low linear transsphincteric fistula in ano. Grade first B, low linear transsphincteric fistula in ano. Grade second A, low abscesses. Grade second B, low multiple tract. Grade second C, low horseshoe tract. Grade second D, supralevator intersphincteric fistula. Grade second E, supralevator intersphincteric plus low transsphincteric. Grade third A, high linear transsphincteric. Grade 4A, high transsphincteric with abscess. Grade 4B, high transsphincteric with multiple tract. Grade 4C, high transsphincteric with horseshoe tract. Grade 5, supralevator intersphincteric with high transsphincteric fistula. Grade 5B, suprasphincteric infralevator fistula. Computed tomography scanning. Merits: CT scan is useful in inflammatory bowel diseases to assess the extent of rectal inflammation and in the evaluation of acute inflammations or abscesses associated with fistula. It is useful in cases where MRI is contraindicated. Demerit: it is not much useful in fistula, secondary tract, or even the primary also may fail to fill the contrast. Differentiation between inactive fibrous tract and active disease is also poor by CT. CT fistulograph of transsphincteric fistula in ano. Transverse showing lower arm of the tract entering into anal canal posteriorly with rectum with contrasting rectum, and coronal image showing upper arm of tract entering into anal canal anteriorly. Conclusion: complex and recurrent fistula cases must undergo preoperative imaging to reduce the chances of merits and demerits also. MRI imaging is gold standard modality but expensive and not so easily available. Fistulography is easily available and quite cost effective. CT is not much informative regarding the anatomy of fistula tract. Trust is expensive and not so easily available. Surgeons should consider clinical findings in establishing the diagnosis. This investigation only to support the design the appropriate management plan for treating Bhagandara. Thank you. Thank you for listening me. Especially thanks to Dr. Asutkar Madam and Ayush Darpan Foundation for giving me such platform to share my knowledge. Thank you, ma'am. Am I audible?
Thank you so much, ma'am. It was a wonderful session. Especially you have elaborated the different techniques, diagnostic techniques to identify.
मम्मी पिल्लू के साथ नहीं खेल रही.
May I request everyone to please mute yourself. So thank you so much, ma'am, for elaborating different diagnostic techniques to identify the complex fistulas. Thank you so much. Now I would like to invite our next guest speaker, Dr. Madhuri Banaras, ma'am. Her topic of presentation is Marma therapy and innovative therapeutic procedure in Shalyatantra. Ma'am pursued her BA/MS in year 2004 from Government Ayurved College, Nanded, Maharashtra. Her pursued her MS Shalyatantra in year 2007. Government Ayurved College, Usmanabad, Maharashtra. She is a PhD scholar from R.A. Poddar Medical College, Worli, Mumbai. She has an immense experience in academics, more than 16 years, and she is a PG teacher since last 12 years. I will invite you, ma'am. Please start your topic for presentation. Thank you, ma'am.
Thank you, ma'am, for such a nice introduction. Can I share my slides now?
Yes, ma'am, you can share. You are the co-host.
Yes. Is it visible, ma'am?
Yes, ma'am, it is visible. Please start the slide share mode, ma'am. Yes.
Okay. Thank you so much. First of all, good afternoon, all the dignitaries and dear participants. Before starting today's presentation, I would like to thank you, respected Dr. Navin Joshi sir, Director of Ayush Darpan, for giving me such a confidence. So as I can do Marma therapy in my daily practice. So thank you so much, sir, for this knowledge. It's a great pleasure to introduce such an innovative therapeutic procedure that is Marma therapy in Shalyatantra. As we all know the Marma very well because we studied it in only graduate level, but we studied it in preventive and prognostic aspect. Today we will see the therapeutic aspect of the Marma, that is Marma therapy. Was Marma therapy used to practice in ancient era? There are some evidences that shows that it was used to practice in ancient era. That is, the use of Marma science as a therapeutic procedure has been observed in some ancient Indian traditions and practices, that is Atharva Veda. Oil massage, pressure, lepa, nasya, yogasans, etc. stimulate the Marma points of the body, resulting in the desired therapeutic benefits. The knowledge of Marma is employed in various ancient Indian traditional practices like Kalari Payat of Kerala, Varma Kalai of Tamil Nadu, and Ayurvedic Abhyanga, that is massage, for therapeutic benefits. So these evidences shows that it was used to practice in ancient era also. So what is Marma? We all know one definition of Marma, that is Marayanti iti Marmani. Again, it is a preventive or prognostic aspect of the Marma, means you should protect the Marmas from the trauma. The definition said that you should protect the Marmas from the trauma. But when we think about the therapeutic aspect of the Marma, this definition is very important. It said that Marmani nama Mausa Sira Snayu Asti Sannipataha Teshu Swabhavata Eva Visheshena Prana Tishtati. Described by Sushuddha in Charistan 6th chapter. See, Marma are the meeting points of the muscles, vessels, tendons, bones, joints. And the prana is specifically located at these Marma points. Visheshena Prana Tishtanti. Means, as we all know, prana is located all over the body. That's why we are alive. But Marmas are the specific points where the prana is specifically located. So again, the last point shows the preventive and prognostic aspect, as since Marma is the seat of prana, injury to these Marmas hampers the Jivan or process of life and thus lead to death or loss of function. Marma is classified in various groups according to anatomical composition of the Marma, means which is the major component of that typical Marma. It is classified into the Mausa, Sera, Snayu, Asti, and Sandhi Marma. And according to location, means where it is situated, on which part of the
body it is situated. It is classified into the marmas of the extremities, marmas of the thorax, marmas of the abdomen, and marmas of the supraclavicular region. Again, according to the effect of the marma, means when it will get injured, then according to the effect, it is classified into Shilpa marma, Vishalagna marma, and Rujakar marma. Again, according to the properties of the marma, it is classified into Saumya marma, Vayavya marma, Agneya marma, and Saumyagnaya marma. So, actually, Vaikalyakar marma are Saumya marma, and the Kapha is the predominant dosha. Then Rujakar and Vishalyagna marma are Vayavya marma, and Vata is the predominant dosha here. Sadhya Pranhara marma are always Agneya marma, and Pitta is the predominant dosha here. Then Kalantar Pranhara marma are the Saumya Agneya marma according to the properties, and Kapha and Pitta are the predominant dosha here. Again, importance of marma. All acharyas gave a great importance to marma as we studied the text. But Sushruta described in Charistan 6th chapter, Marmani Shalya Vishardham. And Sushruta described it the Shalya Vishardham. That is, it covered half of the Shalya Tantra. So that much importance Sushruta gave to marma. Again, Charaka also described in Siddhisthan 9th chapter, Trimarmi Adhyaya. So a separate Adhyaya, that is Trimarmi Adhyaya in Siddhisthan 9, where he described the three Sadhya Pranahara Marma. So Shira, Rudaya, and Basti. He described these three marmas in that particular chapter, and also where he described the diseases of that particular three marmas and the management of these three marmas in Trimarmiya Adhyaya. Also, Ashtang Rudaya, Vagbhata mentioned Marma Vibhaga Sharira Adhyaya in Sharistan 14 Ashtang Rudaya. So all Acharya gave a great importance to these marmas. So is there any direct reference of Marma Chikitsa in our text? Yes, there is a direct reference, that is Abad Varjanam Nityam Swasthavrittanvartanam Utpannarthi Vighataka Marmanam Paripalanam. Charaka described in Siddhisthan 9th chapter, that is Abad Varjanam Nityam, means if you want to live a healthy life, you should follow the Swasthavritta. And if the diseases or disorders occur, then you should take care of Marma Parivala. So this is the direct reference of Marma Chikitsa told by the Charaka in Siddhisthan 9th chapter. Again, some specific names given to the specific marmas like Talarudaya. Talarudaya marma is situated at the center of palm and sole. So if you will take care of this Talarudaya marma, it will ultimately take care of your heart. So that's why the Talaruda name given to this marmas. Sorry. Then Katika Tharun. The name given to Katika indicates if you will take care of this marma, it will take care of your tarunya, that is your young life. So this indicates the evidences of marma therapy. The related therapies like chirotherapy, acupressure, Vidhagni Karma, Panchakarma is nothing but the stimulation of marma, that is marma therapy. Advantages of marma therapy. It is a non-pharmacological OPD procedure and having the negligible adverse effect. There is no need of equipment. Also, it is very cost effective because instruments or drugs are not required. Then it is a less time consuming method. Then, but it requires the knowledge for identification and selection of the marma points. It needs skills, hands-on training, and documentation for the evidences. Then what are the standard operating procedures of the marma therapy? So before doing marma therapy or marma chikitsa, you should follow these standard operating procedures. So pre-marma therapy, history of patient is very important because it is very important to diagnose first the patient. So for confirming your diagnosis, history of patient is very important, because your diagnosis will suggest the selection of the marmas. So after taking the history of patient, you will be able to diagnose the patient and the part which is also able to know the part which is affected, and that according to that you can select your marma points. So that's why history of patient is very important. Again, history is important for the exclusion of some conditions, like marma therapy is contraindicated if that particular marma has the history of trauma within the 6 months. So if that particular marma has a history of trauma within 6 months, then it is excluded for marma therapy. After 6 months, you can do marma therapy at that particular marma, but within 6 months, it is contraindicated for the marma therapy. So that's why history of the patient is very important for selection and exclusion for the marma therapy. So again, a patient should be fasting for minimum 4 hours, or he should be on light diet, because particularly the stimulation of head marma induces the vomiting. So to avoid this complication, you should always advise the patient for light diet or fasting. Then what would be the proper position for marma therapy? So always do marma therapy in sitting or lying position, because again the stimulation of head marma, that is shiromarma, can induces the vertigo. So vertigo can, so patient can fall down due to the vertigo, and patient can be injured. So to avoid this complication, always do marma therapy in the lying or sitting position. Then, while during the marma therapy, selection of the marma is very important. So there are some specific marma points for specific diseases. It is indicated. But if you don't know about this selection process or particular marmas, then you can select the nearest and related marmas. Marma is very important for the marma therapy, because identification and selection of the marma directly correlate to the patient's effect. So always be cautious during selection and identification of the marma points. So Sushruta also described a very good identification markers like Anguli Praman of the patient to identify the marmas. Again, you should mark the marma points with marker, or you can do simultaneously. Then pressure. What should be the pressure? So always give the maximum pressure for the marma stimulation, but again it depends on the type of marma. Means if it is a sira marma, then the pressure should be minimum, that is 1+, and if it is a snayu marma, then pressure should be medium, that is 2+, and when it is asthi and sandhi marma, then the pressure should be always maximum and more than the sira and snayu marma. Then what would be the stimulation method for marma therapy? Mainly press and release is the main, press and release with the thumb is the main stimulation method for the marma therapy. But there are some specific stimulation methods for specific marma points, like rotation of the wrist joint clockwise and anti-clockwise for the stimulation of manibandha marma. Then stimulation of the nerve with making a hook at the ankle joint is the stimulation. It's a little bit different stimulation method for the stimulation of Gulfa marma. So then again, there are some yogasanas, that is Mandukasan for Nabi marma, which means there are some yogasanas which stimulates the particular marma. Then also some mudras are there, that is Hasta Vakshabadha mudra for the stimulation of Sthana Rohit marma, and Ashwini mudra for the stimulation of Buddha marma. Then what will be the frequency for the stimulation of merma means press and release. So it should be 5 to 8 times for normal press and release frequency, and it should be 15 to 18 times for diseased one. What would be the duration of pressure? What would be the duration of pressure while you are pushing? It should be 0.8 seconds for each marma, and you can do marma therapy once or twice. So there are some case studies which I have done at both our surgery. First is tennis elbow. Tennis elbow, that is lateral epicondylitis, is a painful condition that occurs when tendons in your elbow are overloaded, usually by repetitive motions of the wrist and arm. Weak grip strength, sometimes pain at night. The available non-surgical treatment is rest, non-steroidal anti-inflammatory drugs, physical therapy, brace, steroid injections, extracorporeal shock wave therapy, and the available surgical treatment is open surgery or arthroscopic surgery. This is the patient of tennis elbow. I am doing the marma therapy for tennis elbow. See, now I am doing the stimulation of right collarudhe. You can select the right side for the male and left side for the female, as it is related to Ida and Pimla nadi. Otherwise, you can select the affected side first. So this is also one of the SOP for the marma therapy. Now this is Shipra marma, stimulation of Shipra marma. Pushing forward, by giving the pressure. This is the stimulation of Shipra marma. Always do marma therapy on both sides. If only one side is affected, then also you should do it on the bilateral side. See, this is the stimulation of Manibandha marma, rotation of the wrist joint clockwise and anti-clockwise. See, now I am doing the stimulation of Indrabasti marma. It is situated 4 fingers below the Karpur marma or elbow joint. Just press and release is the stimulation method. Four finger below the elbow joint or Kurpar marma. Just press and release. As it is a patient of frozen shoulder, I am doing it for 15 to 18 times. And for healthy person, you can do it for 5 to 8 times. Now I am going to stimulate the Kurpar marma. So first palpate the both epicondyles, bony projections, medial and lateral, and one finger below this epicondyles. Just press and release for 15 to 18 times. This is the stimulation of Kurpar marma. Again on other side. First palpate the bony projection, epicondyles, then one finger below the epicondyles, press and release. See, as this is the upper extremity disease, frozen shoulder. I think complete video is not able to play. Another case is frozen shoulder. It is also known as adhesive capsulitis. It is a condition characterized by stiffness and pain in your shoulder.
Excuse me, madam.
Yes.
Yes. Please compile, ma'am.
Yes, ma'am. Last line. I will show last case. This is the case of knee osteoarthritis. It is also known as degenerative joint disease of the knee. It's typically the result of wear and tear and progressive loss of articular cartilage. It is most common in the elderly. Osteoarthritis is typically a progressive disease that may eventually lead to disability. Common symptoms are knee pain, Then knee stiffness and swelling, pain after prolonged sitting or resting, and pain that worsen over the time. Treatment of knee joint osteoarthritis begins with conservative methods and progresses to surgical treatment options when conservative treatment fails. I will show, this is the last case. I will show you. See, this is the patient of knee osteoarthritis. Patient is giving the history. She has bilateral knee joint pain and swelling. A typical case of OA due to obesity. See, now I am stimulating on the left side. Shipramarma stimulation. Pushing forward by giving pressure. Then now I am going to stimulate Wolfram by making a hook at the ankle joint and giving the massage to the nerve posterior. First, I am palpating the posterior artery pulsation because nerve should be there only, and then making a hook and giving the massage by giving a spark to that particular nerve. You should feel the spark of that particular nerve. Then only it is the proper stimulation of the Wolfram. (15 to 18 times.
Ma'am, please speed up the video.
Yes. Again, on another side. Then Indravasti Marma, forefinger below the knee joint. Just press and release. On another side. Indravasti, forefinger below the knee joint. And now knee stimulation of knee is important. It is the last marma. I stimulated. See. With palm and thumb, you should press it in the upward direction. This is the stimulation of knee marma or janu marma with the thumb and palm. I am doing it on the posterior side also because it is a case of OA. It is important to do from anterior and posterior aspect. This is patient's feedback. Patient has got 50% relief after doing marma therapy. I think sound is not clear. %. She said 50% relief. Then again some cases I will skip it. Thank you so much. Thank you organizing team, especially the director of Ayush, respected Dr. Navin Joshi sir, for giving this excellent knowledge, and specifically Dr. Shilpa Kadhar ma'am for giving this opportunity to me. Thank you so much, ma'am. Thank you the whole organizing team. Thank you.
Thank you so much, Madhuri ma'am. It was a very good presentation. Your practical demonstration was also very nice. Hope we all can implement some of the marma therapy that we have learned from you on this webinar. Thanks a lot, ma'am.
Thank you.
Yeah. Now I would request Dr. Sheetal ma'am. I will hand over mic to her. Thank you, ma'am.
Thank you.
Thank you, Dr. Kiran. And with this, we come to the end of this program. Actually, I'm so delighted to be thanking Dr. Kiran and Dr. Nirmala for such a nice coordination and nicely conducting the event. Task of moderation, the task of conducting and anchoring a program is too difficult actually, and to manage such online virtual programs is a challenging task actually. But both of you have presented it, conducted this program in such a nice way that I'm so happy for both of you, and I would like to congratulate both of you for this challenging task which you have accomplished in a very successful manner. Thank you so much, Kiran and Nirmala. And moving ahead, we are in the very last phase of this International Women's Day celebrations of Ayush Darpan in collaboration with Mahatma Gandhi Ayurved College Hospital and Research Center, which is the constituent college of Datta Meghe Institute of Medical Sciences, Wardha, Savangi Wardha. And we have collaboratively organized the Lady Ayurveda Surgeons which being conducted in 2 days, 7th and 8th March 2022. And we are celebrating the International Women's Day in a very different manner, in a very exclusive manner. And I would like to congratulate all the participants and all the speakers because all the presentations for today and yesterday also were exclusive and were presented in a very dynamic manner with command on the over the voice, command over the subject, and all the female surgeons proved to be the empowered ladies in the Shalya Tantra faculty, particularly Shalya Shalakya, Prasuti Tantra, Strirog and Sangyaharan part of Ayurveda. And they are the leading ladies, and they have given the brief accounts of the surgeries they perform in their routine activities of their exclusive subjects. So thank you to all ladies, and we move ahead to the valedictory session part of this particular program. So I would like to call upon Dr. D.N. Pandey sir, Dr. Sangeeta Salvi ma'am, and Dr. Subhash Chandra Varshney sir for their exclusive remarks. So first of all, I would like to call upon Dr. Sangeeta Salvi ma'am to give her remarks about today's program.
Ma'am, it is a pleasure for all of us to be in this wonderful 2-day program for International Women's Day. And I feel all claps go to you because you have organized it so well. It has gone so well since 2 days. And all the presenters, I would say including myself, have given their best to whatever they could, and they have presented what they are doing. So it's a very nice thing to see all female surgeons doing a very good job at their respective places. And this means that I think Ayurveda surgery will go ahead now. So right from the anesthesiology till the marma therapy, all of the topics were so enchanting, and everyone has really presented in a very nice way. So all hats off to you, ma'am, for getting us all together under one umbrella, because coming together on one platform sometimes is really difficult, and you have shown it from since last year you are trying, and hats off to your efforts. Hats off to Dr. Navin Joshi sir's efforts also, and thank you very much for getting all of us together on one platform today. So thank you very much, ma'am.
Thank you very much, ma'am. Thanks for everything. Thank you very much. Moving ahead, I would like to call upon Dr. D.N. Pandey sir for his remarks. as a guest of honor, Dr. D.N. Pandey sir. So I think he is not in the meeting. Sir was present in the morning, but maybe right now sir is busy with something. So I call upon Dr. Varshne sir. Actually, Dr. Kamini Dhiman ma'am was also expected to be present in the valedictory session. So
I have joined, madam. Join, madam. I have joined.
Oh, thank you so much, ma'am, for being with us today. Actually, thank you so much. I was very keen to see you here in our program, and I'm so happy that you have managed time to attend this program in spite of so much of your busy schedule. So, welcome, ma'am. Dr. Kamini Dhiman, ma'am, needs no introduction at all. Her name is known to all, but still I would like to tell the budding students and surgeons that madam is presently working at All India Institute of Ayurveda in the Department of Prasiti Tantra and Stree Rog, and she is an integral part of Ayush Darpan family, and she is not new to even Lady Surgeons Conference. She was part of Lady Surgeons Conference last year also, and ma'am, welcome you here. Please give your remarks for our program.
Thank you, madam. So nice of you for inviting me for this valedictory session. And I would like to say, respected Pandey sir, Sangeeta Salvi madam, and Vashne sir, namaskar to all of you. And namaste to all the participants who are listening this wonderful sessions. And congratulations to all the surgeons who have presented very well all their work. And theme of this International Women Day is equality, empowerment. But after seeing this webinar organized by Sheetal madam, there is no question of that women are not empowered. All these lady surgeons, dynamic surgeons are already empowered. And we can see that program organized by Sheetal madam is a great example of this equality. No one will have doubt about this empowered dynamic surgeons. And congratulations to all the surgeons who have presented their topic in this webinar continuously for 2 days. Continuously from 2 days, madam was organizing this. And it is really a different and excellent way of celebration of International Women Day. Exchange of knowledge, exchange of thought is necessity of the day. And how all the lady surgeons in different parts of the India are working in their workplace. No one can see or no one can know without this webinar. Through this webinar, madam has done a lot many work that she has given chance to all the surgeons, and she has given chance to participants also to see the work of these dynamic surgeons. And last year also, I was the part of this valedictory session, and last year also, madam invited me. And thank you, madam. Congratulations to all of you. Namaskar.
Thank you so much, madam. Thank you for being with us today. बहुत अच्छा लगा मैम आप आए हो. I know because you are so busy, but still you have managed. Thank you so much.
Thank you, madam.
Yes. There, Dr. Veena Patil also, Veena Patil ma'am, professor and head, Prasuti Tantra and Stree Rog Department, Government Ayurveda College, Osmanabad, was also expected to be attending this Lady Surgeons Conference. But anyhow, due to her preoccupied engagements, she had some previous engagements. She had sent her recorded video of 1 or 1.5 minutes. So I would like to play this video for all of us. So give me a second.
A very good morning to all. Wishing you all happy International Women's Day. Myself, Dr. Veena Ajay Patil, Professor and Head, PTSR Department, Government Ayurvedic College, Usmanabad, Maharashtra State. I would like to congratulate Dr. Sheetal Ma'am, Dr. Naveen Joshi Sir, and all lady surgeons in the field of Ayurveda for organizing and contributing such a great national web conference on contribution of female surgeons to Ayurveda.
There are some technical issues. The video is not sharing. So I'll be sharing it later in our group. So as Dr. Varshne has arrived and sir सभी आपको सुनने के लिए बेताब है. तो सर आप अपने प्लीज चेयरपर्सन रिमार्क्स दीजिए. आपसे आपको आमंत्रित करती हूँ सर.
थैंक यू डॉक्टर शीतल. सबसे पहले तो आज के इस दिन की सभी नारी शक्ति को बधाई. आवाज आ रही है ना?
जी सर.
हेलो, आवाज आ रही? हाँ
जी सर. जी सर आ रही है.
यस सर.
डॉक्टर, सबसे पहले तो नवीन जोशी जी ने कोरोना पीरियड में कहो या बाद में कहो, सबको संगे शक्ति कलयुगे, इसमें संघ का बहुत बड़ा रोल होता है और सबको बांध के रखना एक बहुत बड़ी बात है. और ऐसा प्लेटफॉर्म जिससे हम लोग सब एक साथ मिल सकते हैं, बात कर सकते हैं, एक दूसरे को देख सकते हैं, तो निश्चित ही डॉक्टर नवीन जोशी सर बधाई के पात्र है. शीतल मैडम का क्या कहने का, मैंने कल भी बताया था. इस शीतल नहीं रहती है काम के विषय में तो बड़ी जो है तप्त रहती हैं एकदम. चाहे कोई भी हो, गुरु हो, चेले हो, सबसे काम लेना जानती है अच्छी तरह. और अच्छी बात है, अनुशासन होना ही चाहिए. और हमारे यहाँ हिंदू धर्म में तो बोला ही है, नारी शक्ति को एक दिन नहीं मनाते साल में, हमारे यहाँ 2 बार मनाई जाती है नव दुर्गा. और हमेशा नारी शक्ति को 9 दिन याद किया जाता है, 1 दिन की अपेक्षा. तो हमारे यहाँ तो या देवी सर्वभूतेषु शक्ति रूपेण संस्था नमस्तस्ते 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 नमो नमः. तो हम सबको नमन करते हैं. डीमान मैडम, DN पांडे सर, और उसके अलावा यहाँ पर जो है काशीकर सर. और सबसे बड़ी बात तो ये है, हम आपके आज नेशनल सेमिनार ना हो गई, इंटरनेशनल हो गई. श्रेष्ठा मैडम ने जुड़कर नेपाल से या US से जुड़ के इस सेमिनार को, इस वेबिनार को इंटरनेशनल बना दिया. तो उनको भी मैं धन्यवाद देता हूँ, वो हमारे साथ जुड़ी और इस ऑर्गेनाइजेशन को बहुत आगे बढ़ाया. तो जितने भी सदस्य हैं, सीनियर लोग, काशीकर सर, के पांडे सर, और भी बहुत से लोग हैं जो जुड़े हुए हैं यहाँ पर, तो मैं सबको धन्यवाद देता हूँ. और आज का जो वेबिनार है मुझे लगता है बहुत ही बढ़िया, बहुत ही सफल वेबिनार रहा. बहुत ही सफल जो शुरुआत हुई मैडम जो है संगीता से, संगीत में कहना चाहिए तो वास्तव में एक शब्द में छेद भेद लेख्य करणार्थ, ये तीनों प्रॉपर्टी चार की होती हैं. और उन्होंने जो है श्रवण, नयन, बदन, ग्रहण आदि संस्कृतानाम, इन सभी व्याधियों में उनका उपयोग दिखाया. वास्तव में बधाई की पात्र है और बहुत ही अच्छा, वो बहुत अच्छी सर्जन है, मैं जानता हूँ. लेकिन कॉमन प्रॉब्लम को भी डील करने के लिए हमको ऐसी चीजें दिखानी चाहिए ताकि हम जहाँ काम आवे सुई, क्या करे तलवार. जहाँ सुई से काम हो सकता है, छार सूत से काम हो सकता है, छार से काम हो सकता है, तो बड़े प्रोसीजर की जरूरत नहीं है. बहुत अच्छा उनका एक आज डेमोन्स्ट्रेशन रहा. मैं वास्तव में बहुत उनके प्रति अपनी श्रद्धा अर्पण करता हूँ. मुझे उस समय राहुल बाइस्कर अपना स्टूडेंट है, उसकी भी याद आई. उसने भी अनेक रोग, स्किन डिजीजेज जो है छार से ठीक करी है. तो वास्तव में ये बहुत ही बढ़िया एक टूल है हमारे हाथ में. जहाँ कहीं भी छेद भेद लेख्य तीनों अवस्थाओं को जरूरत हो, वहाँ ये छार काम करता है. मुझे अभिमान है कि मेरी पहली स्टूडेंट कर्णावत, उसका यही टॉपिक था, छेद भेद करणार्थ. तो छार का उपयोग कहीं भी जहाँ छेदन की जरूरत है, भेदन की जरूरत है, लेखन की जरूरत है, और ये काम कर सकता है. उसके बाद मैडम शीतल ने तो बोल ही दिया, कल भी बहुत अच्छा उनका लेक्चर हुआ और आज भी उन्होंने ये प्रूव कर दिया. सद्य राग रुजा शमा, अगर कोई ट्रीटमेंट हमारे पास इमरजेंसी के लिए है, तुरंत लाभ करने वाला ट्रीटमेंट है, तो वो हमारे पास रक्त मोक्षण. और लीच एप्लीकेशन इज वन ऑफ द पार्ट ऑफ रक्त मोक्षण। उन्होंने अनेक स्लाइड दिखाए, अनेक तरह के वर्क दिखाए, और मैं इस बात को बड़ा गर्व से कहता हूं, यदि किसी को इमरजेंसी देखनी हो थ्रम्बोज पाइल्स में, हर्पीज जोस्टर में, जहां बर्निंग पेन हो रहा है थ्रम्बोइजाइटिस ओब्लिटरेंस में, वहां लीच लगाइए और टेबल पे मरीज बोलता है ट्राइजेमिनल न्यूरल्जिया इत्यादि में कभी मुझे तुरंत आराम मिलता है। तो ऐसा उन्होंने बहुत अच्छा प्रयास किया अपनी तरफ से, बहुत ही बढ़िया। उन्होंने अनेक प्रकार की विधाएं, सेलुलाइटिस हो, एब्सेस हो, गैंग्रीन हो, और थ्रोम्बोसिस हो, एक्जिमा हो, मैं अनेक प्रकार की कंडीशन में इन्होंने लीच का दिखाया, मोड ऑफ एक्शन बताया कैसे लीच काम करती है। और मैं समझता हूँ आने वाले समय में और नए हथियार से लेके वो आएंगी लीच के बारे में। उनके स्टूडेंट नया जो प्रोजेक्ट है बेड वुंड बेड प्रिपरेशन, वो सफल होगा, मैं ऐसी आशा करता हूँ। धन्यवाद शीतल मैडम। इसके पश्चात जो मेरी एक और स्टूडेंट है माधुरी बनारस से, मैं तो नहीं समझ सकता था वो इतना हायर लेवल पे पहुंच गई है, मुझे बड़ी खुशी हुई। और उन्होंने स्किन ग्राफ्टिंग के इंडिकेशन से लेकर प्रैक्टिकल डेमोन्स्ट्रेशन जो दिया, वास्तव में वो भी बहुत ही ज्यादा बधाई की पात्र है। और मैं बहुत ही अच्छा बड़ा प्रसन्न हुआ उनके काम को देखने से बाद। और इसके बाद जो अनेक वर्णन थे, मैं कांग्रेचुलेशन दूंगा संज्ञाहरण पूना से, इतना बढ़िया प्रेजेंटेशन मैडम का था। मैं हिस्ट्री से लेके उन्होंने आगे तक क्या रोल है इस सब के बारे में बहुत ही अच्छा, संज्ञाहरण के बारे में बहुत ही अच्छा उन्होंने किया। कंचन मैडम शिकोकर बहुत ही बढ़िया, उनका भी वेरिकोस सिटी कॉमन कंडीशन है और यदि ट्रीट ना की जाए तो अनेक कॉम्प्लिकेशन हो सकते हैं, उनका भी एक बहुत अच्छा सुनने को मिला अपने को यहाँ पर। और उसके बाद अनेक काड़े मैडम तो बहुत ज्यादा टीवी पे छाई रहती हैं, दोनों हस्बैंड वाइफ, और उनका बहुत बड़ा योगदान है नागपुर में, काफी अच्छा काम कर रहे हैं, वो भी बधाई के पात्र है। उसके बाद हॉर्म जोशी, अरे बहुत ही बढ़िया षष्ठी उपक्रम के बारे में उन्होंने बोला। आदौ विमलापनम कुर्यात्, द्वितीयम अवसेचनम, तृतीयम उपनाहम, चतुर्थम पाठनम क्रिया, पंचमम शोधनम च वै, षष्ठम रोपण इष्यते, ऐते क्रमा वृषोयुक्ता, सप्तमम व्यकृता पहम। 60 उपक्रम को 7 में डालना, और फिर जो जो उपक्रम उनके प्रैक्टिकल ट्रेनिंग में उपयोग हुए उन्होंने बहुत अच्छा प्रेजेंटेशन स्लाइड के द्वारा दिया। मैं और आहार के ऊपर उन्होंने जो बहुत अच्छा बोला, मैं उससे बहुत प्रभावित हुआ हूँ, और वो भी बहुत ज्यादा बधाई की पात्र है। बहुत ही अच्छा उनका डेमोन्स्ट्रेशन था, इसमें भी कोई दो राय नहीं है। सविता मैडम का भी बहुत अच्छा प्रेजेंटेशन था, एडवांटेज, क्लासिफिकेशन, मैकेनिज्म, सब लोकल एनेस्थीसिया के बारे में जो उन्होंने बोला, वास्तव में वो भी बधाई की पात्र है। स्मिता मोहड़ बहुत ही नासिक से जो बोली अग्निकर्म और उसके ऊपर, बहुत ही बढ़िया उनका डेमोन्स्ट्रेशन रहा, वास्तव में वो भी बधाई की पात्र है। पूजा मेरी स्टूडेंट है, उसका प्रयास है वो कंडीशन सर्च करना, कहाँ कहाँ हम आगे बढ़ सकते हैं। मैं समझता हूँ बहुत बड़ा कैरियर उनके सामने पड़ा है, एक एक प्रॉब्लम लेंगी तब भी आगे बहुत अच्छा काम इन सभी ब्रांचों में कर सकती हैं, इसमें भी कोई दो राय नहीं है। इसके बाद डायग्नोस्टिक जो है फिस्टुला के विषय में देवाकरी मैडम का बहुत अच्छा था। माधुरी इनका भी बहुत अच्छा, मर्म थेरेपी के ऊपर एक इमर्जिंग ब्रांच है, बहुत ही अच्छा काम है, कोई इसमें अपना खर्चा नहीं होता, मरीज से डायरेक्ट टच होता है और बहुत अच्छा प्रभाव होता है। डॉक्टर सुनील पांडे वाइस चांसलर उत्तराखंड के बहुत अच्छा काम इसमें कर रहे हैं, आपस में कांटेक्ट करें तो और भी साइंस को आगे बढ़ा सकते हैं। मैं समझता हूँ बहुत ज्यादा डिटेल में बोलने की जरूरत नहीं है। वास्तव में आज का जो प्रयास था वुमेन्स डे का, इस वेबिनार को करने का शीतल मैडम का प्रयास सफल हुआ, सभी को जोड़ा। अनेक लोगों की शिकायत रही कि हमको नहीं जोड़ा, हमको नहीं जोड़ा, तो भैया आगे वाले समय में सबको जोड़ लेंगे, लेकिन इतना मैराथन भी करना बहुत ज्यादा आवश्यक नहीं है। थोड़े थोड़े 4-4, 5-5 लोगों को जोड़ो, चाहे हफ्ता मनाओ, वो ज्यादा अच्छा रहेगा, ज्यादा उपयोगी रहेगा, मैं समझता हूँ। लेकिन फिर भी आज का प्रयास तो मैं वंडरफुल, आज का दिन तो बहुत ही बढ़िया गया। इसमें दो सभी लोगों ने अपना, सभी सालू मैडम ने बोला, सब कुछ दे दिया, बेस्ट ऑफ दे हैव गिवन बेस्ट, तो वास्तव में दे हैव गिवन बेस्ट। क्या कमांड सब्जेक्ट के ऊपर, क्या कमांड बोलने के ऊपर सब्जेक्ट, तो बहुत ही मैं प्रभावित हुआ हूँ और बधाई देता हूँ। आने वाले समय में ये लोग सब शल्य शास्त्र को, संज्ञाहरण को, और तुम्हारा शालाक्य को और प्रसूति को, सबको तंत्रों को आगे बढ़ाएंगे, शल्य की विधाओं को, और ऐसी मैं शुभकामनाएं देता हूँ सबको। एक बार पुनः हैप्पी वीमेंस डे सबको करता हूँ। बहुत बहुत धन्यवाद मुझे यहाँ बोलने को मैडम दिया। एक बार और उच्चवार मैडम को भी मैं धन्यवाद देना चाहूंगा कि उन्होंने MJIMS को जोड़ा इससे, और निश्चित ही MJIMS बहुत अच्छा काम कर रहा है इस विषय में। और अब तो शीतल मैडम ने भी ज्वाइन कर लिया है। उच्चवार मैडम बहुत डायनेमिक मैडम है, दोनों मिलकर बहुत आगे बढ़ाएंगे MGIMS को बहुत बहुत धन्यवाद। थैंक यू मैडम, थैंक यू।
थैंक यू सो मच सर, बहुत बहुत धन्यवाद सर। आपने बहुत ही इनकरेजिंग वर्ड्स में सर इसका जो क्रिटिकली एक्लेम करना बोलते हैं जिसको, उस तरह से आपने इस इवेंट को एक अलग ही ऊंचाई पे ले गए हैं आप। और आपके रिमार्क्स हम सबके लिए सर बहुत ही, आपने जो प्रशंसनीय रिमार्क्स दिए हैं हम सबके लिए, वो सबके लिए बहुत एनकरेजिंग है एंड इंस्पायरिंग है सर हमारे लिए। तो थैंक यू सो मच सर फॉर बीइंग विद अस फॉर 2 whole days। और आपने जो टाइम स्पेंड किया है हमारे लिए और हम लोगों को जो एनालाइज किया है, तो वो तो सर शब्दातीत है सर, और आपका सही में आप इंस्पिरेशनल है हमारे लिए। सो थैंक यू सो मच फॉर बीइंग विद अस सर, थैंक यू वेरी मच। और अब मैं श्रृंखला में आगे बढ़ते हुए इसी श्रृंखला में डॉक्टर नवीन जोशी जी को आमंत्रित करना चाहूंगी कि वो इस प्रोग्राम को एक ऑर्गेनाइजिंग प्रेसिडेंट की चेयर से थैंक करें। डॉक्टर नवीन जोशी जी। He was supposed to be in the meeting at this moment, but anyways अभी वो मीटिंग में नहीं है। So Dr. Shrestha madam, Sarita Shrestha ma'am, is she here? Even she is not here. So on behalf of Ayush Darpan Forum, I would like to give the vote of thanks. सर शायद बिजी हो कहीं इस समय, बिकॉज ही इज बहुत बिजी रहते हैं सर, उनके साथ एक्चुअली पैरेलल काफी सारे प्रोग्राम्स चलते रहते हैं। तो आयुष दर्पण फोरम और महात्मा गांधी आयुर्वेद कॉलेज हॉस्पिटल एंड रिसर्च सेंटर के कोलैबोरेटिव वेंचर से जो ये प्रोग्राम ऑर्गेनाइज किया गया, उन सबको रिप्रेजेंट करते हुए मैं डॉक्टर शीतल आसुटकर आप सभी को यहाँ पर बहुत बहुत धन्यवाद देती हूँ। स्पेशली टू माय स्पीकर्स जिन्होंने इतने एफर्ट्स लेते हुए वेरियस टॉपिक्स पे यहाँ पर प्रेजेंटेशन प्रस्तुत किए हैं। मैराथन प्रेजेंटेशंस किए गए कल और आज 2 दिनों में, करीब करीब 24 प्रेजेंटेशंस और 2 कीनोट एड्रेसेस हुए हैं। तो मैं तहे दिल से शुक्रिया अदा करती हूँ डॉक्टर संगीता सालवी मैम एंड डॉक्टर सुनीता सुमन मैम का, कि जिन्होंने अपना समय यहाँ पर हमारे लिए स्पेंड किया और हमें बहुत ही सुंदर हमारे पास जो प्रेजेंटेशंस प्रस्तुत हुए और बहुत ही एक्सीलेंट कीनोट एड्रेसेस हुए हैं। थैंक यू सो मच मैम। मैं उसी श्रृंखला में मैं डॉक्टर सुभाष चंद्र वार्ष्णेय सर का कोटि कोटि प्रणाम करती हूँ सर आपको, और आपका मैं शुक्रिया अदा करती हूँ दिल से कि आप हमारे साथ 2 दिन रहे और आप चेयरपर्सन की उस पर्टिकुलर लेवल से आपने हम लोगों को एक्लेम किया, आपने क्रिटिकली अप्रेज किया सर हमको, और बहुत हौसला अफजाई किया आपने हमारी, तो उसके लिए मैं आपकी बहुत बहुत आभारी हूँ। साथ ही मैं आभार व्यक्त करती हूँ डॉक्टर कामिनी धीमान मैम, डॉक्टर वीना पाटिल, डॉक्टर मीना अलनेवार मैम, डॉक्टर सुनीता सुमन, डॉक्टर श्रीकांत काशीकर सर, डॉक्टर DN पांडे सर, इन सभी विभूतियों का कि जिन्होंने हमारे प्रोग्राम में उपस्थित रह के हम उसको 4 चांद लगा दिए। एंड लास्ट एंड नॉट द लीस्ट माय moderators, both of them, those who have anchored the program very well, Dr. Kiran and Dr. Nirmala, and my postgraduate students, the team was excellent. Dr. Nirmala is in Bhopal, Dr. Kiran is in Pune, and my PG is over here at Wardha MJC, and we work together like a team. And यही तो मजा है टेक्नोलॉजी का, तो हमें उसका फायदा कैसे लेना आता है, इस पे सारे खेल का मजा है। So it was excellent actually. Thank you so much, and thank you so much to all my speakers, especially those who have spent their time in spite of having this much busy OPDs and OTs and the first 2 days of the week, but still they have managed to be in the program and still they have managed to contribute in the program. So thank you so much. Thanks to the audience who has been attending it live on YouTube, and thanks to the audience which is present in the Zoom meeting also. So बहुत सारे लोग जुड़े हुए हैं हमारे साथ, और सभी का मैं धन्यवाद अदा करती हूँ। और उसी के साथ ये विमेंस डे सेलिब्रेशंस के जो प्रोग्राम है उसको मैं यहाँ पर एक इस मोड़ पे आए हैं कि इसको हमने यहाँ पर समाप्त होता है ऐसा घोषित करती हूँ. बट दिस विल नॉट एंड. दिस इज जस्ट pause which we have to take for next year's program to get planned over the 1 year what we will be getting. बहुत सारे लोगों ने एक प्रमोशनल वीडियोस भेजे, हमारे जो फ्रेंड्स है, मेरे जो जूनियर्स है, उन सभी ने, एंड ऑल ऑफ देम हैव एक्सप्रेस्ड देयर ग्रेटिट्यूड एंड एक्सप्रेस्ड देयर विश टू पार्टिसिपेट इन द नेक्स्ट इवेंट. सो आई थिंक दिस इज रियली अ ग्रेट अचीवमेंट फॉर ऑल ऑफ अस कि इस प्रोग्राम का प्रोपेगेशन एक बहुत ही अलग तरीके से होता है हमेशा. तो करीब करीब मेरे 10 to 15 फ्रेंड्स एंड जूनियर्स ने हम लोगों के लिए प्रमोशनल वीडियोस भेजे, जो कि हमने सोशल मीडिया पे अपलोड भी करने की कोशिश की है. एंड ये एक बहुत ही सराहनीय सा एटमॉस्फेयर बन गया है जो कि आगे चलता रहे इसी आशा के साथ, और हम सब एक दूसरे के साथ जुड़े रहे इसी आशा के साथ आज का ये प्रोग्राम यहाँ पर समाप्त होता है, ये मैं घोषित करती हूँ. थैंक यू सो मच.
मैम मैं 1 मिनट बोल सकती हूँ?
Yes ma'am, yes ma'am.
On behalf of all the participants, a very big thank you to you. And congratulations and keep it up. Thank you so much.
Thank you so much, ma'am.
This wouldn't go complete.
Thank you, madam. Thank you, ma'am.
Thank you, Gaurav.
Thank you very much, ma'am.
Thank you. Thanks everyone for those whom I am able to express my gratitude towards, and to all those whom I may have forgot to take names. To all those, thank you so much.
Thank you.